Nafasi hii kwa heshima ningependa kupisha bendi yetu ya polisi iliyoko kwenye msafara wa rais. Watatupa nyimbo mbili mtawalia, wimbo wa kwanza Ndaya na kisha wimbo wa pili Charonyi ni Wasi. Ni bendi ambayo wakati mwingi hutuchezea muziki yenye kulete raha kila wakati wakiwa kwenye msafara wa rais, na leo hii wamejikwatua ili kuweza kutuongoza katika burudani fupi na kisha katika wimbo wa taifa wa Jamhuri ya Kenya na wimbo wa Jumuiya ya Afrika Mashariki. Nikitambua uwepo wa secretary wetu State Functions Bwana Michael Gitonga. Bendi tafadhali.
Tuwapongeze kwa makofi tafadhali Presidential Escort Band wakiendelea kutuletea burudani hapa siku ya leo. Iwe wimbo ambao wamecheza ni Ndaya ambaye tunaendelea kungojea. Mgeni wetu wa heshima ama rasmi Mheshimiwa Rais Daktari William Samoei Ruto tayari amefika, sasa anapitia exhibition booths ili aweze kufika tuendelee na sherehe yetu ama ratiba yetu ya siku ya leo. Kwa hivyo Presidential Escort Band wataendelea kututumbuiza na kutupatia burudani tukiendelea kungojea. Katika ratiba yetu ya siku ya leo hatu expect tutakaa sana, tutarajii tutakaa sana. Tunajua ya kwamba kuna wale ambao watatoa hotuba wachache ili tuweze kuendelea. Kwa hivyo tunatarajia kuwa na siku njema siku ya leo, na najua ya kwamba sote tumekuja tukitarajia mema. Siku yetu ya kuangalia hatua ambazo serikali imechukua kwa upande wa afya. Kwa sasa turudi kwa burudani, na pia tunaona ya kwamba tunaweza tazama kwa runinga kile ambacho kinaendelea katika zile exhibition booth. Tukimwona pale Dr. Mwangangi, CEO wa SHA, akielezea rais na wale wageni ambao wako pamoja kwa yale ambao tayari waziri ama wizara ya afya tayari imeweza kufanya. Kwa hivyo tuendelee bado na burudani, na tukiweza kupata sauti kutoka zile booth tutaweka sauti ili tuweze kufuatilia pamoja. Karibuni.
Now, Your Excellency, we want to move you to this end.
Kwa majina naitwa Margaret Lily. Mwaka jana nilijisikia niko na lump kwa matiti, nikashtuka kwa sababu nikajiambia
and she'll tell us how her journey has been, and she wants to have a conversation with you. They also have requests of you.
I'm very well, thank you. Morning to you. Yeah. Kwa majina naitwa Margaret. Wacha niongee Kiswahili ndio kila mtu asikie. Kwa majina naitwa Margaret Lily. Mwaka jana nilijisikia niko na lump kwa matiti, nikashtuka kwa sababu nikajiambia hizi kansa za matiti zinaanzia na lump, nitaanzaje? I'm just a housewife. So nikakaa 6 months nikichuna majani tu, nikichemsha, nikikula tu hivi nikiona nitapona. Then nikamuongelesha rafiki yangu mmoja anaitwa Mama DLL, akaniambia mbona ujisumbue? Ushasikia kuna kitu inaitwa SHA? Nikamwambia hii SHA hii watu wanasema SHA ifanye kazi. Akaniambia wacha kusikiza stories za watu. Nitakupa 4,000 uende ofisi ya SHA, uende ujiregister, alafu tuone itakusaidia kivipi. Akanipa siku 2, akaniletea 4,000 na M-Pesa, nikaongezea 2,000, nikaenda kwa ofisi ya SHA, nikaenda nikajiregister, na kufika pale niliulizwa tu maswali ya kawaida. Uko na simu gani? Unaishi wapi? Vitu kama hivyo. I think walikuwa wanajaribu kuni evaluate wajue nitalipa ngapi. Nikasemekana naweza lipa 6,000. Nikalipa. Nilivyolipa nikauliza tu saa hiyo hii naweza kuitumia lini? Nikamwambia hata saa hii ukienda hospitali utaitumia. Mimi nikalala, kesho yake nikakimbia hospitali. Kufika hospitali nikaulizwa kitu ya kwanza, uko na SHA? Nikamwambia niko na SHA. Wakaangalia wakasema hii SHA itafanya kazi. Nikaingizwa kwa daktari, daktari akanipima, nikaambiwa nende nifanyiwe skani. Nikasema sasa mimi sina pesa. Sasa hiyo daktari anakuongelesha, unaangalia kwa simu ni contact gani utapigia utafute pesa. Lakini kupelekwa kule scanning, SHA ililipia kila kitu. Nikashtuka kwanza. Unajua mwanzo hii ugonjwa ya kansa inakutia wasiwasi. Hujui utatembea vipi, manake ni ugonjwa, sio ugonjwa ati kesho umepona. Lakini sasa vile nilivyoenda hospitali nilivyolipiwa na SHA, nikaanza kupata nguvu. Nikapigia msichana wangu nikamwambia SHA imenilipia. Akasema mama, ukweli? Mbona mimi nasikia SHA ilipiwa watu? Nikamwambia nimelipiwa, hata nimefanywa scanning na nimeona ndio nifanywe biopsy. Machozi ya furaha ilinitoka. Mtoto wangu akasema nikikuona jioni kwa nyumba nitafurahi ndo nijue ni kweli. Mimi ni mgonjwa kweli. Nimeenda matibabu, nimefanywa hivyo vipimo vyote na SHA ilinilipia. Nikapelekwa chemotherapy. Hata sikukaa, baada ya kuonekana tu sasa ni kansa hii, already daktari akanipeleka kwa chemotherapy. Nikamuuliza chemotherapy itanicost pesa ngapi? Akaniambia wewe usijali. Si uko na SHA na SHA inafanya kazi? SHA itakulipia. Mimi ni mgonjwa wa kweli wa kansa, this is my card. Na hizi ni hizo makaratasi ya SHA walizonilipia. Hizi. Kila session iko na pesa yake. Chemotherapy ilikuwa inalipia around 63,000. Chemotherapy ilikuwa inalipia around 63,000 per session. Na linienda 8 session, sikulipa hata shilingi, zote SHA ilinilipia. Ningeweza kweli mimi? Singeweza. Kutoka chemotherapy almost 11 months kwa sababu nilianza treatment on October last year na sasa ikifika October nitakuwa nimemaliza 1 year. Na session zote after chemotherapy nikapelekwa surgery, nikauliza surgeon itanicost pesa ngapi? Akaniambia it's going to cost you 182,200. Nikamwambia pesa natoa wapi? Akasema mama, kuna SHA. Nimelipiwa na SHA. Kwa sababu kwanza ilikuwa ni 550,000, alafu tukaja tukapewa top up ikafika 800. Ikafika 800. Yes. For 550 to 800. Ai, mimi niseme nini sasa? Chemotherapy imenitumia. Elfu sita tu. Hapana. Hiyo 6,000 tu niliolipa inanilipia paka leo. 8 sessions 663,000 multiply. Alafu surgery 882,200 plus niko na shindano Herceptin naenda 45. They're supposed to be 18 cycles. So far nimepata 11. Kadi ndio hii. I mean nimepata 10 on 24th. Herceptin. Yeah, on 24th naenda ya 11th. Sijatumia hata shilingi. Mimi nashangaa mtu akisema SHA ifanye na mimi nimelipiwa hiyo yote.
Wengi wao ni watu wanaongea katika mikutano ya siasa kwa sababu wanafanya siasa, lakini watu ambao kama wewe ambao umeenda hospitali umetibiwa, experience yenu ni tofauti kabisa. Hivyo msiwadhani wale wanaongea mambo ya siasa, lakini hapa tunaongea mambo ya maisha, mambo ya afya, kwa sababu wewe pesa zako sisi wote tunalipa, inasaidia sasa, kwa sababu hakuna vile shilingi 6,000 inaweza kuwa shilingi 11,800 ni ile pooling, ndio sababu ya sisi wote kusemekana tuwe ndani ya SHA. Ndio wewe ukiwa mgonjwa tukusaidie, mwingine akiwa mgonjwa afaidike, mwingine, kwa sababu sisi wote hatuwezi kuwa wagonjwa siku moja. Tuweze kusaidia, na hivyo ndivyo dunia nzima inavyo.
Tuendelea, if we can have the feed from the exhibition booth so that we are able to follow the proceedings.
Then we said, no, shrink and grow. Keep stocks for 3 months and then grow. So that magically brought our order fill rate very high. So, Your Excellency, we have very serious visibility. We are not working in the darkness, end-to-end supply chain visibility. So as an example, we can at real time, this is a dashboard, see what our order fill rate is, how many orders we have, like the 984 orders, what is the value, the monetary value, over 500 million for those orders. We're serving about 855 facilities for that order, and in about 35 counties. And then it also tells us how much we have been able to push. The green one shows us we have pushed over 500 million to those facilities. Yes, Your Excellency. Help us to be traceable, to be auditable, to be visible. So actually, KEMSA, I can say, is fully paperless. Yeah, at the moment. So the next thing is now to hook into DHA so that we have one national LMIS for the country. So digitization has helped us. Dennis here is able to drill down to the exact facilities. The ones I've said 855. agency that can do doorstep delivery, what we call doorstep. We don't deliver at the county or sub-county. The governors here know we deliver to the facility, to the we changed for some time now. That has been the model. So we don't deposit anything at the county or sub-county. We deliver at the doorstep of the health facility. The time frame. Yes, sir. So time around. Yeah, order turnaround time is the other thing that we measure, and we've also revolutionized that. By the time you order and the time it takes for the medicines or products to be at your doorstep, we have changed that. We have asked ourselves, when we came, warehouse was working like a normal office, 8 to 5. We said, is this not a normal office? Can we do a shift system from 7 a.m. to 7 p.m. with the same staff? So some are reporting at 7 and leaving at 4. Some are reporting at 10 and leaving at 7. So that actually improved our efficiency, and our order turnaround time has moved from 24 days to less than 2 weeks for the rural health facilities, from 20 days for hospitals to less than 10 days for hospitals now. Thank you, sir. Thank you, sir.
We are supplying ultrasound, where we are able to do obstetric, abdominal, pelvic, and all body scans. We've supplied 71 equipments, Your Excellency. This is fee for service. So the cost of every equipment is about 3 million, the whole package. Additionally, Your Excellency, we are providing consumables for the entire contract period, and we're also giving refresher training, both clinical and technical, to our service health providers. Now, what we've also done, maintenance is on us, Your Excellency. Consumables, we provide maintenance, and then we also do training, both clinical and technical. You only pay for use, fee for service. No, you don't wait. We have an uptime of 98%, Your Excellency. So what we've also done to do that, if it is not working, we have no money. So it is in our best interest and the government's interest that it works. Additionally, Your Excellency, we've also been able to integrate this equipment through the Digital Health Authority with SHA. So now there is no fraud. If a SHA-approved patient comes here, in the work list, we will get the names of the patient, a scan will be done, and a report is sent back to SHA through DHA, confirming that the equipment has offered service and the service that has been offered. Yes.
Already supplied.
Your Excellency, this to offer 217,000 plus scans since inception. Yes, across the country.
And the hospitals are those ones?
Yes, those ones across the country.
How many counties?
31 counties. Yes, 31 counties.
Very good. Hello, how are you?
Hi, Your Excellency, karibu. Salama. Safi kabisa. Welcome to NESP. I think we have Donald who will take you through the MRI.
Welcome, Your Excellency. I think somebody take us through all of them in one go.
Okay. So we have MRI.
In how many facilities? We have done 2 facilities now. 2 facilities.
2 facilities, yeah.
MRI. And linear at Kenyatta. What about the other?
We have the regular laboratory.
Yeah, laboratory.
Yes, laboratory.
How many facilities?
609 equipments deployed.
Yes.
And you can see the live transmission of all the facilities. 609, yes.
This is what lab equipment?
Lab equipments, yes.
What is the lab equipment? Which are the lab equipment?
We have the hematology machine, we have the biochemistry machine, we have got amino analyzer, mix of all the lab equipment in different facilities.
You also you provide the equipment?
We provide the equipment, we provide the reagents, we provide the consumables.
The consumables?
Yes. And also the training and the servicing and maintenance for the next 7 years.
Yes.
Yes.
So
then we also have the theater.
Yeah.
Theater also the same. We deployed 96 facilities for theater. And currently, we're also deploying more, up to 150 by end of this month. The same arrangements.
What are the equipments for the?
We have the tables, 9 primary equipments for theater, fully fledged theaters. Yes, theater equipment. On 98 facilities, but by end of this month, we will be at 150 facilities. Yes, the same arrangement again, all the services.
All these are the facilities that are.
All this, what we have done is we have integrated all the data, and we created the laboratory information system. So what you can see here is a live test that is being done by the facilities now.
Why is it leaking?
I really think it's because of the power. Just check them.
How many?
Kenyatta, we have Moi 15. Moi teaching, we have done 9. Jaramogi, we have done 9. And
One theater, sample is like how much?
each
What, 5?
the for one theater is around 15 million. Yeah, 15 million. Yes, 15 to 20 million because the highest is 20 million. Yes. 8 theaters for Margaret.
So 8 theaters, you do 10.
That's 150. Yes. Yes.
Your Excellency,
And
I thought you should know that lady for cancer. It's in her family. Her sister, as we speak right now, is a beneficiary of SHA at Coast General. This is us. How are you?
okay.
39 cities country.
Yes.
In different facilities.
In different facilities.
What is the experience?
I think so far the experience we saw is most of the patients who are coming for these services to either Kenyatta have now gone back. Yes, have now gone back. So it has reduced the referrals.
The game changer here is that it's a 100 slice, so they can do more complex procedures. Dialysis.
Yes, how are you? Yes.
So here we have dialysis. So in short, dialysis does the work of a failed kidney. By cleaning the fluid and waste from the blood hours at a time and a couple of times a week. So I'll jump to the numbers. So at the moment we have 24 machines installed. We've scheduled an additional 28 machines to be installed, including an installation being done this week, and we're projected to be at 100 machines by the end of the year. Additionally, we've digitized these machines that allows the Ministry of Health to view this utilization in real time, verifying the services they're paying for. Additionally, also provides analytics to help make better informed decisions. Okay, we will. Thank you.
Morning, Excellency.
Good morning, how are you?
Thank you, sir. This is our awareness stand where you are championing, ensuring that no mother in Kenya dies while giving life and no newborn dies from an preventable death. So these are my team members from maternal health, newborn, and also we have an innovation for our youth to access health through AI innovations done by Kenyans. So I'll allow, this is our POCUS. POCUS is a point of care ultrasound. This is very handy and it's using AI system. 635. This year we will do similar numbers at 5 facilities. Yes.
Across 21
counties. This year we'll go to 26 counties.
So these are the people who are dealing with the
Your Excellency, it's okay. Yeah, so this is the Kenya National Public Health Institute, established by the government as the health security agency, guiding matters of protecting the public against events of public health, effects of public health threats, sorry. So here we are going to demonstrate the outbreaks that we have been trying to respond to. In this current year, we have been able to respond to rabies, we have responded to chikungunya, we have responded to cholera and anthrax. Currently, we are responding to the dengue fever, which is in Garissa and Wajir. We already had 1,678 cases. We have also been responding to Mpox, 1,261 cases already, and measles outbreak that is currently ongoing at 463. As you're aware, Your Excellency, we have Ebola outbreak in DRC, and recently Uganda and France also reported cases. Two, yes. So there were 12, but yeah, it's done now. So now, yeah, so Kenya has not reported any case, but we have already tested around 196 samples that have come to our lab. Yeah, but all of them are turned negative. Yes, people traveling, others who have come to the hospital and have symptoms of Ebola, but presented to the health facility. And in our history taking, we demonstrated that they had either traveled to Uganda or DRC. We have already screened 420,000 cases and 20,000 people at points of entry. Yeah. All right.
Salama sana, Your Excellency. We're going to show you what we have done in digitization. Remember, Your Excellency, one of the main problems we had on UHC is accessibility. And one of the first issues that was there is our public hospitals did not have the digital systems and digital infrastructure to be able to provide services. That's why even under NHIF, they used to get a mere 34% of the money. And therefore, Your Excellency, the first thing we did is provide these tablets to all our public facilities, 6,700 of them. This tablet, Your Excellency, comes with power bank, and Your Excellency, it comes with paid-up internet of 10 years. And 10 years, Your Excellency, so that our governors and our public hospitals do not need to pay for any of internet connectivity in that area, Your Excellency. For big hospitals of level 4 to 5 and 6, because they take a lot of data, we're giving them these computers, Your Excellency, 4,500 of them. Yes. There are 6,473 out of 6,700. Few of them, others are still ongoing, Your Excellency. And you can see every county, Your Excellency. In every county, you have each and every how much we have distributed for them. For each facility and every. Yes, Your Excellency. And you can even see, Your Excellency, you can go as it is now. We are able to see how many are live now, because we also monitor. We do not allow anybody to use this device for any other purpose apart from for health. Your Excellency, the second, as we go that, you can move to the second one. So this is how the coverage look like, and that is how Safaricom is giving us 2G or 3G or 4G in every of those areas. Your Excellency, the second area was the issue of data centers. Many of our public facilities used to have small data centers. For the first time, Kenya became the first country to have a sovereign cloud. This is where we centrally store the data for all our facilities and all health. And that to be able to make decisions using data.
Your Excellency, welcome. You promised, we delivered. And with this, Your Excellency, 95% of our facilities in Kenya are digitalized, all the way from level 2 to level 6. And you can see, for example, we have the map of Kenya here. This is how the distribution is of all the facilities in the counties. So we have digitalized all the counties in 47 counties. Your Excellency, Kenyatta National Hospital is the first facility of its kind in Africa to be fully automated. actually paperless, because now even from this week, they are transmitting share claims through the electronic way. So we are proud to see, and this is real live dashboard, Your Excellence, whereby we are seeing the number of patients who are coming, who are admitted on real-time basis, Your Excellence. Your Excellence, also, we can see what is happening in real-time basis at the facilities. The governors here, they can even monitor the health workers, wherever they are, on real-time basis, clients who are being seen in every facility on a daily basis. So we promised, you promised, and now we have delivered. You can see the number of clients who have been seen through the system. Over close to 30 million clients have been seen through this. People have been seen through our electronic systems, HMIS, Your Excellence. Yes, and we have actually insurance. And you can see in a month, Your Excellence, we are having more than 4 million clients coming, our patients, to be seen through the electronic platform. So you promised, and now you can see we have delivered as a country. Thank you.
Thank you very much, Momo.
Your Excellency here. Yes. Sorry. So Your Excellency, the third area is about logistics. How do we ensure our drugs are safe? How do we ensure that we're able to track these drugs? But Dr. Wamisha will take you through, Your Excellency.
So good morning, Your Excellency. This is the new kid on the block in Digital Health Agency. So the starting point when digitalizing health products and technology is to have like a Bible, a dictionary on how we identify health products across the health sector. So what we have is a product catalog, the national product catalog, and that's what you're looking at. Everyone who's prescribing, dispensing, bringing in medicines must read from this product catalog. So for example, like this medicine is particularly there. Yes.
Benefit package.
Exactly. So from there, we then move to health facilities need to be consuming this particular product catalog, and we are doing that through our Taifa Care Hospital Management Information System. The biggest question, sorry, yeah. Yes.
What is the connection with KEMSA?
Exactly. I want to now take us there. So the hospital needs to order medicines from KEMSA. So it's, and those medicines, it needs to first identify what is in the store. So the system has a pharmacy and stores module. So the pharmacist is able to see, this is what I have in store. Then they are also able to now requisition to KEMSA through what we are calling the National Logistic Management Information System. And you can...
That is housed in DHA.
Yes, housed in DHA. So let me take you to now the NLMIS. This is a game changer, Your Excellency. Here we are going to onboard manufacturers, distributors. We've already onboarded KEMSA. KEMSA, we can see we have 10,609 products. This is real time. We can also see the prices. Today, when a pharmacist wants to buy medicines, they have to call somebody, ask what is happening. So on the NLMIS, we have the marketplace. This is going to be a marketplace. So once the order comes in, then the facility is then able to have a Glovo-like experience. This has not been there. The facility in charge wonders, is the truck arriving? When are the medicines coming? But now with this, they are able to tell where their order is. All this is happening through the National Logistic Management Information System and their audit logs. The last bit that we are working on with PPB. Yes, we've been working with them. They have onboarded, sir.
Pay some attention.
Okay. Okay, the last bit that we are working on with PPB is to uniquely identify the health products. Your Excellency, I have two medicines in front of you. One has what we call the global standard, what is used to uniquely identify the product, and that is this. It's a data matrix that has got lots of numbers. Then this one doesn't have. Okay, it just has this barcode. We want all medicines coming to Kenya to have this, and we are working with PPB to ensure that this happens. We are currently in transition period, so we are starting with the ones that already have, but by 1st January, anything else coming in here must have this. Then with this, yeah, yes, exactly, 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 exactly. And then, Your Excellency, the connection with the patient. Allow me to show you that. The last one is on Afya Yangu. Because the patient must be in the story. So on Afya Yangu, this is an app that the patient has in their hand on a phone. And this is actually me who visited a health facility a few days back. I had a headache, I was feeling unwell. I went to a senior health center, and this excited me, Your Excellency, because a few days later, when I went to my Afya Yangu, I actually saw the medicines that I was given.
Sababu tunaona ya kwamba mengi yamefanywa, yametendwa, na tunajua ya kwamba rais sasa anakaribia kumalizia ili aweze kuja tuweze kuendelea na programu yetu hapa ama ratiba yetu rasmi. Kwa sasa nitakaribisha Presidential Escort Band waweze kutupatia burudani moja mbili tukiendelea kungoja. Karibuni. Makofi kidogo ya kuwapongeza tafadhali. Presidential Escort Band, definitely arguably one of the best bands that we have in this country, able to do very diverse and different genres of music, both local and international. Na ukisikiza vizuri utasikia nyimbo ambazo umezisikia mara nyingi zilizopendwa, na pia zingine ambazo sio za zamani, za kale sana. Kwa hivyo tunaendelea kungojea, na nimeelezewa ya kwamba rais ako karibu kumalizia the tour of the exhibition, so he will be joining us shortly as we get ready to start the plenary session. For now, we'll continue with more music from the Presidential Escort Band. Anybody who can identify which song that was? Ama mko mnasikiza? Naona CS Rebecca ana dance kidogo, ni kama anaijua kutoka kuota zingine. It's a song done by a Tanzanian artist known as Mario. Anybody know his real name? Mario is the singing name. Jina yake ukweli tunajua. Leo tunafanya education, not just the health education, lakini pia najua ya kwamba when the sun goes down, some of us love our entertainment. And now that CS Rebecca is here, I know she can give us a few places where we can tour and enjoy ourselves. But as we continue waiting, we'll have more music. Oh, the real name of Mario is actually Omari. Sally Omari or something like that, and Tanzanian artist. But we'll continue listening to more entertainment from the Presidential Escort Band as we continue waiting patiently for us to begin our session. I'm sure His Excellency must, as we have seen from the interaction that he's having with the various stakeholders in the health sector, he is definitely checking and making sure that the milestones that have been set have been achieved. So we'll continue with more entertainment. Tutaendelea na burudani. Kwa hivyo Presidential Escort Band, uwanja ni wenu. Sijui mbona upande wao tupigi makofi. Tuwapigie makofi tafadhali. Najua hapa PS Mangeni ndiye ameongoza gang ya mapeka na nimesikia hiyo ilikuwa wimbo ya kutoka Western. Sijui warudie tusimame tuimbe kidogo. Naona tumeketi for long. Band nita request tuimbe hiyo tena hiyo it's a gospel genre of music and it has given us some good. Tusimame tafadhali. Just to stand up, it's also a health break. We've sat longer than we expected, so tufanye tu hiyo tena kidogo, na ule anajua wimbo tunaweza tukaimba mahali tulipo, tutemeze mabega kidogo ili tuweze kujitayarisha na tukue tuko warm kabla rais afike. Bendi, twende kazi na tuongeze volume kidogo ili tuweze kucheza tukifurahia sote. Karibuni. Na kama unajua uimbe mlilo wanje Yesu mlilo wanje, mlilo wanje Yesu mlilo, hey! Yesu mlilo wanje, Yesu mwana wa Nyasaye. Mlilo wanje ndio hiyo, Yesu mwana wa Nyasaye. Aya, wapi shangwe na vigelegele? Tuwapigie makofi. Tuendelee au tuendelee? Badala ya kuketi, si tutaketi for some time. Tuendelee au tuendelee? Band, nataka sasa tuende upande wa Nyanza. Tukikuja hivi, si tuende Nyanza ama tuende pande gani? Naona Honorable Attorney General ako tayari kabisa. Hata sikujua akitoka kotini, kumbe anakuanga na mapeka na peleka mabega kabisa. Bendi, tuende kazi. Na najua hiyo tunajua kabisa ni waranono. Ni waranono chwaler, ni waranono taya. Ni waranono chwaler, ni waranono taya. Taya ni waranono wagwenyi wanilambo, ni waranono. Ni waranono chwaler, ni waranono taya. Saa zingine unajua tu unajiachilia. Taya ni waranono chwaler, ni waranono taya, ni waranono chwaler. Ewanwatio nengima. Ewanwatio. Ewanwatio nengima. Naomba sote tusimame. Let us all be upstanding. Tuwapigie makofi basi, tukijua ya kwamba sasa Mheshimiwa Rais amekaribia kufika. Kwa hivyo tubaki tumesimama, na itakuwa mzuri pia akiingia tumkaribishe kwa makofi, kwa sababu leo ni siku ambaye ni ya furaha, sote tukiangalia hatua ambazo kama nchi tumechukua kwa upande wa afya. Kwa hivyo tujitayarishe kumkaribisha kwa makofi, kwa sababu ni siku njema. Bendi, tuendelee tukingojea. Aigua mote tondo ali na mwana, tiga komote mohikie moikarani, wahota kwirehera munyaka. Naona CS Ali sio anajua kabisa. Huyu ni mtu wa Mugithi. Sasa turudi official. Tujikaze kidogo, turudi official. Band. His Excellency the President. Tumkaribishe kwa makofi tafadhali. While we remain standing, we'll start with the two anthems, starting with the Kenyan national anthem, followed by the East African anthem. The anthems. While we remain standing, Your Excellency, allow me to invite Dr. Salim Hussein and Mr. Benjamin Murkomen to lead us in a short prayer for us to begin our session.
Tuombe. Bismillahi rahmani rahim. Alhamdulillahi rabbil alamin. Ar-Rahmani rahim. Maliki yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina as-sirata al-mustaqim. Sirata alladhina an'amta alayhim. Ghayri al-maghdubi alayhim waladdallin. Amin. Ewe Mwenyezi Mungu, mlinde rais wetu, mbariki, uongoze viongozi wetu ili tupate baraka na fanaka. Ewe Mwenyezi Mungu, uliongoze taifa hili, ulipe taifa ambalo litakuwa na afya, lisilo na majanga wala balaa. Mwenyezi Mungu, uongoze taasisi zetu za kiserikali ili watuongoze tupate afya na maendeleo. Tunakuomba uweze kubariki huu mkutano wetu wa kilele wa afya ili watu wetu waweze kupata afya na watu wote ambao wako nchini Kenya wapate afya. Tunaomba yote katika jina lako ewe Mwenyezi Mungu. Amen.
Let's continue praying. Heavenly Father, we come before you today with hearts of gratitude, acknowledging that all authority comes from you. We thank you for the gift of life, for bringing us together for the Kenya Health Summit. We lift up our President, Dr. William Samoei Ruto, all the leaders of our country and the citizens. Grant our leaders wisdom, protection, strength, and understanding as they guide us and our nation towards universal health coverage. Oh Lord, guide us, guide our discussions and decisions with wisdom, unity, and compassion. May this health summit be a turning point towards stronger health systems, greater preparedness, quality, accessible, and equitable health care for all Kenyans. May this summit yield meaningful and lasting solutions and strengthen our health system for the benefit of every Kenyan. We commit this summit into your hands. Lead us now guide us, and bless our efforts. For in Jesus' name I pray with thanksgiving. Amen.
Let us kindly take our seats. Your Excellency, Dr. William Samoei Ruto, President and Commander-in-Chief of the Kenya Defense Forces, Your Excellency, Professor Abraham Kithure Kindiki, Deputy President of the Republic of Kenya, Your Excellency, Dr. Musalia Mudavadi, the Prime Cabinet Secretary, Honorable Moses Wetangula, the Speaker of the National Assembly, Mr. Gary Cornell, Resident Coordinator, United Nations, all cabinet secretaries present and principal secretaries present. In this case, we have Honorable Aden Duale, the Minister for the Cabinet Secretary for Health, Honorable Ahmed Abdullahi, COG Chair and Governor, Wajir County, Ms. Neema Kimambo, WHO Country Representative, Host Governor, Honorable Johnson Sakaja, all governors present, all members of parliament present, development partners, stakeholders, and all in the health ecosystem, distinguished ladies and gentlemen. Your Excellency, with your permission, allow me to invite Dr. Ouma Oluga, PS State Department for Medical Services, who will give a short welcoming remarks before inviting PS Modoni to then guide us with the program. Tupigie makofi tafadhali akija, PS Dr. Ouma Oluga.
Your Excellency, the President of the Republic of Kenya, Dr. William Samoei Ruto, Your Excellency, the Deputy President, Professor Kithure Kindiki, Your Excellency, the Prime Cabinet Secretary, Honorable Musalia Mudavadi, Honorable Cabinet Secretary led by Cabinet Secretary for Health and all Cabinet Secretaries, allow me to ride on the protocols established by the State Function Secretary. Your Excellency, mine is just to set the scene of why we are here. Health at its best is a promise. It's a promise to every citizen, a promise that we gave ourselves in the Constitution. It's a promise that we've talked about for more than 60 years. And it's a promise that year after year, we want to give ourselves as a service. But it's at its best, it's a promise that you don't know when the calamity will hit. Most of us seated here or outside may be healthy. You don't know when the health need will come. Under the leadership of Your Excellency, the President, you have established reforms to turn that promise into a service and to turn that service to be offered in a manner that does not ruin families financially and in a manner that does not facilitate families or loved ones to die from causes that we can prevent. Your Excellency, that is the reason why you have directed that we come together as a nation so that we can unveil those reforms that you have established, from the policies to the legislative framework, to the implementation agencies, and to the deliveries. Your Excellencies, you've kept telling us that health should not be a privilege. It should be a right. It's a right that has been enshrined in the Constitution, Article 43, Part 2 of the Constitution. Your Excellency, it's now my opportunity to welcome everyone to this discussion as we unveil the reforms that have been delivered. And those reforms that have been delivered so that health is given as a right, so that we turn the promise into a service. Your Excellency, with those very few remarks, I would like to invite my colleague, Principal Secretary Mary Mudhoni, to take over the program. And all of us feel much welcome to the Kenya Health Summit.
Thank you very much na karibuni sana. Asante sana PS Oluga. Your Excellency,
the President of the Republic of Kenya, global partnerships and multilateral cooperation are the bedrock and the resilient health systems. Together with our international allies, we are translating health security policies into actionable realities that probe communities across borders. At this juncture, Your Excellency, allow me to invite Gary Connell, the resident coordinator of the United Nations. A round of applause for Gary.
Your Excellency, Dr. William Samoei Ruto, President of the Republic of Kenya, Your Excellency, the Deputy President, the Prime Cabinet Secretary, the Honorable Speakers of the Senate and the National Assembly, Cabinet Secretary for Health, Chairperson of the Council of Governors, Excellencies, Governors, Honorable Members, distinguished delegates, and above all, the health workers and community representatives in this hall today. Good morning, and what an inspiring morning it has been already. I am honored to speak on behalf of Mrs. Zainab Hawa Bangura, Director General of the United Nations Office in Nairobi, who conveys her warm greetings to this summit, and to address you as Resident Coordinator on behalf of the United Nations family in Kenya. Thank you for convening the whole health system in one room. The national government and the counties, parliament, health workers, communities, faith-based and private institutions, academia, and partners. No single institution can deliver health. And a summit that begins from that truth, in my view, begins extremely well. The theme you have chosen, reforms delivered, health as a right, sets a demanding standard, and I believe the right one. It builds on the premise that a right is not measured in the law that proclaims it. It is measured in the life of the person who actually claims it. It also establishes that a reform is delivered when a mother in any county reaches safe and respectful care in time, when a community health promoter can complete a referral, when a clinician finds the medicine that was prescribed, and when a family seeks treatment without fear that illness will push them into poverty. As we have already seen this morning, Kenya has built a serious foundation on that standards. New legislation on social health insurance, primary health care, digital health and facility improvement financing, the Social Health Authority, primary care networks, and a strengthened community health workforce, and sustained attention to health workers, health products, local manufacturing, and public health security. This is important reform architecture and a clear national direction, progress on which Kenya can and will continue to build. Now, this chapter is opening new and expanded implementation, carrying these reforms with equity and quality into all 47 counties and every community. That will ask, in my view, 4 things to move together. Financing that reaches the point of care and protects households, a workforce that is supported and fairly distributed, reliable essential medicines and technologies, and data that tells leaders who is being left behind. And this morning, again, we saw incredible, innovative work around that. It will ask both levels of government to move as one system, and it will ask all of us to protect essential services as external financing change. The community health promoter kits to be launched this morning carry that ambition in the doorstep of the household, where a right begins to be felt. For our part, the United Nations stands ready to align its collective offer behind Kenya's institutions, not to substitute for them, but to strengthen their ability to deliver for every Kenyan. Evidence and standards, technical expertise, support to national and county systems, to primary health care and health security, and to financing analyses through this transition. One United Nations system team behind a national agenda. We warmly welcome the summit communique and the joint UHC acceleration plan to be adopted here. Our shared hope is that they emerge focused, sequenced, and time-bound, clear about responsibilities, that they are well-designed. They deliver because people, and that's what we're seeing, leaders, health workers, communities, keep faith in one another. Kenya has those people in this hall and in every county. A right written is a promise. A right delivered is a country keeping its word. Mkutano huu na usiahidi Kenya kutimiza ahadi yake kwa kila Mkenya. Asanteni sana. Thank you.
Thank you very much. Your Excellency, the battle of universal health coverage is won at the grassroots. And strong intergovernmental coordination ensures that our nation health strategies translate into tangible and life-saving primary healthcare services. At this juncture, Excellency Governor Sakaja, utukaribishe, and then you invite the chair of the council.
Your Excellency, the President of the Republic of Kenya, Deputy President, allow me to acknowledge the protocols that we've established, ministers, colleagues, governors, and development partners, and everybody who is here. Mine is very simple. So welcome you to what I believe is one of the most consequential summits that have been held in this country, the Health Summit. Karibuni, Nairobi. Your Excellency, we have seen a true transformation in the health sector. And I can say it with authority as a governor. In many aspects, over the next 2 days, we'll have opportunities to go into the details of this transformation from our primary care networks, where we have, CHPs. In Nairobi, we have 7,820, covering 780,000 households, to the provision of essential services, Your Excellency, reduction of maternal mortality. Hospitals like Pumwani, which would be on the news every day for the wrong reason, have now 0% maternal mortality out of 16,500 deliveries. Your Excellency, we've seen hospitals like Riruta doing 100 deliveries in a month now. New maternity services in Kayole 2, in Mathare North, across the city. The story of the health transformation is something to talk about. We have facilities that would get 100,000 shillings in 2 years. In a year, getting 4 million shillings a month, allowing them to invest in healthcare and to invest in serving our people. Your Excellency, allow me to conclude by saying, because we'll get into all these details, today it was really just to welcome us all. Our constitution has been hailed as being one of the most progressive on the continent. It has mainly been hailed as being progressive because of the kind of rights. The first generation rights, Your Excellency, are civil liberties, where government is asked to step back to allow people to have the right to, do a number of things. But the second generation rights are what we call positive obligations. Positive obligations require government to actually do something. When people talk about constitutionalism in this country, constitutionalism is not just about maandamano or making noise. Constitutionalism is about fulfilling the constitution. The right to health would not fulfill itself. It has to be designed. It has to be planned. It has to be thought out. There has to be legislation. The right to housing will not deliver itself. It has to be planned for. And Your Excellency, I can say, and I dare say, if there has been a leader who has fulfilled the constitution of the Republic of Kenya, it is William Samoei Ruto, by these actions that you've taken. So people should not romanticize and preach on pulpits about Katiba. This is what Katiba is. Giving that right to every Kenyan, that health is no longer a privilege for the few. It is not a privilege for those who have money. That just because one person gets unwell, families have to sell their livestock, to sell their investments. What you're doing, Your Excellency, I believe this will be one of your most enduring legacies, the transformation of healthcare in our country. And I think our president deserves applause for what he's been able to do. Your Excellency, we are proud in Nairobi, in SHA. Mheshimiwa Moses Kuria was giving me an analogy because of the numbers we have. The most tech-savvy country in the world is Estonia, where we go to benchmark. The people registered in Nairobi and Asha are 2 times the population of the whole of Estonia. More than 3 million people registered and more than 1 million actively paying every month. And through the DHA dashboard, I can see who is self-employed, who is employed, and how they're doing. So we really thank you and want to really congratulate Mheshimiwa Duale. You have really led the way in healthcare. Your PSs, Oluga, who we are very proud of as Nairobi, and PS Mary Muthoni. Allow me to also salute the thousands of community health promoters across the country who are bringing healthcare to the people. Before, we used to tell the people to go to hospital. These days with the CHPs, the hospital is going to the people. And that has reduced greatly the cost of health service delivery in this country. I'm sure that investment can be quantified by our minister and by the team here. Your Excellency, allow me at this juncture to invite the chairman of the Council of Governors to also come make his remarks and introduce the governors, the many governors who are here. Your Excellency, we have members of parliament, we have senators I can see, we have members of the National Assembly. I hope at some point they'll also get full recognition and introduction by the minister as he comes. Tupigie chairman wetu makofi tafadhali.
Your Excellency, Dr. William Samoei Ruto, CGH, the President of the Republic of Kenya and Commander-in-Chief of the Defense Forces, Your Excellency, Honorable Professor Kindiki Kithure, Deputy President of the Republic of Kenya, Your Excellency, Dr. Moses, Your Excellency, Dr. Musalia Mudavadi, Cabinet Secretary, Prime Cabinet Secretary, and Cabinet Secretary for Foreign Affairs, Your Excellency Dr. Moses Wetangula, Speaker of the National Assembly, All Excellency Governors, Cabinet Secretaries, PSs, Members of Parliament, Development Partners, ladies and gentlemen. Your Excellency, it's a great honor to join you at the Kenya Health Summit 2026 on behalf of the Council of Governors and the 47 county governments. I wish to appreciate the Ministry of Health for convening this important summit and for the continued engagement with county governments in advancing the health agenda of our country. The theme of the summit, Reform Delivered, Health as a Right, speaks directly to the responsibility we carry as leaders. Health is not simply a sector of government, it is a constitutional right and a fundamental determinant of social and economic well-being of our people. Your Excellency, we meet here more than 16 years since the promulgation of the Constitution of Kenya 2010, which fundamentally transformed our system of governance. Devolution has evolved from a constitutional aspiration into one of Kenya's most consequential governance reforms. Today, Your Excellency, our emphasis is that we can do so much for Kenyans in the health sector through coordinated intergovernmental implementation, functional service delivery, and measurable patient outcomes. And I want to confirm on behalf of the COG that we have actually achieved so much in the space of healthcare. We have achieved tremendous results over the past 4 years through your leadership, Your Excellency, and through the bottom-up economic transformation agenda, BETTER, which prioritized universal health coverage for all Kenyans. I wish to highlight, but just a few areas that demonstrate the progress we have made and equally the work that remains before us. In primary healthcare, over 107,800 community health promoters, CHPs, were deployed under a 50-50 shared financing model between the national and county governments. This has expanded health service availability at the primary level, primary care networks, PCNs, have increased from 89 to 277. On health financing, Your Excellency, since the inception of the Social Health Authority, counties have cumulatively received 46 billion shillings, out of which 31.4 billion has been paid to hospitals through the Social Health Insurance Fund, SHIF, and 14.2 billion has been reimbursed to primary health care facilities. 98% of public facilities have been onboarded on the Social Health Authority share. Through collaboration between the two levels of government, 32.4 million people have been registered under the Social Health Insurance Fund, representing a significant increase from the 7 million people previously registered under NHIF. Counties have also strengthened emergency response with 304 of our ambulances out of the 506 that we run currently already integrated into the National Ambulance Dispatch System, improving referral linkages and timely response to patients requiring urgent and specialized care. Your Excellency, through your initiative under the National Equipment Service Program, NESP, the county governments have now specialized equipment at all levels. This has gone a long way in improving the capacity of counties to handle critical patients and other access to specialized care. We now have MRIs, ultrasounds, blood equipment, blood chemistry equipment, you name it, in the most peripheral of places, Your Excellency. Through the UHC reforms and digitization, the Digital Health Authority has been able to distribute 42,300 digital devices across level 2 to level 5 facilities, processing SHA claims in all 47 counties. These are but a few areas that the reforms in the healthcare sector have greatly improved. Your Excellency, this summit is about consolidating gains, celebrating what we have achieved, taking stock, and charting out the way forward on what else needs to be done. We acknowledge certain challenges, especially in workforce gaps and industrial relations, and together we will work to solve those. Your Excellency, as the Council of Governors and the 47 county governments, we reaffirm our commitment to working with the national government, development partners and the private sector, civil society, health workers and communities to consolidate the gains thus far and to address the gaps that remain, as I said. Let this summit mark a renewed phase of cooperative governance, shared accountability, and accelerated implementation. Let's build on what has worked, confront what has not, scale innovation emerging from both the national and counties, and ensure that our reforms are felt where it matters, as it's already happening. Together, let's deliver a resilient, equitable, responsive, people-centered health system where quality healthcare is not a privilege but a right for every Kenyan in every county and at every level of care. Your Excellency, I want to conclude by observing that I have had politicians out there saying that the first thing they will do if they get into office, is to scrap SHA. Your Excellency, actually one politician said, on day one, I'll scrap SHA. To replace with what? Your Excellency, your administration is doing its best to fix everything. I think what we have failed to fix as a country is the toxicity of our politics. I want to confirm that hospitals in the most peripheral of places today receive funding directly from SHA. And in many cases, and I've said this before, the challenge we have as governors is to control what they do with that money so that they're not using it to just do more pavements and more renovations, but use it to things that can actually help patient care. This would not have been achievable without SHA, Your Excellency, and without all the policy changes. Your administration has thought through everything from financing to policies to digitization. And as a council, we appreciate the partnership that we have. Your Excellency, let me just take a minute to introduce the governors who are here. Excellency governors, you may just stand where you are. I hope I can see you. Thank you very much. From the very end there, we have Professor Barchok, Governor Bomet. We have Governor Gladys Wanga, Governor Homa Bay, Gideon Mungaro, Excellency, Governor of Kilifi, Fatuma Achani, Governor of Kwale, Governor, I call him Kipiego Arabsang, Governor of Nandi. We have Governor Simba Arati. We have our Chair of Health, Governor Abdul Samad Sharif Nasir. And we have Governor Wesley Rotich, Governor of Elgeyo Marakwet. And we have Governor of Nairobi, our host. Your Excellency, I want to end by saying that we look forward to very engaging deliberations for the next 2 days to discuss where we are, to consolidate gains, to appreciate ourselves that actually we have achieved a lot. And for those saying that they will scrap SHA, it's akin to telling us that they will destroy the roads that have been tarmacked once they get into office. I end it there. Thank you, Your Excellency.
Thank you very much, Your Excellency. Before I call the next speaker, I would kindly request the PSs who are in the house to stand up and just wave to the crowd. We have PS Mohamed Dagar, Transport, PS Judith Pareno, Justice, PS Ismail Madei, Special Programs, PS Harry Kimutai, Mining, PS Beatrice Inyangala, Higher Education, PS Idris Dokota, Cabinet Affairs, PS Joel Oromonyang, Public Works, PS Ann Wangombe, Gender Affairs, PS Karen Agengo, Children's Services, PS Cyril Wagunda, Public Investment, PS Joseph Mutari, Social Protection, PS Aurelia Rono, Parliamentary Affairs, PS Abubakar, Investment, Susan Mangeni, MSME, and PS Jacobs Fikirini, Youth Affairs. Oh, and our SG, Solicitor General for the Government of Kenya. Your Excellency, transforming healthcare requires bold leadership and a steadfast commitment to delivering comprehensive reforms. I now would wish to, it's my distinct honor to invite my Cabinet Secretary, Honorable Aden Duale, the Cabinet Secretary for Health. A round of applause.
Your Excellency, the President of the Republic of Kenya and the Commander-in-Chief of the Defense Forces, Your Excellency, the Deputy President, Professor Kindiki, Your Excellency, the Speaker of the National Assembly and the Head of the Legislature, Speaker Moses Wetangula, Your Excellency, our Prime Cabinet Secretary, Honorable Musalia Mudavadi, Your Excellency, the Chair of the Council of Governors, Governor Abdullahi, Your Excellencies, Governors present, Cabinet colleagues, Your Excellency, the Cabinet Secretary for Housing, my sister Alice Ohome is here, the Cabinet Secretary for Tourism, Rebecca Miano, the Cabinet Secretary for Gender, the Cabinet Secretary for Environment, the Attorney General, my brother, the Cabinet Secretary for Sports, the Cabinet Secretary for Energy, the Cabinet Secretary for Education, the Cabinet Secretary for Water and Irrigation, and the Cabinet Secretary for Labor. Your Excellency, allow me also to recognize the chairs of our Parliamentary Health Committee, the Senator Mandago, the chair of the Health Committee from the Senate and the entire leadership, Dr. Nyikal, the chair of the National Assembly Health Committee. Your Excellency, allow me also to recognize the entire leadership of the Ministry of Health at the national level. Allow me also to recognize the entire leadership from the CECs of our entire 47 counties who are present here, civil society representatives, NGOs in the health sector, our development partners in the health sector, our diplomatic representatives who are here, a number of diplomats are here. Your Excellency, the heads of health agencies, health workers, citizens who are here this morning, allow me to welcome you and every delegate to the Kenya Health Summit 2026. This is the largest gathering, Your Excellency, of Kenya's health sector ever convened in this republic, and it is fitting that it takes place under the theme that is a statement of fact rather than a wish. Reform delivered, health as a right. Your Excellency, in August of 2022, the people of Kenya were offered a choice. They were not offered slogans. They were offered a plan, written down, published, in which universal health coverage stood as one of the 5 pillars of our national transformation. Kenyans read that plan and they give it their mandate by electing you as their 5th president. 4 years later, we have come to this hall to do something that is rare in the politics of our country and in our region. We have come to place that plan side by side with a record and to invite the whole country to compare the two. And I want to say something about why this was possible, because it is not a technical story we want to say. It's also a political one. Every government that has ever governed Kenya knew what was wrong with our healthcare system. The diagnosis was never a secret, but it is set in reports. It was found in commissions. It was found in expert panels, in the exit notes of the departing officials, including presidents. But what was missing was also never the analysis. What was missing was a head of state willing to spend the political capital. Your Excellency, in the first year of your administration, you chose to retire an institution that has served this country for nearly 6 decades, that employed thousands, that had a constituency of its own, that has defeated the reforming intentions of every government before you. You were advised, and I know because some time is set in those meetings, and it could have been safer for you to amend, it could have been safer for you to postpone, or to pilot the way some of your predecessors have done, or to appoint yet another task force. You declined all those offers. You went to Parliament as our president, and you asked for the 4 new laws And that's why the Speaker of the National Assembly and the Committees of Health are here. And when the transition proved difficult, as deep reforms always do, you did not retreat into silence. You went out and explained it publicly in every county in this republic. And that's why we are here today. Not because the Minister of Health is clever, but because this reform had a political ownership at the very top, sustained for 4 years, and the technical machinery built deliberately underneath. Your Excellency, you will shortly place before this nation, is not my duty, the full account of universal health coverage known as Taifa Care. You'll tell the country the coverage we have done. You'll tell the country the contribution, the payments, and the outcome. And allow me, therefore, Your Excellency, to report to this summit on 3 matters that fall directly to this ministry and which determine whether any of that money ever becomes care, the medicines, the equipment, and the people. Your Excellency, a health system on health commodity security. A health system is only as credible as the medicine on its shelves. When this administration came into office, the national order fill rate at Kenya Medical Supplies Authority stood at 35%. In plain language, a facility that ordered 10 essential commodities received fewer than 4. Today, that rate stands at 95%. We restored the authority's balance sheet by recapitalizing KEMSA through 10 billion shilling credit facility arranged with one of our commercial financial institutions. And we did that because there's no supply chain in the world that functions without working capital. We have operationalized the Embakasi Supply Chain Center, and we have strengthened our regional distribution hubs in Kisumu and Mombasa. And we have moved the entire chain from paper to platform. Your Excellency, today KEMSA supplies more than 11,400 health facilities, and 54% of everything it distributes goes to primary health care at level 2 and level 3, the dispensaries and the health centers, where most Kenyans seek care. What this means for an ordinary Kenyan, Your Excellency, is very simple. The mother who walks to a dispensary with a prescription in her hand now finds the medicine at the end of the queue, and not a referral to a chemist she cannot afford. On National Equipment Support Program, equipment, Your Excellency, because a clinician without a diagnostic is a clinician guessing. Under the National Equipment Support Program that you introduced as one of the key pillars of universal health coverage, as of 30th July 2026, we have installed medical equipment valued at 9.68 billion shillings in 251 health facilities across our 44 counties, showing 239 county facilities and 8 national facilities. Let me be very specific about what that means at the bedside. It means 36 CT scans, it means 2 MRI machines, it means 52 digital X-rays, and it means 72 ultrasound machines that have been provided. Consider what that changes. Not long ago, a Kenyan who needed a CT scan had 2 options: travel to Nairobi or go without a diagnosis. Today, that equipment is available in the great majority of our counties, and it's paid for by Taifa Care, not by the national government and not by our county governments. Over the last 4 years, this government has deployed 24,573 healthcare interns to all the 47 counties, Your Excellency, at an investment of 19 billion shillings. and annual placement has risen from 3,373 in the financial year 2022-2023 to 6,800 in 2026, nearly doubling the single admission for our young graduates from our colleges. This has allowed young Kenyans who for 4 years ago could have completed their training and go home to wait, get a placement. We have also sponsored 262 medical registrars across 35 specialties, so that counties who have never had a single specialist are now growing their own. We have released 3.5 billion shillings to settle the accrued basic salary arrears owed to our doctors. Under your direction, we are employing 5,000 additional nurses and midwives are being recruited. All these happened under your leadership, Your Excellency, in the last 4, and we will showcase them as the 2-day health summit progresses. Your Excellency, allow me now finally to acknowledge our partners in this work. To our Excellencies, the governors, health is a devolved function, and every figure that will be quoted in this hall was earned in a county facility by a county staff. This reform has been a genuine partnership between the 2 levels of government, and I want to thank our governors for that. To our development partners who have stood with us, Kenya, through a very difficult period of global health financing, thank you for the confidence you have shown in our healthcare system. To our private and faith-based providers, our professional bodies, our unions, you are inside this system, not outside. And this reform is stronger for your involvement. And to the Kenyan healthcare workers who are here and those who are listening to us, who are the reason any of this, who are the reasons that a patient reaches them at any time. This government sees you. Tomorrow, this summit devotes an entire plenary to your future. Over the next 2 days, Your Excellency, we will do an examination of our healthcare financing, primary health care and community health, human resource for health, health products and technologies, health security, digitization of the healthcare system, and our specialized and referral services. Her Excellency, the First Lady, will do a session tomorrow on maternal and newborn health at the plenary. We will close, we'll have the Deputy President who will run another plenary tomorrow afternoon before we have a joint plenary where we want to listen to the people of Kenya, and His Excellency the President, as a listening leader, will be sitting in that forum. Your Excellency, just to conclude, tonight we have the Town Hall Health Summit. And we want to answer all the questions. We want to answer all the questions concerning the healthcare system in Kenya. We want to answer all the fake headlines for 4 hours. Because as I said, we had a plan, and now we are presenting the record so that the people of Kenya can compare what we promised, what we planned, and what we have delivered as of now. To Your Excellency, and more important, is in that healthcare at a health summit town hall tonight, we will have testimonials from the stakeholders, what our unions see in terms of healthcare workforce reform. Our patients, professional associations like Kenya Medical Association and many others. Our governors will be there. The entire leadership of the counties will be there. But Your Excellency, just to answer some of the basic questions that we have been asked, is that the architecture of universal health coverage, at the bottom is the primary health care, which is fully funded by your government. 27 billion in the last 2 financial years. 19 billion in this financial year. Why do we invest in primary health care? We invest in primary health care because 70% of the disease burden in our country is at the primary health care. And Your Excellency, with those many remarks, it's my honor and duty to invite the Speaker of the National Assembly to come and give us remarks on the role of the legislature in the delivery of healthcare system in our country.
Your Excellency, the President and Commander-in-Chief of our Defense Forces, Your Excellency, the Deputy President, and all established protocols followed. I'm here and I'm honored to address this health summit on behalf of Parliament. Your Excellency, over these 2 days, delegates will speak of hospitals, will speak of funds, will speak of medicines and equipment, will speak of systems, will speak of outcomes. I wish to speak about one aspect that precedes all of them, and without which not one of them would exist, and this is the enabling legal framework. Your Excellency, Article 94 of our Constitution provides that the legislative authority of the Republic is derived from the people and is vested in and exercised by Parliament. At our independence, Your Excellency, our founding father pronounced that the incoming government of the people of Kenya was going to focus on fighting 3 things: poverty, ignorance, and disease. Over the years, efforts have been made in the health sector to achieve the war against diseases. In 1966, the National Health Insurance Fund was founded, and later in 1998, it was cemented into an Act of Parliament as NHIF, primarily to provide for medical cover for formal and informal sectors. The fund was operated by the National Hospital Insurance Fund Board of Management, and it relied on tiered flat rate monthly deductions as its contributions rather than proportional income scaling. Over the period, Your Excellency, the NHIF faced massive systemic corruption, losing billions of shillings through ghost clinics, inflated claims, collusion between rogue medical facilities and state officials. The reform journey that your government started, Your Excellency, has had the effect of addressing all this. Whenever you speak to any member of Parliament, Your Excellency, you'll hear always the same story. Desperate families calling at midnight about hospital emergencies and their attendant bills, their names being forced on fundraising committees and cards that are circulated without their knowledge, standing at hospital gates negotiating for the release of a patient, and at mortuaries negotiating for the release of bodies to their loved ones. Parliament understood the necessity of reform because parliamentarians have constant interaction with the needy in the population. The Departmental Committee on Health in the 12th Parliament had recommended, as it exited on the 8th of June 2022, that its successor should establish a facility improvement fund for county public health facilities. Section 104 of the Health Act of 2017 had also directed that legislation on health be enacted within 3 years. That instruction had remained unfulfilled. The National Hospital Insurance Fund, born in 1966 and governed by the 1998 Act, had long since been overtaken by the structure of our economy and dynamic social needs. So, Your Excellency, when you brought this agenda to the House of Parliament in your administration, you found an already convinced Parliament. Parliament had been waiting for the executive to act, and it took courage from 1963. All successive governments had made half-hearted attempts to achieve what we now have in our country. In the year 2023, Parliament considered, interrogated, amended, and passed 4 statutes, which Your Excellency assented to on the 19th of October of the same year. These were, first, the Primary Health Care Act, number 13 of 2023. It established for the first time in our history a legal framework for the delivery and management of primary health care through primary health care networks, and it placed our community health promoters on a statutory footing rather than leaving them to the whims of successive government initiatives. The second was the Facility Improvement Financing Act, number 14 of 2023. This, anchored on Article 207 of the Constitution, permits a public health facility to retain and manage the revenue it generates. In plain language, money earned at a dispensary in Kimilili or Kilifi or Kachiliba is now spent and ought to be spent at that dispensary. The third piece of legislation was the Digital Health Act, number 15 of 2023. It discharged the unfinished obligation of the Health Act of 2017, established the Digital Health Agency, mandated a comprehensive integrated health information system for the whole Republic, and gave every Kenyan statutory protection over their personal health data. The fourth, the Social Health Insurance Act, the much talked about SHA, over which yours truly here was taken to court 6 times. It now, together with it establishes 3 public funds for primary health care, for social health insurance, and for emergency, chronic, and critical illnesses. 4 statutes passed in one session of Parliament, Your Excellency, was unprecedented. It is the most consequential body of social legislation enacted by any parliament in Kenya since independence. Far-reaching reforms are not always readily embraced and accepted. These 4 health bills were met with robust public debate. There were those who benefited from the gaps, flaws, and shortcomings of the status quo who did not welcome the reforms. These were in the minority. The majority of Kenyans saw this as a right trajectory in mitigating the myriad challenges that the health sector faced, and saw these legislations as a Damascus moment for our health sector. As we speak today, the number of Kenyans registered under the universal health coverage being a whopping over 30 million compared to about 8 million under NHIF will convince every doubting Thomas on the vision and foresight that informed these reforms. Numbers do not lie, and in law we say, res ipsa loquitur. Things speak for themselves. Under the Constitution, Parliament appropriates and divides revenues between the two levels of governments. It then has the mandate to ensure prudent use of those resources so that Kenyans get value for their money. I want to assure this summit that this is a duty that Parliament holds sacrosanct and will discharge without fear or favor. Parliament shall always ensure that any person or entity entrusted with management of public resources is accountable to the letter. Your Excellency, ladies and gentlemen, there are cases within the laws I have cited that require no financial contribution from citizens. These are primary health care, emergency, chronic, and critical illness. That notwithstanding, the law has set out the primary health care fund and emergency illness and critical health care fund, which are financed from parliamentary appropriations. Even in such cases where ordinary citizens do not directly pay for those services, the funds draw the money from taxpayers' purse, while the degree and extent of responsibility must remain the same. Your Excellency, ladies and gentlemen, with all these good legislative reforms, questions are constantly raised by members of Parliament on issues that this summit needs to address. Number one, rationalization of manpower or health professionals so that citizens in both urban and far-flung rural areas enjoy similar benefits and attention from our health sector workforce, including medical consultants. Two, the preventive and promotive care should be more enhanced to avoid costly curative remedies. Here we should place emphasis on regular physical checkups, clinics, advice on nutrition, fitness, immunization, counseling, etc. Three, cases of hemorrhaging funds from the healthcare system by individuals and health facilities, whether public or private, must be checked, and those found culpable must face the consequences. These include the war against ghost facilities that were very common under the defunct NHIF. I was happy as we went round to see that now we have an AI fraud engine that is dealing with this difficulty. The last, even where the citizen is required to make a financial contribution, the regulators should ensure that no unlawful charges are levied against any citizen. Your Excellency, distinguished delegates, ladies and gentlemen, as I conclude, I want to assure this summit that Parliament will discharge its responsibility to keep the health sector buoyant in our country. We will appropriate sufficient funds subject to the size of the envelope available and other national requirements. We will ensure appropriated funds are put to proper use, and together with the Auditor General, we will discharge these functions fully. We will remain open and ready to support the government with continuing legislative reforms to better existing laws and regulations and to give full meaning to health-related provisions in our Constitution and for the benefit of our country. I thank you.
Your Excellency, distinguished delegates, now it's my honor and duty to invite the Prime Cabinet Secretary to take the program from here.
Your Excellency, the President of the Republic of Kenya, Dr. William Samoei Ruto, Your Excellency, the Deputy President, Professor Kithure Kindiki, Speaker of the National Assembly, Chair of the Governors,
and all governors present, my colleague ministers, colleagues in the public space, members of the private sector, medical practitioners, distinguished ladies and gentlemen. Your Excellency, mine will be very brief. This summit is extremely significant. It is a summit that has brought us here so that we can acknowledge a very important thing. That is that the transformation, the delivery in our health system today is not a story of fiction, but is now a matter of fact. Your Excellency, you have stayed the course. You stayed the course when people went to court. You stayed the course when there are demonstrations in the street. You stayed the course when the critics were in every corner. You stayed the course even when people were branding you all sorts of names. Today, we celebrate a major transformation in Kenya's health sector. What we are going to witness and what we have witnessed, ladies and gentlemen, is fact and not fiction. Secondly, Your Excellency, I just want to say that one other hat you do wear, because the issue around the medical challenges does not end with Kenya's boundaries, is that you are also doubling up as the African Union champion for pharmaceutical manufacturing in the African Union. Again, a journey that moves beyond Kenya's boundaries to the continental realm, where you have to aggressively support and help transform matters medical on the African continent. Your Excellency, even in the middle of challenges, you have stood out to make sure that Kenya remains a responsible member of the international health fraternity, WHO, and other international obligations. When most people were scared to step forward on how Kenya can play its role in the midst of pandemics and epidemics, Kenya stood forward and you said that you shall be a responsible member of the WHO and the conventions that relate to health and the need to anchor and support other countries and other people when there's a medical crisis. You were taken to court, but you stayed the course. Your Excellency, Kenya emerging as a medical mecca in the region. The investment that the Ministry of Health is putting in place through the leadership of Duale and his team, consistency you have put forward on matters health is systematically and surely
transforming Kenya into a medical hub in the region. And that is something that we all need to cultivate and be proud of. Finally, Your Excellency, Kenya Kwanza, the nation first, the citizens first. Your message around the health sector is clearly a very, very critical plank and message that you will have nothing stopping you as long as you are focused on making the citizen come first in this country. We salute you. We also recognize that this is another classic example of perfect partnership between the national government and the county governments. This is a devolved function, but it is a partnership between the national government and the county government. I'm emphasizing this, Your Excellency, because there are times when you say that you want a partnership about other things between the national government and the county government, people proceed to court, forgetting that even what we are doing is a partnership between the national government and the county government. The two levels of government must work together all the time. Let me end by recognizing members of the diplomatic corps who are present. Those of you in the room, please just rise so that we can acknowledge you. I'll not attempt to go by name or country, but thank you so much. Most of you are not just diplomats here, but you're also partners in this journey. Thank you so much for being present. It is now my honor to invite the Deputy President, Professor Kithure Kindiki, to come and make his remarks and invite His Excellency the President.
Kenya hoye! Kenya hoye! Mr. President, Your Excellency, colleagues, today is an important day for our country. We have struggled since our country was established to create a good country. We have struggled to modernize our country and improve the quality of life of our citizens. 16 years ago, we adopted a new constitutional order. The summary of that constitution envisages a Kenya which is democratic, but also a Kenya where the citizen is empowered economically and has a healthy life. While we have made good progress on the democracy front, I think, Your Excellency, the last 4 years are extremely important for us because for the first time we have started deliberately making the first steps towards realizing a wealthier and healthier Kenya, which is an important component of realizing the dreams of the founders of our nation, the makers of our constitution, and the dream of a Kenya of the future. And so as I sit here to listen, Your Excellency, I relish to see the progress you have enabled us to achieve by carrying the people. Now we are talking of 32.3 million Kenyans covered with a medical insurance cover. This is phenomenal. We are looking at people getting medical advice from their homes and villages through the consequential 107,000 community health promoters, which continue to serve our nation well. I've just been with you as you went through what this administration is doing around medical equipment under the National Equipment Support Program, and also the consequences of the laws that our parliament has put in place. The Primary Health Care Act, the Social Health Insurance Act, the Digital Health Act, the Facility Improvement Finance Act, and the funds that are in place now. Primary Health Care Fund, the Social Insurance Fund, the Emergency Chronic and Critical Illness Fund, and the Facility Improvement Financing or the Facility Improvement Fund. So, Your Excellency, I am a very proud member of your administration. I speak on behalf of so many of us who serve in your administration. I speak on behalf of many Kenyans who believe in your leadership, that we are looking at a very, very critical transformation of our country. And we can look at the people of Kenya in the eye and tell them, this government has lived to its promise and commitment to pull the people of Kenya from disease and to create a healthier country which can be the engine for the economic and developmental future of our country. Naomba kwa heshima wenzangu, tusimame, tushangilie Mheshimiwa Rais akuja atuongeleshe. Rais Ruto ni fire si fire. Karibu Mheshimiwa Rais.
Asante sana Bwana Deputy President. Huyu Deputy President ni fire si fire. Tafadhali tuketi, asanteni sana. Thank you very much. Let's take our seats. Distinguished guests, ladies and gentlemen, there are promises governments make because they are popular. Others because they are convenient. And then there are promises a nation must keep because they speak to who we are and the country we intend to become. Universal health coverage is one such promise. For years, Kenya lived with a contradiction we should never have accepted, that access to health could depend on the size of a citizen's wallet. Illness could force a farmer to sell his livestock or sometimes his land. A mother could exhaust her savings, or a community forced to organize a fundraising simply to keep one of their own alive. Too often, treatment became a debt and sickness a pathway to poverty. That was wrong. It was also unjust. 16 years ago, through Article 43 of our Constitution, Kenyans made a solemn promise to one another. And that promise, the right to the highest attainable standard of health, was inscribed in our supreme law, and that no person shall be denied emergency medical treatment. That is not an aspiration. It is a constitutional command. That command informed the promise we made when I sought your mandate in 2022. Universal health coverage was one of the 5 pillars of our bottom-up economic transformation agenda, because economic empowerment means little when illness can wipe out a family's savings or push citizens into poverty. Yet, by 2022, barely 1 in 4 Kenyans had health insurance, and fewer than 1 in 20 among the poorest households. Millions paid out of pocket, borrowed, sold assets, organized harambes, or simply stayed away from hospital because they could not afford. Kenyans were spending an estimated 150 billion out of pocket every year on healthcare. The problem went beyond financing. KEMSA's order fill rate had fallen to roughly 40%. Medicines were often unavailable. Records remained paper-based. Claims moved very slowly, and facilities struggled for resources, while emergency care remained fragmented without a coordinated national response. We resolved to build that system from the bottom up, not to patch the old one, simply rename it or make another promise about it, but to fundamentally change it. On the 19th of October 2023, I signed 4 landmark laws that created the legal architecture for universal health coverage that replaced the NHIF Act. The Primary Healthcare Act strengthened preventive and community healthcare, while mainstreaming the place of our community health promoters. The Social Health Insurance Act replaced NHIF with SHA and established dedicated funds for primary health care, social health insurance, and emergency chronic and illness. The Digital Health Act established an integrated digital health system, and the Facilities Improvement Financing Act enabled public health facilities to retain and reinvest their revenues. Together, they transformed our healthcare in terms of financing, delivered and accounted for in Kenya, created the architecture through which we would finally translate Article 43 of our Constitution from a constitutional promise into everyday reality. We call this undertaking Taifa Care, as you all know. What followed has been transformational. And I would argue that alongside affordable housing, universal health coverage is one of the most consequential social transformations we have undertaken as a country. This achievement belongs, above all, to the people of Kenya. It is through your contributions, your taxes, and your participation that we have been able to make possible what our country has aspired for generations. Kwa hivyo, Taifa Care sio zawadi ya serikali kwa wananchi. Ni mfumo ambao Wakenya wenyewe wamejijengea kupitia kwa mchango wao wa mawazo, mchango wao wa pesa na kwa ushirikiano ya Wakenya wote. I consider it one of the greatest privileges of my public service to have been entrusted in our time with helping turn that national aspiration into reality. Across the country today, 107,800 community health promoters are going from household to household, equipped with smartphones and essential kits to find illness before illness becomes a catastrophe, to register households, educate families, screen for disease, monitor mothers and children, identify danger early, and connect families to facilities. More than 9 million households have been reached by our community health promoters, and over 750,000 people have been referred for treatment. For the first time, we have built a nationwide health network whose first point of contact is not necessarily a hospital bed, but the doorsteps of a Kenyan home. We are reversing to match county government contribution to CHP or community health promoter stipends shilling by shilling. From this level, when a patient requires further care, the next part of the journey begins. Through the Primary Healthcare Fund, eligible services at level 2 and 3 dispensaries and some level 4 health centers are financed by government. So far, the fund has received 27.4 billion shillings in budgetary allocation and disbursed 23.3 billion to support more than 20 million outpatient visits, benefiting over 15 million Kenyans. As we said, walk in, receive treatment, walk out, just as we promised. And I want to commend facilities, both public and private and faith-based, for working with us on this endeavor. This is a fundamental shift. Prevent what we can, detect what we cannot prevent, treat early what we detect, and refer efficiently what requires specialized treatment. And when a Kenyan requires admission, surgery, or specialized treatment, the Social Health Insurance Fund provides the next level of protection. build on the principle that everyone should contribute according to their means and their ability, but no one should be denied care merely because they cannot afford it. That is why the government of Kenya has sponsored nearly 560,000 vulnerable households, covering approximately 2.2 million Kenyans, while Lipa Sha Pole Pole enables families in the informal economy to contribute progressively according to their circumstances and means. Today, 32.3 million Kenyans are registered with the Social Health Authority. 8 million have received treatment. More than 1.5 million mothers have been supported to deliver safely, and more than 500,000 surgical procedures have been supported and paid for. These are significant numbers, statistics, as some would say, but behind every number is a human being, an anxious patient, a worried parent, a frightened child, a health worker doing everything possible, and for a life to be restored or saved. Consider, for example, the case of Lydia, an 18-year-old student and her mother, Naomi Mutendwa Kilunda. When Naomi's assistant chief encouraged her to register with SHA, she enrolled and listed her children as dependents, as is required. She could not have known then how much that decision would matter. Lydia later developed severe breast overgrowth that affected her mobility, her confidence, and her life as a teenage girl. She required specialized surgery at Kenyatta National Hospital costing $168,000, a bill her mother could scarcely have afforded. But because Lydia was covered, her surgery was paid for, and so was her recovery. Today, she is back in school, preparing for her Form 4 examinations. Or consider Christine Awino Onyango, a 42-year-old widow from Kisumu County, diagnosed with stage 2 esophageal cancer. Until recently, Christine would have confronted two enormous burdens: the cost of highly specialized treatment on one hand, and the additional cost of traveling hundreds of kilometers to Nairobi to receive it. Instead, she received specialized care at Jaramogi Oginga Odinga Teaching and Referral Hospital, including surgery, intensive care, and post-operative management. Her medical bill exceeded $250,000, yet her annual SHA contribution was only $7,000. Her bill was paid by SHA. So when people ask, what happened to the bottom-up promise, to the mama mboga, the boda guy, the farmer, and the ordinary working Kenyan? I say this to them: look at Christine, look at Lydia, and consider the millions of Kenyans who can now walk into a health facility and receive care. What could be more bottom-up than that? That is the transformation we promised. It is the transformation we have delivered. But the journey does not stop there. For some Kenyans, treatment is not a single visit or an admission or a procedure. Cancer, kidney disease, and other chronic and critical conditions can require care for months or years, with costs capable of overwhelming a family and their entire savings. That is where the next layer of protection comes in: the Emergency, Chronic, and Critical Illness Fund, established to ensure that prolonged or critical illness does not become a sentence to financial ruin. The same fund protects Kenyans when care cannot wait at all, in moments of emergency, when someone collapses, when a child cannot breathe, when there is an accident on our roads, or when a mother develops complications during a delivery. Nobody has time to compare prices, search for telephone numbers, or negotiate deposits. That is why earlier this month, we launched the SHA 922 Lifeline and National Ambulance Dispatch Center. A free call connects a person in distress to emergency care, with evacuation and the first 24 hours of stabilization covered whether or not the patient is registered with SHA. No deposit, no guarantee, no relative running around one office to another looking for money while a life hangs in a balance. And this is because Article 43 of our Constitution does not say emergency care is available only to those who can afford it. It says no person shall be denied emergency medical treatment, period. We are finally giving practical meaning to those words. Financing patients is only one side of universal health coverage. The other side is the facilities treating them, which must function. Through the Facilities Improvement Financing Act, public health facilities and all other facilities can retain and reinvest their revenues in medicines, equipment, and better patient care. Since October 2024, Social Health Authority has received more than 209 billion and paid out 178 billion to contracted facilities across 47 counties. KEMSA's fill rate has risen from approximately 40% to, as you have seen in the numbers there, 91%. That is commendable progress for KEMSA, but our destination still remains 100%. That is why we have recapitalized KEMSA with Kenya shillings 1.5 billion and extended a Kenya shillings 10 billion credit line to strengthen the supply chain in KEMSA. Ladies and gentlemen, digital health is the backbone that holds much of this architecture together. The old system was not only inefficient, but its opacity created opportunities for people to profit from its weaknesses. We had claims for procedures that never happened, fictitious patients who did not exist, inflated bills, and many more. We even encountered the absurdity of claims for the amputation of patients' legs several times, as though the same leg might have somehow grown. That was not healthcare, it was theft. And it was theft from sick people. That is why the Digital Health Act is so important. And you must have seen a huge campaign that was undertaken against the digitization of health. In fact, many headlines were written, sponsored by those who benefited from these schemes as to how expensive it was, how unworkable it was, and how it was assigned to some people and that kind of thing. Digitization is not simply about replacing paper with screens. It is about making every patient visible, every treatment traceable, and every payment accountable. Let me repeat. Digitization is not simply about replacing paper with screens. It is about making every patient visible, every treatment traceable, and every payment accountable. That is what it does. And as I have said, this whole process, the heart of it is our digitization process. For the first time in independent Kenya, we have put in place a comprehensive legal framework, financial architecture, institutional framework, community and digital architecture for universal health coverage, built and sustained by the contribution of Kenyans themselves. We have crossed a historic threshold. Just imagine what we have done. You know, when we asked the people of Kenya that we need to change the contribution metrics so that instead of contributing a fixed amount, let us contribute a percentage of everybody's income. The difference is what you see. We have done so together. I thank our governors and county governments for working hand in hand with the national government to make universal health coverage a reality across our country. And I say this with a lot of humility, that without the participation and the partnership of our county governments, this exercise would have been very difficult. And again, my good friends, the governors and the counties, I want to request you to stand up so that we can do a round of applause to all our counties. Tuwapigie makofi jameni. Thank you very much. You can take your seats. You were not so much interested in where the national government functions and the county government functions stopped or began. Collectively, we were interested in the health of the people of Kenya. And that is why this partnership has given us this result. This is the partnership and the cooperation between our two levels of government that our constitution envisaged. In our midst, we have also our members of parliament, who I very sincerely thank for debating and shaping and passing the laws that underpin this reform process, as was ably enumerated by the Speaker. Again, to our members of parliament, in both houses, those of you who are represented here, if you can stand up, we have members of parliament in our midst. Thank you very much. Thank you very much. We have both the chair of the Senate and the chair of the National Assembly in our midst. Asanteni sana. Please pass my regards, best wishes, and thanks to all the members of parliament who, across the aisle, debated these bills, made their contribution in formulating a sound legal framework upon which today we are undertaking this most consequential and transformational program in Kenya. Let me also, in the same spirit, thank my cabinet and principal secretaries. They have put in many hours under the leadership of the Deputy President to streamline and in a very consequential way made proposals on the improvements that were required, that were initially captured in our manifesto and progressively shaped into bills that went to Parliament. Again, Mr. Deputy President and my cabinet team and the principal secretaries behind you, simameni tuwapigie makofi. You guys have done a wonderful job. Asanteni sana. I really appreciate your support. But crossing this threshold does not mean the work is finished. It means the question before us has changed. No longer whether Kenya should pursue universal health coverage, that we have crossed that Rubicon. But how we make it work even better for every patient, at every facility, and in every county. That is the task ahead of us now. And we must be candid. We know that there are areas to improve, including making registration easier, benefits to be made clearer, claims faster, digital systems more seamless, and the quality of care more consistent. Because the ultimate measure of reform is not the laws we pass or the numbers we register, but the experience of every patient in terms of dependable, affordable, and dignified care. That is the measure. And we all know reform is not an event. It is a continuous journey of closing the distance between the promise we made and the experience of every Kenyan who seeks care in all our facilities. Ladies and gentlemen, this summit also comes as we begin a wider national conversation on the Kenya we intend to build beyond Vision 2030. Your contributions over the next 2 days will therefore do much more than improve universal health coverage today. They will help define the healthcare Kenya should guarantee to its people beyond 2030. Serious nations do not start again every 5 years. Governments will change, but a Kenyan's right to health cannot change with them. We can improve what we inherit and correct what does not work, but we cannot tear down progress without an answer for what comes next. Universal health care must become part of our national covenant, not an achievement of a government, a party, or a president, but of the people and of the Republic. That is why the National Development Charter matters, so that our children begin where we finish, not where we began. We have come so far, and we have further to go. Let us use these 2 days to strengthen what we have built, improve what can work better, and safeguard for generations what Kenyans themselves have made possible. I want to thank all the participants. I am looking forward with great anticipation for the next 2 days so that we can do a stock take of what we have achieved, agree on areas that need improvement, and consolidate what we have gained into progress that can be built on by generations that come after us. It is now my honor and privilege to declare the Kenya Health Summit 2026 officially open. And congratulations. God bless you all. God bless our great country. And I thank you. Asanteni sana.
Another round of applause for His Excellency, please. Your Excellency, with your permission, if you may, if I can seek your indulgence, kindly let's take our seats. We'd just like to take a few photos that will help us mortalize this day. Allow me, Your Excellency, to invite His Excellency, the Deputy President, the PCS, Speaker, CS Health, and the 2 PSs for Health kindly to be part of the photos as we progress. The 2 PSs kindly. And with that, I'll also request, as we are taking that one, all governors, please, to be on the left of the stage. All governors present. Please, let's proceed to the left of the stage and join in. Actually, let's join in. All governors present. We can balance with some coming to this side, please. Your Excellency, with your permission, if we can have all the PS, yes, okay, maybe we can use the 2 stages. And we have the CSs to join His Excellency at the bottom, and the PSs we can be at the back. We'll get a very good picture there. There's a space here. Yes. Thank you. And the last photo is all ambassadors present, please. So CSs and PSs, kindly take your seats. All ambassadors present, please, to join. And we have the last photo. While I take this opportunity to invite Dr. Mercy Korir, who is going to be continuing with the plenary after this. So while we finish, we'll allow His Excellency to exit, but the rest of us will remain to kindly proceed with the plenary. Ambassadors, you may take your seat. Allow me, Your Excellency, to just have the members of parliament, particularly the committee, who have made this possible as the last photo. Dr. Mercy Korir, if you kindly can come forward. After this, we'll allow His Excellency to proceed to the next session that he is going to be taking part in. But the rest of us will remain for the plenary and will be guided by Dr. Mercy Korir, who's right here. Thank you, Your Excellency. UN agencies. Thank you, Your Excellency. At this point, we'll allow His Excellency to proceed to the next session. The rest of us kindly remain seated while Dr. Mercy Korir takes over. Please let's remain seated as we allow Dr. Mercy Korir to guide us on the next plenary. Thank you.
Thank you. Thank you very much. Let's remain seated as we get organized for our next session. We'll be playing a short video to showcase what these policies have meant in transiting and transforming this to people. We'll play a short video as we get organized for the next session, and I'll ask that we still remain seated. Let's do a short video.
In 2022, the government committed to making quality healthcare accessible and affordable to every Kenyan. That commitment was translated into 4 landmark laws enacted in 2023. The Social Health Insurance Act, the Primary Healthcare Act, the Digital Health Act, and the Facility Improvement Financing Act. The launch of universal health coverage at Kapkatet marked the transition from policy to implementation, while the launch of community health promoters as a Yoruba extended healthcare into communities and households. Today, the impact of these reforms is becoming visible across the health system. More than 32.2 million Kenyans are enrolled with the Social Health Authority. Over 1 million deliveries have been financed, while 23.3 billion Kenya shillings has been disbursed to level 2 and level 3 facilities through the primary healthcare fund. The proportion of household health expenditure paid out of pocket has reduced from 23.5% to 20.3%. Households facing catastrophic healthcare costs have also declined from 12% to 8%. H2 Health is moving Kenya from manual processes towards secure and connected services. A total of 6,171 public health facilities, representing 91.9%, are using digital systems. 5 health platforms are interoperable. 88% of targeted processes have transitioned from manual
check, check. Mic check, 1, 2. Mic check, 1, 2. Mic check, 1, 2. 1, 2. 1, 2. Mic check, 1, 2. Eh?
One, two, sound check. 1, 2. 1, 2, sound check.
Mic check, mic check.
We break for lunch. We come back for the plenary session at 2 o'clock. Kindly, let's be back here by 2 o'clock for the. Huh? Let's come back at 2 o'clock for the plenary session. So we can be able to use this interlude to take a quick bite and be back by 2 o'clock for the first plenary session. Thank you.
In 2022, the government committed to making quality healthcare accessible and affordable to every Kenyan. That commitment was translated into 4 landmark laws enacted in 2023. The Social Health Insurance Act, the Primary Healthcare Act, the Digital Health Act, and the Facility Improvement
89% have access to reliable electricity. Access to essential medicines has improved, with primary healthcare facilities recording an 88% fill rate. The health workforce remains central to these reforms. More than 24,000 interns have been deployed during the administration, including 6,801 in the 2026-2027 financial year. Kenya also has 71,533 active public sector health workers. At the household level, 107,831 community health promoters are serving communities across all 47 counties. They are connected to 9.42 million households through digital systems. Primary care networks have expanded from 2 to 278, supported by 278 multidisciplinary teams. Community health promoters have assessed 17.4 million children under 5, identified 316,000 pregnant women, and referred 750,000 clients to health facilities for maternal, child, and chronic healthcare. From financing to digital health, from healthcare workers to medicines, and from primary care to specialized treatment, policy is being translated into measurable services. This is Kenya's journey from policy to patient. This is Taifa Care. Reforms delivered, health as a right.
Hello everyone and welcome back to the Mathare National Teaching and Referral. Today we have a very important guest and I'll tell you more about him, but today we want to have a conversation about maternal mental health with a specific focus on postpartum depression. I am Dr. Vundi. I'm a consultant psychiatrist at Mathare Hospital and I will be having this conversation today. And to my left is a very wonderful friend that I met recently, who I want to give the chance to introduce himself. Karibu sana.
Thank you so much for having me, and I cherish the platform to be able to echo the sounds of many who are going through postpartum depression. So my name is Ben Hage Onyango, and I'm a cyclist, so I enjoy cycling. And today I'm here with a focus on appreciating mental health. And so I am a sociologist by training. I've interacted in my work experience in the space of public health. And that interaction has led me to have something innate in me to be able to just keep the conversation going beyond just a general engagement, but focusing on health promotion, going out to figure out what are the other ways of doing this. So I use bicycles as a tool to basically engage. So some of the things that has allowed me to be able to reach out to more people is using the bicycle, for example, to cycle through 9 countries and echoing the voices of people who are using the roads. So road safety, because we know one of the public health issues is accidents on the road, and more so for people who are cycling or motorbike, etc. So going into such journeys allow people to appreciate that, hey, there's a lot that we could learn through the process, and not only learning, but seeing it from my own eye or from my own focus, so that people can also get involved. I've done many other things. One of those is last year, for example, in 2025, I went out and cycled over 12,000 kilometers from Kenya all the way to South Africa and back.
Wow.
Trying to share about Turner syndrome, which is a genetic condition that affects women and girls who miss an X chromosome. So that is basically who I am. I have a lot to share and I'm happy to be here. Thank you so much for having me, Dr. Vundi.
Wow, that's amazing. And the fact that you've come to visit us here at Mathare, I suspect that your new advocacy journey has something to do with maternal mental health?
Yes, it has.
Tell us a little bit about that.
Yeah, during my cycling, I was about 128 days, October, that was early October. So I checked my phone and I saw a message that was quite unique. So when I read through the message, it was like, hey, we've lost Diana. And so like, couldn't figure out what had happened. I was quite fatigued during the day. I think I was having eye issues. So I thought, let me just rest. So I was in Tanzania coming back. Later in the evening, now the details were shared with me. And so we lost Diana out of postpartum depression.
I'm so
And
sorry. I'm sorry.
she left a very young baby, barely a month old.
Mm.
And so when I, through that night, when I was thinking around what awareness will look like, I said in 2026, then I'll go into and create awareness of mental health and particularly postpartum depression, because from the family point of view and for myself is not, we don't want any other new mother to go through the same. Why
Yes.
not echo the information required, the services that are available, the social spaces where one is able to pretty much have a conversation to lessen the burden of feeling isolated and so on. And so I'm here today to be able to just be that voice showing the steps to women and families and even healthcare workers, how a journey will actually support many other people, because delivery will always happen. Even today, there are many people who are giving birth. So if you look at the numbers and I know the statistics, for example, at the teenage and below, when you talk about postpartum depression, you're looking at 43% up to 48%. That is almost for every 2 births, one might, or most likely, will undergo PPD. So that's why I'm here. Madare is a national facility, and it incorporates mental health. And so
Yes.
coming here allows me to appreciate
Thank
how does
you.
it look like to be supported
Yes.
through the process of maternal mental health. And
All right.
specifically, yes.
First of all, let me just say I'm so sorry for the loss of Diana. Of course, we had talked before and you had told me the story. For those who are watching and are not fully understanding what we are talking about when we say postpartum depression, let me bring it back home. Postpartum depression is a mental condition that affects women who have just given birth. The prevalence is about 10 to 20%. In Kenya, it's closer to 15%. And what that means is after a woman gives birth, because of the hormones fluctuating, it causes a condition where a woman gets sad. So there's issues with the mood. Other symptoms could be irritability, anger, lack of sleep, although we know that at that time, really, you can't sleep, but it means that some of these women can go for days without sleeping. Now, there can be excessive feelings towards the baby where you're not feeling attached to the baby. You're not feeling like you're bonding to the baby. On a very extreme end, we do have postpartum psychosis, whereby the woman completely loses touch with reality. And these some of the consequences of postpartum psychosis include women harming themselves, so taking their own lives, dying by suicide, or even harming the baby, what we call infanticide. So postpartum depression, having listened to the signs and symptoms, you might be wondering, maybe you have a wife who is pregnant, you have a sister and you're wondering, how do I tell that she's not okay? And what do I do? So from the symptoms that I've given, if there's any change in 3 parameters that from thoughts, feelings, and behaviors. So if there are any changes of a woman during she's given birth and you're observing that her thoughts, feelings, and behaviors have changed, please reach out to a mental health professional. We have psychologists, but preferably we aim to start with a psychiatrist. Okay, so if you see that her thoughts are, we start with thoughts, her thoughts are sad. She's always thinking thoughts that my baby is going to die. I'm not a good mother. I'm worthless. So if you're noticing her thought patterns are negative towards herself, towards the baby, that's a sign. Moving to feelings, if she's talking about sadness, if she's talking about excessive worrying, Feelings can even be anxiety, or feelings like the baby is irritating her. Take this baby away from me. So those are some of the symptoms. Behaviors are the last parameter. Remember, we said thoughts, feelings, behaviors. If you notice strange behaviors, right, that she's withdrawing herself, she's isolating herself, she doesn't want any visitors, she's refusing to shower, odd behaviors, throwing things, banging things, then you know that this person needs help. Bringing this back to you, Ben, I think one of the things that we can't, finish this conversation without talking about is stigma. And I believe the whole point of advocacy is to dismantle stigma. Can we talk about what you have seen when in your advocacy journey when it comes to maternal mental health?
Yeah, thanks. One of the hashtag, I know in the space of hashtag, one of the hashtag is basically cycling to kick postpartum depression stigma, because it's real. I was having a conversation with someone who has a lived experience, and one of the stigma that came to her was just feeling she's not part of the family. And so isolation became a reality to her, and she created what we call a dark room. So wherever anything happens to her, she'll be looking forward to going to this dark room. I'm reflecting back to what she said. Could it be different? Honestly, she was aware about it, but the environment kept on bringing the same issues. Why did you decide to go try and commit suicide? Why did
These
you?
are now questions from...
the questions now she's being asked. Looking at stigma from what I call the nuclear family is number one, because she got pregnant when she was a teenager. And so it was not an expectation. And just as mentioned earlier, if you look at new mothers and PPD, most of it in terms of percentage is way high among themselves.
Yes.
And the stigmatization starts from there. Secondly, when talking about advocacy, with the focus of the community, most people are actually not aware about it. They say, no, si ule mwanamke ni hivyo ndio anafanya. So it's generalization. It's not coming to understand, for example, could there be something wrong? Was this the same person you're seeing? Behaviors you've shared, is there a pattern that has changed? And so as an advocate, for me, it's trying to get how do we support the community members to recognize certain behaviors or certain patterns that could allow community members, our healthcare providers, to even go a step ahead and support them further. Back to the story of the lived experience, she mentioned that once I gave birth, I had a tear. The tear was never done immediately. It was done the following morning after childbirth. So pain became part of the whole thing. So whenever she felt pain in her environment, she felt like, you people don't understand me. And so when she talked, the rest of the community be like, but that's your own problem. So that kind of feeling also brings that feeling of I'm not part of.
I think
it's not the easiest.
It's not the easiest. As we talk more about stigma and the advocacy that Ben is doing, I think, Ben, I need to shine a light on what you're doing a bit more, because people don't know that you have cycled all the way from Mombasa. You started 4 days ago.
Yes.
And tell us a bit more of your journey. Where are you planning to go? And as you're going to all these places, what are you actually doing? Are you interacting with the community? Are you meeting other doctors? Tell us a bit more of your journey.
Yeah, thanks. So my journey is appreciating the context where Diana lived, which is Kenya. And so I decided I'll do cycling within the country. So I'm cycling across 12 counties in Kenya. And within the 12 counties, I'm doing very different things. Of course, having courtesy visits, because health is devolved at the county level. Then away from that, now visiting specific entities. So I started off in Mombasa, where I was flagged off by the public health and prevention director, Dr. Salma Swale.
I know Salma.
And then, of course, with her counterpart in the mental health space. So they gave me a feel of, for example, how they're working to empower the community health promoters to have, to some extent, understand the mental health.
Wow.
So that they're able to identify them at the community level and have a linkage with their health facilities. So that's where they are at. And they are trained, if I'm having the number right, about 10 of them out of the many CHP that they have.
Yes.
And so that is the strategy they're using so that they're able to identify some of the cases, including those from postpartum depression. So it's a learning lesson as I'm doing this. So that is what I learned from Mombasa through the Mombasa County.
Yes.
Then when also still in Mombasa, I also visited Chiromo Health Group, which is also a health facility that supports mental health wellness. And in there, I was asking the question, what is PPD from your perspective? And the facility, what are you doing?
Yeah.
And hearing the expert, the psychiatrist and the psychologist speaking, it gets me to understand how much we have in terms of support. The question now is, how do we link people in? So as I'm doing this, I'm sharing about this. You are a listener out there. You get to see and understand there's so many places you can actually get support. Sometimes, the example I gave you last time, I mean, I'm 40 years. It was my first time visiting Mathare.
Yes.
Getting into the gate.
Right.
Now here I am again.
Yes.
I'm beginning to appreciate that, hey, it's a facility that supports general treatment, including mental health.
That question that you asked the team at Chiromo, I'm going to attempt to answer it because I've really taken it as a challenge. As Mathare, what is our view about maternal mental health and what are we doing about it? In fact, that might be my challenge for the next year. But I can say that we take it extremely seriously and it's a top priority. Whenever we have a mother who is not doing well, and she has just given birth and she presents either at the outpatient or at the clinic, she receives top priority. There's also a lot of research that is going on within Mathare, which I'm very, very involved in terms of to see the gaps and how those gaps can be filled.
There are many gaps surrounding maternal mental health, being one of the areas in mental health and mental health itself in general. There's a lot of gaps and a lot of issues going on in the community. But I'll pick up from what Ben mentioned when you were having a conversation with him in terms of awareness. Yeah, so awareness is one of the biggest gaps, even for the mothers themselves, knowing that what am I going through? Is this normal? Is it what am I experiencing when I've experienced the birth and now they are going through depression? Sometimes there's what is also termed as a postpartum blues. So people sometimes just imagine it's just blues. It's just women go through this. They experience this after birth, and sometimes, as we were saying earlier, it can get normalized. And the mother doesn't know that she's actually going through a condition that is treatable and can be managed. So that is one of the first gaps that I usually notice, is that the mother herself may not be aware of what she's going through. That is actually a major problem that can get complicated, as you said earlier, and even go into psychosis and go into even fatal outcomes. And even the family, the people around that mother are not aware that this lady is going through a lot. Sometimes they feel like they're exaggerating. Other mothers have given birth and they have gone through bigger problems. So there's a big problem with awareness, people understanding that postpartum depression is a big thing. It's an actual condition that women go through after giving birth, and it's something that needs to be addressed and can be treated. So that's one of the major gaps in terms of awareness. The second gap is access to services and being able to get treatment. As you've said, it's a condition, as you highlighted, it's a mental illness and people can get treated. So people may not, first of all, be aware that it's something that they can come to hospital to get treated. So that is the first gap in access. They're not able to know that they can get treated. And when they get to many facilities, so it's a condition, as you said, that is treated by psychiatrists and psychologists. So in many parts of the country, we may not have enough psychiatrists, we may not have enough psychologists where these mothers can go to and get treated. But that gap, at least of late, has been getting filled up. There are many psychiatrists getting trained, and many are going back to the counties. So you might feel like you may not know, but some county near you, a county referral hospital near you, should be having a psychiatrist and should be having a psychologist. Just walk in and ask the accident and emergency or the reception. You might get a psychiatrist, and that is the first stop where a mother who has experienced or is experiencing postpartum depression can get services from. So the next gap that I talked about is access. Then the next gap is getting the right treatment or getting the right environment for treating this mother. So you find even when they're in a county referral hospital or even in a facility like ours where this is a national mental health hospital, if they come here for treatment and they get admitted, then we are not able to give some services like a baby wellness area where the mother can
baby unit.
Exactly. So sometimes the mothers have to leave their babies back at home, or the relatives have to stay with a 1-month-old baby, 2-month-old baby, and now the nutritional benefits for that child, and even the mother's benefits being with their own baby. Well, they are getting admitted and they are getting treated for the postpartum depression. We are adding more stress because they are away from their baby.
There we go,
so the environment, hospital environments may have some gaps where we need to rethink. We need to see how best we can make sure that when the mother is getting treated for the postpartum depression, we can make the environment conducive enough for the mother and the baby.
In fact, you've just answered my next question. I think that's one of the answers. I was going to ask, what are some of the suggestions that you can make to help bring close these gaps when it comes to maternal mental health in Kenya? So I'm guessing recommending mother-baby units would be one of the ways that you'd recommend we close these gaps. What are some of the other suggestions that you have?
One of the ways, as you've said, is making the environment conducive and ensuring that the mother and the baby have dignity in the process of recovery. So that, for instance, maybe that's one of the challenges that we can take as Mathare, that we can start thinking of having a dormitory where, or a place where the babies can be available for the mothers as they are being treated. In other ways that we can fill in these gaps, as I've already talked about, we talked about the gap for awareness. That calls for training. That calls for a lot of teaching, a lot of awareness that the guy is doing. I've been commending him and I'm telling him he's doing a great job. He's going out for us as we're sitting back here in the hospitals to treat the patients. We need people out there to talk about this and create the conversation so that people can be aware about postpartum depression and maternal mental health. So we need to create a lot of awareness. We need to train. He talked about a facility in Mombasa that is training community healthcare workers, people who are out there in the community, people who can access the homes and can be able to identify these conditions early and even link and refer the mothers early. And also now even linking the mental health space and the maternal health space, where we link the psychiatrist and the gynecologists and even the maternal health nurses, all the specialists in the maternal health space, to have a seamless interaction with the specialists in the mental health space, so that we don't have anywhere we are losing the mothers in the gaps.
I love that. I mean, you've answered it fantastically. Those are recommendations that, as you've said, we should champion, because we are the people here on the ground interacting with the patients. So that's a challenge for us. Ben, I just want to thank you so much for being here today and for all the work that you're doing. It's too much. What he's doing is too much to fit into this interview. So I'd really like for you to follow him on his social media platforms. He's going to mention them, but we are also going to link them in the description below. So please follow him so that you can see beyond Mathare what else he's going to be doing about this advocacy on maternal mental health. So please tell the viewers where they can find you.
Thank you so much. So on social media, Ben Hagai on Facebook, Instagram, Strava, and then on X,
mic testing,
Ben
2,
Hagai
1,
2. Am I missing?
Mic check, 1,
Any
2.
publications or papers you've written, you've been
Mic
part of?
testing,
Yeah,
2,
so if you
4,
go through
6.
those social media, how do you call it?
2. 1, 2. Yule hajaenda lunch aende lunch. Saa 8 ikupate hapa. 1, 2. 2.
Check on 2. 2. Check on 2. On to the next mic.
I've almost shared each and every writing, publication in my social media spaces. So feel free to interact backwards as we engage, so that you see to what extent am I doing health promotion and health advocacy to be able to echo some of the voices when it comes to the space of health. Yeah.
Thank you so much. And please also subscribe to the Mathare National Hospital digital pages, so that you can keep getting to see these amazing conversations that we will be having. Thank you so much. Be sure to like, share, and subscribe. We'll see you next time.
Yeah. 2. Check 1, 2.
If you look at the 18 months of social authority in existence, in terms of primary health care, level 2, level 3, and level 4, the county, the public health facilities, the counties more so, get the biggest share, about 67%. But when you come to the more specialized treatment, the Social Health Insurance Fund and the PMSF, then the private sector and the faith-based take a bigger lion's share. What am I saying? I'm saying dispensaries and facilities are the recipients of the Facility Improvement Fund. Ideally, the way the law has been designed, both at the National Assembly and the Senate and at the County Assembly, the ring fencing in terms of what activity they're supposed to do with has not been done and should be done. That this money is meant for recruiting more healthcare workers, whether contract or locum, buying medicines for those facilities, buying laboratory reagents, buying small equipment, and more so making sure that the facility looks and has the standard required of a health facility. So we're facing two problems. One, we're facing governance issue. The people who should run those facilities as a board must be people, from the community, but people of integrity, people who will not use the money from the social authority, to make a gate, to do cabro, when that facility has no medicine, that facility has shortage of staff. That's number one. Number two, we have also found a situation where even in the counties, not all counties, but some few counties, money is returned back to the county treasury. And we have spoken to the Council of Governors, and that one has. But I think we just need, let me give it credit, a lot of our public health facilities are using the Facility Improvement Fund correctly. Parliament and the Senate committees have gone round, they have done a report on specific counties they have gone to. But ultimately today, I can tell you without any fear of contradiction is that there's more resources going to the primary healthcare networks than during the NHIF time. And that means Kenyans can go, and that's why we have a charter in all those health facilities that says we offer the following services and they're free. So I really want to ask Kenyans, do not allow somebody, even the watchman in that facility, to ask you to buy an exercise book. Primary Health Care Fund is a fund that is established in law, and it says Kenyans should walk into any facility and walk out when they are treated, given medicine. If you are asked to pay something, that is illegal, that is criminal, and I think Kenyans must be aware of that.
Mic check 1 2. Yeah 2. Perfect.
Hello everyone and welcome back to the Mathare National Teaching and Referral Hospital digital space. Today we have a very important guest and I'll tell you more about him, but today we want to have a conversation about maternal...
My name is Douglas Bosire. I'm the Chief Executive Officer for the National Syndemic Disease Control Council. NSDCC is a semi-autonomous government agency, a parastatal for that matter, under the State Department for Medical Services, Ministry of Health. Many people knew us before as National AIDS Control Council, which was the institution formed to lead the country's robust multi-sectoral response to HIV back in 1999, when HIV was declared as a national disaster in this country. And our mandate was expanded in the year 2022 by the legal notice 143 of 2022. And now we became National Syndemic Disease Control Council, whereby the word syndemic includes HIV and the other related epidemics. Over the last 42 years of programming and having the virus here with us in Kenya, because the first virus was actually detected in the year 1984, the country has made tremendous progress. However, we are wary of confusing that progress with success here at NSDCC and as a country. We have managed to reduce significantly the number of AIDS-related deaths. We reduced significantly the new HIV infections and that of other systemic diseases. Currently, we have about a cohort of about 1,480,000 Kenyans who are living with HIV. Courtesy of the government-led processes, of course, led by His Excellency President Dr. William Samoei Arap Ruto, and our leadership in the Health Ministry, led by our Cabinet Secretary, Honorable Aden Duale, we have managed to enable 93% of Kenyans who are living with the virus to know that they actually have the virus. Out of those 93%, 91% have been put on treatment. We currently have a cohort of about 1,348,000 Kenyans who are on treatment. It is the 7th largest treatment program globally. And out of that number, we have managed to ensure that 87% of them are virally suppressed. Viral suppression is very important because it not only enables you to stay healthy, but also it impedes or stops transmission between you and a loved one. So this is all part of the gains and the focus that we are having towards ending this epidemic. Over the last 4 years alone also, very dramatic and significant progress that we must note. We have reduced the number of new HIV infections from 22,154 in the year 2022 to 13,936 in the year 2025. This is the period of the current government of His Excellency, the President, Dr. William Samoei Ruto. So that significant reduction in the number of new HIV infections, which is about 37%, has never been seen within such a short period. We have fairly done well. We have demonstrated that actually we can do it. These statistics that we released the other day for 2025 are statistics of hope. They give us determination. They encourage us that we stay this path and we address that challenge of HIV in children, HIV amongst adolescent and young people, and HIV amongst key population, then together we can get to an AIDS-free Kenya by the year 2030. My name is Douglas Bosire. I'm the Chief Executive Officer for the National Syndemic Disease Control Council. DCC is a semi-autonomous government agency.
My name is Dr. Andrew Mulo, Head of the National HIV and STI Control Program in the Ministry of Health in Kenya. First, to begin with, is to appreciate that Kenya's HIV program has been, over the last 40 years, run as a vertical program, supported by donors, where we have had standalone clinics for care and treatment, and heavily funded programs within the ministry's delivery system for the program. With the reality of changing donor funding landscape and the global health financing landscape occasioned by reducing funds through the multilateral mechanisms, including Global Fund, UNAIDS, WHO, and bilaterals, especially the United States government support and changing of the PEPFAR program, it has become imperative for the Kenya government, Ministry of Health, and the National Treasury to take up domestic resourcing of HIV. And as part of sustainability plan, which we had already come up with prior to some of these shifts, we have ensured that HIV is part of the integral part of the health delivery system in the country. One of the key tenets to that is integration. So HIV services are integrated in the primary healthcare. We are also working in the new reforms that are happening in the healthcare and financing landscape, so that HIV services become part of the social health insurance landscape. And the priorities that the health reforms that are undertaken, which is the human resources for health, a lot of healthcare workers that are engaged in the HIV delivery systems are actually supported by donors. Part of that is to through the G2G arrangement that is already under negotiation and implementation, is to absorb this stuff into government payroll. We also have commodity security. HIV clients require drugs, require clinical monitoring, which is laboratory support, and testing for HIV as means of prevention and detecting new infections. And these commodities are required to be in stock at all times. And we are working with the Ministry of Health to ensure that these services are integrated into the national planning, including local manufacturing of some of these products, condoms, test kits, ARVs, as part of the sustainability plan. We also aligned in terms of digitization. The HIV space has for a long time been the leader in digitization of services in the country, and we are working with the DHA. We are also scaling up training of healthcare workers, so that all healthcare workers from whatever point of care, they can be able to handle HIV clients and offer quality HIV services. We are also I talked about local manufacturing, for example, as part of the sustainability, so that we are able to have products being manufactured locally for the Kenyan market and even for the global market. And talking about a huge population that will require to be on lifelong treatment. We are also working with the global community to ensure that we also adopt new technologies, especially for prevention. Kenya was among the first countries to adopt the use of long-acting lenacapavir injection for prevention of HIV as a means of preventing new infection, because we believe it's only by closing the tap of new infections that we can really contain the HIV epidemic. My name is Dr. Andrew Mulo, head of the National HIV and STI Control Program in the Ministry of Health in Kenya. First, to begin with, is to appreciate that Kenya's HIV program has been, over the last 40 years, run as a vertical program, supported by donors, where we have had standalone clinics for care and treatment, and heavily funded programs within the ministry's delivery system for the program. With the reality of changing donor funding landscape and the global health financing landscape occasioned by reducing funds through the multilateral mechanisms, including Global Fund, UNAIDS, WHO, and bilaterals, especially the United States government support and changing of the PEPFAR program, it has become imperative for the Kenya government, Ministry of Health, and the National Treasury to take up domestic resourcing of HIV. And as part of sustainability plan, which we had already come up with prior to some of these shifts, we have ensured that HIV is part of the integral part of the health delivery system in the country. One of the key tenets to that is integration. So HIV services are integrated in the primary healthcare. We are also working in the new reforms that are happening in the healthcare and financing landscape, so that HIV services become part of the social health insurance landscape. And the priorities that the health reforms that are undertaking, which is the human resources for health, a lot of healthcare workers that are engaged in the HIV delivery systems are actually supported by donors. Part of that is to through the G2G arrangement that is already under negotiation and implementation, is to absorb this stuff into government payroll. We also have commodity security. HIV clients require drugs, require clinical monitoring, which is laboratory support, and testing for HIV as means of prevention and detecting new infections. And these commodities are required to be in stock at all times. And we are working with the Ministry of Health to ensure that these services are integrated into the national planning, including local manufacturing of some of these products, condoms, test kits, ARVs, as part of the sustainability plan. We also aligned in terms of digitization. The HIV space has for a long time been the leader in digitization of services in the country, and we are working with the DHA. We are also scaling up training of healthcare workers, so that all healthcare workers from whatever point of care, they can be able to handle HIV clients and offer quality HIV services. We are also I talked about local manufacturing, for example, as part of the sustainability, so that we are able to have products being manufactured locally for the Kenyan market and even for the global market. And talking about a huge population that will require to be on lifelong treatment. We are also working with the global community to ensure that we also adopt new technologies, especially for prevention. Kenya was among the first countries to adopt the use of long-acting lenacapavir injection for prevention of HIV as a means of preventing new infection, because we believe it's only by closing the tap of new infections that we can really contain the HIV epidemic.
My name is Aisha Dakala. I'm the highest female blood donor in the country. I've donated 103 times. I've done blood 73, and platelets I've done 30 times. And I started donating when I was 17 years. And right now I'm 62 years. So I've been donating blood for the last 45 years.
You realize that blood is a drug, but it's the only drug that you can't go into chemist and procure with your own money. So a human being have to donate blood to save a life of a human being. So we normally say it's a life-saving drug. In 2022 June, we had collected 230,000 units of blood. That is the highest we could go by then since independence. From 2022 to 2026 June, we've collected 450,000 units of blood across the country. When you compare with WHO guidance, WHO says a country should collect 1% of its population blood units. So what that means is we're supposed to have 520,000 units. Okay? So this season, that is June 2026, we collected, like I said, 450,000 units. That is 86% of need. And this is historical. We've never achieved this. We've also improved on technology. Those days, the year 2022, we used to collect what we call whole blood. But currently, we have diversified. If patients require platelets, what we call platelets, we collect platelets. If donor wants to donate platelets, he or she donates platelets. Those days, they collect the whole blood. I mean, so there's a huge growth in terms of availability of blood and the need that the patient really need to get what they want.
As a country, we've built now a blood donor management system, and we are among the few countries that have done an in-house development of a national blood banking management system. As at today, we have already registered over 600,000 donations in the system, and all our blood management processes are done through the system to ensure that as hospital requests for blood, they also digitize the requests that they get to us, and also we are able to digitize how we are issuing the blood to them.
The women are our caregivers. We see our children dying, our parents dying, our husbands dying, and we are very easy to cry. So normally I say tears can never save a life, but if you have donated blood, it will save a life.
I encourage Kenyans to continue donating blood. There are challenges in any systems in terms of access because of the logistical setting of this country. But if you go to Turkana today, Lodwar, you will get the same quality of blood that you get in Kenyatta. If you go to Mandera, you get the same quality of blood that you get in Garissa. I mean, so we have touched the whole corners of our nation. So Kenyans will have hope, okay, that whatever they get need in terms of blood is currently available. And we keep on expanding. We keep on expanding.
My name is Aisha Dafala. I'm the highest female blood donor in the country. I've donated 103 times. I've done blood 73, and platelets I've done 30 times. And I started donating when I was 17 years.
My name is Dr. Masi Mwangangi, and I'm the Chief Executive Officer of the Social Health Authority. And I'm pleased to be able to engage with you today to share with you the impact that the Social Health Authority has had on Kenya and the citizens. And perhaps where we start is by looking at what was there before, trying to understand what was there before, and then why we're doing what we're doing right now, and why we have reforms that have led to the creation and implementation of the Social Health Authority. Now, any country in the world has to make an investment towards the health of its people. And that's because a lot of evidence has shown us that when you invest in health and health systems, then you also invest in the economic development of a country. So people summarize it by saying health is wealth, and that is very true. Now, Kenya has been on a journey towards universal health coverage all the way since independence. UHC means that all Kenyans, the U is the universal part, all of us Kenyans are, one, covered and have health that is able to ensure that we have good services and good health outcomes. Now, if you look at what we are doing right now with the Social Health Authority, which is a constituent of 3 funds, Kenya right now, if we were to look at the Primary Healthcare Fund, we would say that we are at 67% population coverage. A second key component that I touched on before I mimic, what is closest to NHIF, which is the Social Health Insurance Fund, would be the ECCI fund, where again, for the first time in this country's history, an administration has decided to focus on emergency services. This has never happened before. So the Social Health Authority has then the middle fund, right? We've talked about the Primary Healthcare Fund and we've talked about the ECCI fund. Now, the middle fund, the Social Health Insurance Fund, is a contributory fund. And this is the fund where you and I, as Kenyans, contribute into it, and then we're able to get benefits, particularly secondary care benefits. Now, this fund perhaps is what would mimic to the previous NHIF. And so even just by barely looking at the design of the current reform and what was underway in the previous administration, you can see that this government has been deliberate about primary health care, has been deliberate about emergency care. Now, in the middle fund, the Social Health Insurance Fund, in the lifetime of NHIF, the highest collections that NHIF ever received from the national scheme. If you remember the old national scheme, this is what Kenyans would pay into, which was about 500 Kenya shillings. The highest collections that were ever done then, just for the national scheme, was about 40 to 45 billion. Now, NHIF also ran other schemes, many other enhanced schemes. There were about 88 other enhanced schemes. And so if you look at the financial statements of NHIF, you'll notice that perhaps towards the end of NHIF, their collections were around 80 billion, 70-something billion, thereabouts. SHA, in 17 months, has been able to have collections of 203 billion. Just let that sink. From 88 billion to 203 billion. And I always like to emphasize to Kenyans, this is not old money. This is new money that has been invested in our healthcare services. And so by any measure, this is a positive move in the right direction. All the packages that were there prior to NHIF, SHA has improved and marked them up almost by 12 to 20%, depending on the different packages of care. And additionally, we have introduced primary health care, we've introduced emergency care. I always say, without fear of contradiction, this investment is good for Kenyans. This program is good for Kenyans. Do we have teething issues? Yes, like any new program. As you know, right now we are fully implementing a fully digital system. It means our digital infrastructure needs to be mature enough to do the same. And we are working towards that. We've seen gains. I always tell people, particularly partners who come and engage with the authority, we don't do any manual processing. NHIF, if you went to the former NHIF branches, and I have all those documents, you'd see folios of paper. A claim was this big. And a claims officer in NHIF had to go through the manual file. My claims officers do not do anything manually. There is no paper. Everything is within a digital system. And again, that's an improvement. So for me, we have demonstrated impact in just 19, 20 months and shall continue to harness more impact. There are things that we want to improve upon as we continue doing this. We want to look at ICU care further. We want to look at newborn care further. We want to perhaps even extend the packages for newborn cares. We know preterms will be in the neonatal unit for sometimes up to a month. Right now we do reimbursements of 12 days. So we want to see how we extend that further. But at the end of the day, the construct of this reform is robust and it is supportive of ensuring that Kenyans have better health outcomes. My name is Dr. Masi Mwangangi, and I'm the Chief Executive Officer of the Social Health Authority. And I'm pleased to be able to engage with you today to share with you the impact that the Social Health Authority has had on Kenya and the citizens. And perhaps where we start is by looking at what was there before, trying to understand what was there before, and then why we're doing what we're doing right now, and why we have reforms that have led to the creation and implementation of the.
Najisikia. Check 1 2. Mic check 1 2. 1 2 2 1 2. Check 1 2 1 2 1 2 1 2 1.
Marked them up almost by 12 to 20%, depending on the different packages of care. And additionally, we have introduced primary health care, we've introduced emergency care. I always say, without fear of contradiction, this investment is good for Kenyans. This program is good for Kenyans. Do we have teething issues? Yes, like any new program. As you know, right now we are fully implementing a fully digital system. It means our digital infrastructure needs to be mature enough to do the same. And we are working towards that. We've seen gains. I always tell people, particularly partners who come and engage with the authority, we don't do any manual processing. NHIF, if you went to the former NHIF branches, and I have all those documents, you'd see folios of paper. A claim was this big. And a claims officer in NHIF had to go through the manual file. My claims officers do not do anything manually. There is no paper. Everything is within a digital system. And again, that's an improvement. So for me, we have demonstrated impact in just 19, 20 months and shall continue to harness more impact. There are things that we want to improve upon as we continue doing this. We want to look at ICU care further. We want to look at newborn care further. We want to perhaps even extend the packages for newborn cares. We know preterms will be in the neonatal unit for sometimes up to a month. Right now, we do reimbursements of 12 days. So we want to see how we extend that further. But at the end of the day, the construct of this reform is robust and it is supportive of ensuring that Kenyans have better health outcomes.
My name is Dr. Omar Al-Bush. I'm Director Health Sector Coordination and Intergovernmental Relations in the Ministry of Health, State Department for Public Health and Professional Standards. my role is really health diplomacy. So as part of our role, we really coordinate, the health sector, under the leadership of the ministry. And we initially act as the secretariat of this summit because we are the one who really work with the different departments, different agencies, and different levels of governments. So we were the ones who initiated the secretariat, set up the secretariat, and of course now the secretariat is bigger, mostly working under our directorate and also the administration directorates, which are helping in planning and organizing this event. So I think it's really for us playing a key role in bringing the different stakeholders, making them aware, and mobilizing resources, and trying to make sure everybody is engaged in this summit. So for us as a coordinating directorate, we support the leadership of the ministry to drive the agenda of reforms towards achieving UHC. This includes the agenda of digitization, the social health insurance, the emergency and chronic care fund that was yesterday launched by His Excellency the President, and also any initiative that involves external partners and internal partners. So my role really is to make sure that the national government, the county governments, the partners, the stakeholders, both local and international, are speaking with one voice when it comes to the reforms for UHC. They are all aligned. They are all looking at working together in a collaborative manner to achieve this agenda of universal health coverage for Kenya. The Health Summit really is a platform where we showcase Kenya's achievement and success stories, and of course challenges in the journey to universal health coverage. Our country has implemented immense number of reforms within a short time in the last 4 years, including legal framework, and of course mobilizing resources, government resources towards the journey to universal health coverage. So we've seen immense contribution from, of course, the public sector, and also goodwill from other government agencies and partners to ensure that their journey to universal health coverage is on track. On 18th and 19th of August, we are going to showcase that to tell Kenyans what we have achieved, what is yet to be done to make sure that the journey is completed and that every Kenyan has access to quality and reliable health services without financial constraint.
My name is Dr. Patrick Amoth. I'm the Director General for Health. I welcome everybody to the Kenya Health Summit 2026, an event where we are going to showcase the progress that we have made as a country, strengthen our partnerships with everybody, partnerships and collaboration with all stakeholders, show the progress that we have made, the gaps that require to cover, and collectively move forward as the clock ticks towards 2030 Sustainable Development Goal agenda. Data is the new world currency, and we are happy to note the progress that we have made as a country to be able to strengthen the digital ecosystem for us to be able to make quick decisions, to be able to inform our policies. We have moved from paper-based systems to a situation where you go to our level 2, level 3 facilities fully digitized. Our community health system is fully digitized to the electronic community health information system. So we can be able to collect information from the household level to the facility level to the national level to be able to quickly take decisions. We are proud of the work that has been done by the Digital Health Agency in terms of digitizing our entire health ecosystem. For example, since we launched the social health insurance, we know, for example, the mothers who have delivered from October 2024, we know them by name, by ID number, by telephone number, by sub-county, the outcome of that pregnancy in terms of whether the child was born alive, whether the mother survived. So we are moving away from the periodic surveys that we used to undertake every 5 years, basing our decisions on past events to real-time decision-making based on real-time data that we generate on a day-to-day basis. Africa's continent experiences more than 100 public health emergencies every year, costing us huge amounts of money, disrupting our health systems, disrupting our economies, making us lose not only lives, but also livelihoods. Lessons learned from COVID-19 really taught us key interventions that we needed to put in place. As a result of that, we have strengthened our surveillance system. We have rapid response teams in place. We have increased our diagnostic capacity. For example, when COVID came in 2019, the first specimen that we picked, we had to ship it to South Africa. We have capacity now, literally in all the 47 counties, to be able to identify the novel or new generation pathogens. And we have also built capacity in terms of risk communication, community engagement. In terms of the ongoing Ebola outbreak in DR Congo and Uganda recently, the World Health Organization did an assessment at the beginning of the outbreak, and we assessed at 66%. Based on the investments we have made in the past 2 months, a recent assessment that was undertaken towards the end of July placed at 90%. So I'm very, very confident that the measures that we have put in place will not only be able to prevent us, save lives, help us save lives, but also help us in saving livelihoods. Preparedness is critical not only for population health, but also for our economies, to ensure that our business continue, our schools continue to operate, and therefore not only to be able to protect our health, but also to protect our economy and protect the global community. The journey towards universal health coverage is to ensure that no one is left behind. No one can be able to do this job alone anywhere else in the world, and therefore partnership is critical. The partnership that we have established between the national and county governments continues to deliver results. Our development partners continue to invest in us so that we can be able to move the needle so that we have better outcomes in terms of health and therefore better population health. We continue to embrace partnerships not only for financial support, but also for technical support in terms of the interventions that we need to put in place to be able to improve the health of our people. In this time and era when there is declining overseas development assistance, then it becomes even more imperative that we strengthen our partnerships, optimize the limited resources that we have, make the right investments for maximum results, ensure communities, families, communities, and societies are behind each and every policy that we make to be able to improve the health of Kenyan people.
Thank you very much for having me. And I believe that health is progressive. Countries that have made much progress in the healthcare sector, they have built it over years. With a light foundation, they continue adding over time. The benefit of SHA they are giving for services in terms of entitlement will also grow. We never had emergency in this country, ever, since independence. This president have done a very serious thing. They have provided every Kenyan a right to access emergency services. We never used to cover the issues we are talking about, the 3 areas I have told you about, right? When you look at ICU, we used to, NHIF was not paying anything. I say SHA began by paying 4,000. Now they are paying 28,000 per day. That is progressive. That is growth. So as SHA perfect ability to collect resources and mobilize more, benefits will actually increase. And therefore, we will head up to a level where it will be optimum that when you have SHA, you walk in and walk out of the hospital without having to pay anything. That is where we are going. It is doable.
we have come the wrong way. The remaining things are what, through the leadership of the president, who is very committed actually to seeing Kenyans' health improve and have no financial strain and improve access. This one, I believe he will be able to achieve it. And then, because he also has time, it's first time he has laid the right foundation. We have started seeing the benefits. By the time we are finishing his second term, people will look at the Kenyan healthcare system, they will not know it. But I also want to challenge you. Talk to people outside who are trying to change and improve their healthcare systems. Ask them about the success of Kenya. Ask them about the milestone done here. It has not been seen in very many places in the world. What determination can do, what political goodwill can do, what a team that is willing to actually see real change can do.
My name is Dr. Nazila Ganatra. I am the Director for Health Products and Technologies at the Ministry of Health. So the Directorate normally deals with basically the policy developments, technical assistance to counties, and also capacity building of healthcare workers. So the reforms that have now taken place, one of them is digitization, and it is really playing a very critical role in this area of health products and technologies, because we are able to use the National Logistics Management Information System, and that is able to track the data well, so that we can be able to quantify the commodities, leading to adequate supplies, so that there are no stockouts, there are no expiries, and they're not overstocked as well. So that is one of them. And the second issue that in digitization that we are actually implementing with the assistance of the DHA, that is the Digital Health Authority, is the track and trace system in conjunction with the Pharmacy and Poisons Board as well. And this is a system that will be able to enable us track a medicine from the manufacturer right to the consumer, that is the patient. And in between, we'll make sure that these drugs are safe, effective, and available for use for our clients. And we can be able to also ensure that these medicines are genuine, basically. We are strengthening our forecasting and quantification, and by that we are ensuring that we train the pharmacists and pharmaceutical technologies and all healthcare workers who deal with the supply chain, and that will of course enhance the forecasting and quantification of the commodities. Secondly, we have developed several policies, one of them being the oxygen policies, oxygen guidelines, and policies regarding the oxygen has been developed to ensure that we have safe availability of oxygen, and we know that that was quite a problem during the COVID-19. However, we have ensured that that has been working in progress. The other very main thing that we have been doing is His Excellency the President is the local manufacturing champion, and since 2024, we have been really actively working to ensure that we have safe, affordable, accessible commodities for health security and job creation as well. So in 2024, we were able to do capacity assessment of our local manufacturers, and earlier this year, we launched our local manufacturing strategy, which is an ambitious strategy to ensure that we are able to up our own local manufacturing of our commodities from the current 30% to at least 80% by 2030. And this will ensure job security and also commodity security during normal times and also during health emergencies. We also very closely work, our directorate also deals with the traditional and alternative medicine. And we know that our Kenyan population do use traditional and herbal medications, about 70% of them. So we are working on a policy to ensure that we are able to ensure that these herbal and traditional complementary medicines are actually safe and effective for use and are able to also be incorporated into our social health authority. So that is work in progress. And we are also going to ensure that there is adequate training and recognition of these cadres as well. We also develop policy documents that I had mentioned earlier, such as the Kenya Essential Medicines List, Diagnostics List, Supplies List. And these lists are very important because they show us the minimum, or they really reflect the minimum amount of drugs that can be able to be used at any one time at different levels of the facility. And we do so every 2 years. We update it every 2 years. So we are still in the process of updating it. And we are also developing or reviewing the development of our pharmaceutical health policy. The last one was done in 2012. So we are on track to review that as well, to be more futuristic in the pharmaceutical sector and in the health products and technologies continuum as well. We know that AI is coming up as one of the major innovations, especially in health technologies, and therefore we want to ensure that our policies speak to that and also really push to ensure that we onboard the local manufacturing agenda as well.
In 2022, the government committed to making quality healthcare accessible and affordable to every Kenyan. That commitment was translated into 4 landmark laws enacted in 2023. The Social Health Insurance Act, the
My name is Dr. Nazila Ganatra. I am the Director for Health Products and Technologies at the Ministry of Health. So the Directorate normally
My name is Dr. Kelly Olwach.
My name is Dr. "35% of our resources in the healthcare system have been from donors. And as you know, donations is a thing of the past. Many countries are reviewing their healthcare policies, especially foreign assistance. We know Germany, which was giving money to Kenya through GIZ, pulled out of the healthcare sector. Danida, which is from Denmark, is ending in the next 6 months. In fact, I just signed their last check for financing. We know what happened when the US government issued the stop work order and subsequently, at least for Kenya, using our friendship and bilateral engagements, we have reintroduced a new program, but even that is just for 5 years. FCDO, which is what the United Kingdom have used, the Foreign Common Development Organization, has deprioritized health. In fact, they are only having 2 years before they also pull out of health. Basically, in a nutshell, I'm saying that any country, and Kenya in specific, must look at how do you resource your healthcare system. No one is going to be somewhere waiting for you to showcase them. These your people who are suffering because of malaria or HIV or hunger. The world is no longer a warrior kind of system. So you must resource mobilize. And we are better off putting up a very robust system to resource mobilize. That is the entire reason why the Social Health Authority is a do or die. And that is why His Excellency the President has been keen to ensure that we put in the necessary infrastructure to ensure that SHA reaches every citizen. And the way that that is working is we put in money through taxes, and that tax goes through the primary healthcare fund, and then we also put in money on the diseases that even if you are very rich or employed, you will get poor when you start paying for them for yourself. Even if you're employed and you have to pay for dialysis in a year, you will spend 1.2 million. So government pays for that. Government pays for cancer. Government pays for emergency. You saw the ambulance set up at SHA. So health financing, and that's a key agenda of the reform. Number two is the health workforce. You know, you can have all the money, you can put in the building, you can put in the CT scan, the MRI, but the healthcare worker must be able to use all of these things to treat you. "35% of our resources in the healthcare system have been from donors. And as you know, donations is a thing of the past. Many countries are reviewing their healthcare policies, especially foreign assistance. We know Germany, which was giving money to Kenya through GIZ, pulled out of the healthcare sector. Danida, which is from Denmark, is ending in the next 6 months. In fact, I just signed their last check for financing. We know what happened when the US government issued the stop work order and subsequently, at least for Kenya, using our friendship and bilateral engagements, we have reintroduced a new program, but even that is just for 5 years. FCDO, which is what the United Kingdom have used, the Foreign Common Development Organization, has deprioritized health. In fact, they are only having 2 years before they also pull out of health. Basically, in a nutshell, I'm saying that any country, and Kenya in specific, must look at how do you resource your healthcare system. No one is going to be somewhere waiting for you to showcase them. These your people who are suffering because of malaria or HIV or hunger. The world is no longer a warrior kind of system. So you must resource mobilize, and we are better off putting up a very robust system to resource mobilize. That is the entire reason why the Social Health Authority is a do or die, and that is why His Excellency the President has been keen to ensure that we put in the necessary infrastructure to ensure that SHA reaches every citizen. And the way that that is working is we put in money through taxes, and that tax goes through the primary healthcare fund, and then we also put in money on the diseases that even if you are very rich or employed, you will get poor when you start paying for them for yourself. Even if you're employed and you have to pay for dialysis in a year, you will spend 1.2 million. So government pays for that. Government pays for cancer. Government pays for emergency. You saw the ambulance set up at SHA. So health financing, and that's a key agenda of the reform. Number two is the health workforce. You know, you can have all the money, you can put in the building, you can put in the CT scan, the MRI, but the healthcare worker must be able to use all of these things to treat you. "35% of our resources in the healthcare system have been from donors. And as you know, donations is a thing of the past. Many countries are reviewing their healthcare policies, especially foreign assistance. We know Germany, which was giving money to Kenya through GIZ, pulled out of the healthcare sector. Danida, which is from Denmark, is ending in the next 6 months. In fact, I just signed their last check for financing. We know what happened when the US government issued the stop work order, and subsequently, at least for Kenya, using our friendship and bilateral engagements, we have reintroduced a new program, but even that is just for 5 years. FCDO, which is what the United Kingdom have used, the Foreign Common Development Organization, has deprioritized health. In fact, they are only having 2 years before they also pull out of health. Basically, in a nutshell, I'm saying that any country, and Kenya in specific, must look at how do you resource your healthcare system. No one is going to be somewhere waiting for you to showcase them. This your people who are suffering because of malaria or HIV or hunger. The world is no longer a warrior kind of system. So you must resource mobilize, and we are better off putting up a very robust system to resource mobilize. That is the entire reason why the Social Health Authority is a do or die, and that is why His Excellency the President has been keen to ensure that we put in the necessary infrastructure to ensure that SHA reaches every citizen. And the way that that is working is we put in money through taxes, and that tax goes through the primary healthcare fund, and then we also put in money on the diseases that even if you are very rich or employed, you will get poor when you start paying for them for yourself. Even if you're employed and you have to pay for dialysis in a year, you will spend 1.2 million. So government pays for that. Government pays for cancer. Government pays for emergency. You saw the ambulance set up at SHA. So health financing, and that's a key agenda of the reform. Number two is the health workforce. You know, you can have all the money, you can put in the building, you can put in the CT scan, the MRI, but the healthcare worker must be able to use all of these things to treat you. "35% of our resources in the healthcare system have been from donors. And as you know, donations is a thing of the past. Many countries are reviewing their healthcare policies, especially foreign assistance. We know Germany, which was giving money to Kenya through GIZ, pulled out of the healthcare sector. Danida, which is from Denmark, is ending in the next 6 months. In fact, I just signed their last check for financing. We know what happened when the US government issued the stop work order and subsequently, at least for Kenya, using our friendship and bilateral engagements, we have reintroduced a new program, but even that is just for 5 years. FCDO, which is what the United Kingdom have used, the Foreign Common Development Organization, has deprioritized health. In fact, they are only having 2 years before they also pull out of health. Basically, in a nutshell, I'm saying that any country, and Kenya in specific, must look at how do you resource your healthcare system. No one is going to be somewhere waiting for you to showcase them. These your people who are suffering because of malaria or HIV or hunger. The world is no longer a warrior kind of system. So you must resource mobilize, and we are better off putting up a very robust system to resource mobilize. That is the entire reason why the Social Health Authority is a do or die, and that is why His Excellency the President has been keen to ensure that we put in the necessary infrastructure to ensure that SHA reaches every citizen. And the way that that is working is we put in money through taxes, and that tax goes through the primary healthcare fund, and then we also put in money on the diseases that even if you are very rich or employed, you will get poor when you start paying for them for yourself. Even if you're employed and you have to pay for dialysis in a year, you will spend 1.2 million. So government pays for that. Government pays for cancer. Government pays for emergency. You saw the ambulance set up at SHA. So health financing, and that's a key agenda of the reform. Number two is the health workforce. You know, you can have all the money, you can put in the building, you can put in the CT scan, the MRI, but the healthcare worker must be able to use all of these things to treat you. "35% of our resources in the healthcare system have been from donors. And as you know, donations is a thing of the past. Many countries are reviewing their healthcare policies, especially foreign.
Hello, sound check. Daktari.
Good afternoon, colleagues. I would like to make a few announcements. First, I'm in UHC session. We are heading directly to breakout sessions now. This room will be used by the health products and technology breakout session. So we'd like to proceed with the health products and technology breakout session. For if you are interested in the other breakout sessions, you can proceed to the other breakout sessions. But this one now has transitioned effective immediately to the health products and technologies breakout session.
Assistance. We know Germany, which was giving money to Kenya through GIZ, pulled out of the healthcare sector. Danida, which is from Denmark, is ending in the next 6 months. In fact, I just signed their last check for financing. We know what happened when the US government issued the stop work order and subsequently, at least for Kenya, using our friendship and bilateral engagements, we have reintroduced a new program, but even that is just for 5 years. FCDO, which is what the United Kingdom have used, the Foreign Common Development Organization, has deprioritized health. In fact, they are only having 2 years before they also pull out of health. Basically, in a nutshell, I'm saying that any country, and Kenya in specific, must look at how do you resource your healthcare system. No one is going to be somewhere waiting for you to showcase them. This your people who are suffering because of malaria or HIV or hunger. The world is no longer a warrior kind of system. So you must resource mobilize, and we are better off putting up a very robust system to resource mobilize. That is the entire reason why the Social Health Authority is a do or die, and that is why His Excellency the President has been keen to ensure that we put in the necessary infrastructure to ensure that SHA reaches every citizen. And the way that that is working is we put in money through taxes, and that tax goes through the primary healthcare fund, and then we also put in money on the diseases that even if you are very rich or employed, you will get poor when you start paying for them for yourself. Even if you're employed and you have to pay for dialysis in a year, you will spend 1.2 million. So government pays for that. Government pays for cancer. Government pays for emergency. You saw the ambulance set up at SHA. So health financing, and that's a key agenda of the reform. Number 2 is the health workforce. You know, you can have all the money, you can put in the building, you can.
Ladies and gentlemen, kindly, we are waiting for us to settle down so that we can start our session. And I want to acknowledge that the panelists and the discussants are with us. So I seek your indulgence, those who are still standing, kindly may we take our seats so that we save on our afternoon session. We've had a very nice morning, starting with our program and also the CHPs. And now we want to go deeper into policy issues and also case studies, not forgetting learning from examples, good examples. So I'm requesting those who are still outside, you're part of the session, come in and take your seat. As we start our afternoon session, we're behind schedule with like half an hour, but I'm double sure we'll be able to handle it well. So I'll invite our afternoon session moderator to take stage so that we can start our afternoon session. Daktari, kindly.
Thank you very much. I think we are about to start the HPT session. I can see the team preparing themselves. Dr. Wesley from BioVax and the team, I think I can invite you now to come and start the session. For those who are not familiar with the phrase HPT, it means Health Products and Technologies, which is Madawa. We apologize for the delay, but we are about to start now.
Good afternoon. So we apologize for the delay. My name is Wesley Rono, I'm CEO Kenya Biovax. I'll be chairing this session
Health.
on health products and technologies. So you'll give us about 2-3 minutes as we set up our some of the videos that we'd like to start off with. But just to say, it's going to be an interesting session for health products and technologies, and it builds onto the sessions that we had in the morning, where we would like to show some of the progress that has been made. We know very well that when you go for healthcare, one of the things, a measure of healthcare, is whether, of course, you receive you see a doctor, but at the end of the day, is whether you also receive medication. So this session, we would like to show the progress that we have made in improving access to health products and technologies in the country, in terms of not only being accessible, but also the questions around affordability, the questions around quality and safety. During this session, we'll have actors in the public sector, starting from where the products are developed, that's the research institutes, KEPRI, and then how these products then move to manufacturing, and then to the supply chain, and finally to health facilities and to households and the patients. So we'd like to show how this ecosystem has been strengthened in the last 4 years, and addressing the challenges that have been made and the tremendous progress that has been made. Access to medicine and health security is not only accessing those medicines from outside the country, but also building the capacity of the country in terms of producing these products. So again, as we go through this session, we'll also show the progress that we have made as a country in setting up the necessary infrastructure to produce medicines within this country. There are lessons learned during COVID-19 in terms of supply chain disruptions. So the country has built resilience in terms of producing medicines within the country, but also being part of supporting the continent in producing these medicines, because the continent depends heavily on imported medicines. So that's key. And to set off this whole session, we have lived experiences that will be shared. We'll also have panel discussions. We'll also demonstrate some of the work that our institutions are doing. So we'll be starting off, of course, with a keynote address, and then we'll also share some videos which we think will provide more context on what the work that we are doing. But what is very important is, for this session, is for the citizens that are part of this, those who are not in the health sector, and you would like to know what the health sector is doing, we want to welcome questions. And you heard the minister saying that we are here today and tomorrow to respond to the citizens, to their concerns, to the challenges that they face. And so part of this session is also an exchange between the ministry and also the citizens, and what we have, the progress that has been made, but also what needs to be done better. So we'll be starting shortly, but Rabera, are we ready with the videos? Okay, good. So I think, where did my chat disappear to, Rabera? Yeah, I think I have explained, but just to highlight very briefly the context of this session. So how do products move from the labs to the patient? And who are the actors? Public sector actors, private sector actors, and you'll see that PPP does the overarching regulatory role. One of the big questions that citizens have is, am I getting a quality product that is comparable to any other part of the world? So that's the role of PPP. So this chart just highlights some of this, what we'll be sharing today. So just to start off, this is how we'll run the session. So we'll have a background video, and then we'll then invite our keynote speaker, who is the governor of Kilifi, And then we'll have presentations from PPP and National Quality Control Lab. And then we'll also have a lived experience video, and then a panel discussion. So I'll now welcome our keynote speaker, but before he comes, I would like to share with you his, just a second, I'd like to share with you his profile, a very rich profile. Give me. Could you send me? You'll send me, right? Yeah, no, it's okay. Let me just get it. Could you send me again? Okay. Has it come? Okay. Okay, that's fine. Yeah. Yeah. So please, those who are seated behind, please come nearer. We'd like to have a close interaction. So apologies. I just wanted to be very to be careful to introduce you properly. So His Excellency Honorable Gideon Maita Mung'aro is the governor of Kilifi County, elected in August 2022, a distinguished statesman and seasoned public servant with over 2 decades of leadership experience. The governor is widely recognized for his people-centered approach to governance and his unwavering commitment to delivering measurable development outcomes. Born and raised in Kilifi, he began his public service journey as the mayor of Malindi municipality before being elected member of parliament for Malindi in 2007. During his parliamentary career, he served as a chief whip in coalition government, chairperson of parliamentary committee on lands and natural resources, and the chairperson of Eastern African region at Pan-African Parliament. Since assuming office as governor, has placed healthcare transformation at the heart of his administration, leading one of the most ambitious health sector modernization programs in Kilifi history. His government has expanded and modernized health infrastructure through construction of maternity wings, ICU, HDU units, operating theaters, and upgraded outpatient facilities. His administration is also spearheading digitization of healthcare through fully paperless hospital systems, while strengthening emergency response services and forging strategic partnerships with national government and international partners. Beyond healthcare, Governor Mung'aro is driving broad socio-economic transformation in key sectors across agriculture, youth, women, and industrialization, special economic zones. He holds a degree in business management and has undertaken advanced leadership on governance, training, and locally and internationally. There's a quote that he has, leadership is not measured by promises we make, but by the lives we transform. Indeed, we are privileged to have you, Your Excellency, because I know Kilifi is home to Revital, which is a leading manufacturer in Kenya, and also the oxygen plant. So, karibu sana. Yeah, I think I can go straight. Yeah. Welcome.
Thank you. Thank you. Good afternoon, everybody. thought a CS was going to be here. I believe there are few of my colleagues around. Any governor around? I've seen one of them. None. Okay. I don't know if the principal secretary is there, but the county executive committee members of health present, representative of regulatory, research and manufacturing institutions, development and implementing partners, representatives of the private sector and academia, health professionals, distinguished delegates, ladies and gentlemen. Good afternoon. Let me begin with a question. My remarks will be really in point form, but I want to begin with a question. What if next life-saving machine, diagnostic, or medical device used across Africa were researched, manufactured, and supplied from Kenya? This is no longer simply an aspiration. It is an achievable national objective, one that can strengthen health security, create skilled employment, advance research, and ensure that essential products reach our people when they need them. For decades, Africa has exported its ideas, talent, and raw materials while importing many of the medicines, diagnostics, and medical devices required to protect its population. COVID-19 exposed the risks of that dependence when global supply chains were disrupted and countries competed for limited essential products. The lesson was clear. A country that cannot secure essential health products cannot fully secure the health of its people. Distinguished delegates, health products and technologies must be understood as one connected national ecosystem. From research and innovation through regulation, manufacturing, procurement, and distribution to the patient at the last mile. Kenya already possesses important parts of this ecosystem. Our research institutions and universities generate knowledge and develop innovations. Our regulatory agencies protect quality and safety. Local manufacturers are building production capacity, while KEMSA county supply system and healthcare facilities connect products to patients. Our challenge is that these paths do not always operate as one continuous pathway. Promising research can remain in laboratories. Manufacturers may face uncertain demand. Regulation can take longer than innovation cycles. And products may still fail to reach facilities on time. The future we must build is one in which an idea developed by a Kenyan scientist can be validated, regulated, manufactured at scale, procured sustainably, and used to save a life in any county. This requires deliberate collaboration between the national and county governments. The national government provides policy, standards, regulation, national procurement frameworks, market shaping instruments, and support for research and industrial development. Counties provide the environments in which investment takes place and products are ultimately used. They can provide sustainable land, infrastructure, investment facilitation, skilled local workforces, reliable demand information, and the health facilities that connect products to patients. Our responsibility may be different, but our objective is one: to guarantee that every Kenyan has timely access to safe, effective and affordable health products. Ladies and gentlemen, several counties are already demonstrating what is possible when research, government, and industry work together. Kilifi hosts the KEMRI Wellcome Trust Research Program, whose work in malaria, pneumonia, vaccines, health systems contributes to policy and clinical practice in Kenya and beyond. The county also hosts Revital Healthcare EPZ, which has developed the capacity to manufacture approximately 2.1 billion medical devices annually and up to 20 million rapid diagnostic tests each month. Synergy Gases, supported by partners, is establishing a liquid medical oxygen plant in Kilifi with the capacity to produce 13 tons daily. COVID-19 reminded us that oxygen is medicine and that domestic production can become the difference between dependence and preparedness. These investments are not important only to the counties in which they are located. Their products can serve facilities across Kenya, support regional emergency preparedness, and supply markets throughout Africa. Other counties possess different comparative advantages. Some have strong universities and research institutions. Others have established industrial parks, transport corridors, pharmaceutical expertise, agricultural inputs, or renewable energy that can support manufacturing. We should not create 47 isolated healthcare manufacturing strategies. We should build one national ecosystem in which counties contribute according to their comparative strengths and share in the resulting investment, jobs, and improved access. Distinguished delegates, for this ecosystem to thrive, Kenya must connect innovation to industry more deliberately. Research funding should consider product development and commercialization. Training institutions should respond to emerging needs in biotechnology, engineering, quality assurance, manufacturing, and supply chain management. The Pharmacy and Poisons Board must provide efficient, predictable, and credible regulation while maintaining rigorous standards of quality, safety, and effectiveness. Regulatory reform must facilitate innovation without compromising the protection of patients. Nationally and county procurement systems must also give manufacturers clear and predictable demand signals. Transparent purchasing, timely payment, and appropriate preference for quality-assured local products can give investors the confidence to establish and expand production. KEMSA and county supply systems must then ensure that products reach facilities before shortages occur. A product researched and manufactured in Kenya has not fulfilled its purpose until it reaches the health worker and patient who need it. This is why the last mile remains the true test of the entire HPT ecosystem. The medicine must reach the dispensary, the diagnostic must reach the laboratory. The device must function in the facility and the oxygen must reach the bedside. Ladies and gentlemen, looking ahead, Kenya should aspire to manufacture a growing share of its essential medicines, vaccines, diagnostics, medical devices, and other health products. This will reduce exposure to global supply disruptions, conserve foreign exchange, and strengthen our capacity to respond to future health emergencies. It will also create skilled employment for young Kenyans, support technology transfer, expand research, and position our country as a regional center for health, innovation, and manufacturing. Achieving this future will require one coordinated national plan with clear roles for ministries, counties, regulators, research institutions, manufacturers, investors, and healthcare providers. Development partners should reinforce this common framework and help build capabilities that remain after individual programs end. Local manufacturing is not merely an industrial ambition. It is a health security imperative, an economic opportunity, and a foundation for national self-reliance. Distinguished delegates, let this session help us design a future in which national policy enables country opportunity, country innovation, strengthens national capacity, and public investment creates both better health and wider economic prosperity. Let us build a Kenya that does not wait for the world to supply every essential product, but one that possesses the confidence and capability to discover, regulate, manufacture, and deliver for itself and for Africa. From the laboratory to the factory, and from the factory to the last mile. If we make it together, we can protect lives everywhere. Asanteni sana na Mungu abariki na Mungu abariki Kenya. Asanteni.
Thank you very much, Your Excellency, on your keynote address. I think he has highlighted key issues, and I think for Kilifi County is interesting because of the investments that have been able to attract. He has talked about the Revital, which not only produces for Kenya, but actually exports, and the oxygen plant that has been set up with very innovative financing mechanisms and off-take mechanisms. So lessons to learn. Wellcome Trust, KEMRI, has played a key role, especially on childhood diseases, pneumonia, the vaccines that we have, pneumococcal vaccines that we have. Some of the trials were done in Kilifi. So Kilifi has been a very, a good example of a county in terms of investments in healthcare, but also supporting the country to build resilience. The governor has also talked about the true test of the health system is when the products reach the patients, which is also true, which is very true. And I can also say that, we can only say health is a right if the medicines are able to reach the patient. So we'll continue with that. From that keynote address, we'll have colleagues from Pharmacy and Poisons Board and the National Quality Control Lab doing their presentation, mainly to highlight the work that they are doing around quality. How do they ensure quality across the entire ecosystem so that the medicines that reach you as a patient or your household is of assured quality. So we'll have our colleagues from NQCL stepping forward. So we have the PPP Director, Dr. Ocheng Okuta, and Mr. Jonah Piwot from the National Quality Control Lab. So I hope your presentations are set up. Who is connecting for you? Okay, fine. So you can go ahead.
And to the patient. Health is a right, and a right must be delivered, from the idea to the proof, to the shelf, and to the patient. This is the journey of Kenya's health products and technologies. It starts with a question that leads to research in search of answers.
We were able to show that one dose is enough, just one shot. The World Health Organization took this data, and late last year, they changed their recommendations to 1 or 2 doses for ages 9 to 20.
That's one lab, one disease. Across the country, other researchers are chasing different threats.
Now, KIPRE is Kenya Institute of Primate Research. This is biomedical research institute that has a mandate of improving human health by ethically utilizing non-human primates. In this country, over 20,000 Kenyans are bitten by snakes. And we have about 8,000 who suffer permanent disfiguration. Now, currently, all the antivenoms that are being used, because when you're unlucky to be bitten by a snake, what you are administered with to manage that is called an antivenom. Now, currently, all the antivenoms that are being used in the market are either from Europe or in India. So what we want to do is to use our own venoms here from our snakes and improve the efficacy rates.
But an idea alone doesn't protect a patient. Before it reaches them, it must be proven safe. Across Kenya, 57 million people trust that behind every medicine is a question already answered. Is it safe? The Pharmacy and Poisons Board regulates the professionals, the premises, and the products. Over 15,000 licensed pharmaceutical professionals and more than 11,000 licensed premises nationwide. Through market surveillance and pharmacovigilance, 1,413 quality complaints are reviewed. 99 products are recalled, over 32,000 adverse drug reaction reports assessed. New systems like Track and Trace and Practice 360 are following every product from source to patient. None of this works without somewhere to actually test the products.
So one of the things that we are doing as a country in Kenya is to ensure that these medicines, the ones that we import and even the ones that are manufactured in country, are tested for quality. And that is what the National Quality Control Laboratory does. So we are expecting that within the next 1 year or so, or shortly after, we should be able to have a lab that can now meet the standards of that demand of being able to produce vaccines and biologics and other things.
Regulation builds trust, but trust needs supply, and that supply must be made at home. During COVID-19, Kenya learned a hard lesson. The countries that survived were the ones who could make their own medicine. COVID-19 exposed a hard truth. The countries that could provide their own medicines were the ones best placed to respond.
So Kenya Biovax has been given this mandate to lead in terms of producing vaccines and biologics. Our target is to produce vaccines that are safe and of quality of international standards, especially for childhood immunization. The vaccines that we produce at Biovax is not only for Kenya, but it will also serve the continent.
Manufacturing is only half the story. The vaccine still has to get to the end user. 24 hours a day, 7 days a week. KEMSA keeps Kenya's health supply chain moving. Over 90,000 square feet of warehousing. Every product tracked. Every shipment secured with geographic information system-enabled logs and digital proof of delivery. From Nairobi to regional depots to every one of Kenya's 47 counties, bringing essential health products closer to the people who need them. It's not just medicines that need to reach communities. Specialized care does too. That's the work of the National Equipment Service Program NESP, taking specialized medical equipment and services out of major referral hospitals and into county and lower level facilities. Every machine installed, maintained, and kept running with vendors paid only for the services they deliver. The goal? Decentralized specialized care like radiology, surgery, and dialysis so patients can access it closer home. Research that asks the right questions. Regulations that protect every dose. Manufacturing that builds self-reliance. Delivery that reaches every county. This is how Kenya is reforming health products and technologies, one link in the chain at a time.
Good afternoon. So, Excellencies, distinguished delegates, ladies and gentlemen, my name is Wilfred Ochieng Oguta from Pharmacy and Poisons Board. I think my presentation should be all right. You can see it. I'm going to make a very brief presentation on the reforms that the Pharmacy and Poisons Board has undertaken, delivered to secure the health of the public. And I want to start by saying, picture this, if or when someone or Kenyan takes a tablet for a particular reason, the last thing they want to worry about is whether the medicine is genuine, whether it is safe, or whether someone has checked or is watching to confirm that everything is okay. They just want to get the problem solved. That is the responsibility that is behind the work of the Pharmacy and Poisons Board. That is what we do. So this afternoon, I want to highlight that we have one message for Kenyans. We want to deliver safe medicines, trusted care, and of course, towards achieving the right to health, the constitutional right to health. You can skip the outline. So the Pharmacy and Poisons Board makes 5 promises. Number 1, 5 reforms, 1 promise, that we deliver safer medicines. We have reliable access, trusted pharmacy care, skilled professionals, and continuous protection. Because behind every tablet, every vaccine, every injection is a system that the Pharmacy and Poisons Board has built, a system involving people, a system of standards, a system of technology, and safeguards that have been put in place to deliver this. And in the past 4 years or so, I want to share with you some numbers. You can go to the next. Oops. I don't have my slide here. Just a minute. So we have done stronger checks to improve the protection through inspection and surveillance. We have actually undertaken 43 recalls and safety alerts in the year 2025 alone. We have grown the number of registered pharmacy premises to over 10,000, delivering where quality services can be offered in this country. We have over 7,000 registered medicines available for the public. We have over 15,000 pharmacy workforce, pharmacy personnel that are considered competent and registered and licensed by the board to offer services. And the board has also introduced what we call track and trace, which is going to be rolled nationally, mandatory, to track medicines from the manufacturer to the patient. Now, distinguished delegates, these reforms or these numbers on their own do not mean anything. These numbers, if you look at the trend, it means that we are increasingly providing an environment where Kenyans are able to access safe medicines. They are able to get their medicines delivered by people who are qualified. And safe medicines alone, I want to highlight, is not the full story. Because if the medicines get in the wrong hands, then still, no matter how good or no matter what the quality of the medicines is, there's still the possibility of poor pharmaceutical care, poor services. And so the board has also put in place other mechanisms to make sure that people are safe. So, next slide, please. I've taken you through these numbers, and basically, these are reforms that we have put in place and what we have achieved to make sure that Kenyans are safe. If you look at the, I'm sorry, I didn't highlight this when the slide was up. In the last 5 years, the number of licensed personnel has gone up by up to 40%. This is a system which is supported from training, where you get the number of institutions that are producing quality graduates has increased. The number of people who are being licensed has increased. And that means to every Kenyan that services can now be provided closer to where they stay. Next slide, please. So, ladies and gentlemen, the impact of this is that having deployed technology, Kenyans can now make safer choices. From whichever part of the country where you are, you can actually verify the licenses that the board issues. You can verify if the person is registered. You can verify if the medicine that you have been given is actually registered. You can verify if the premises where you are getting care from is also licensed. And then the system called pharmacovigilance, which the board has put in place and is still strengthening, ensures that we are able to, people are able to report. You're talking about the patient can report, the professional can report, the manufacturer can report, and basically anybody can report any quality or any suspected substandard medicines. We have learned a few lessons. And one of the lessons we have learned is that regulation is a key transformation in delivery of healthcare, in the healthcare system. And it is something which this transformation is not an event, it is continuous. So what we are promising Kenyans as Pharmacy and Poisons Board is that we have grown in terms of what we are delivering over the past years, and we are still growing and strengthening those systems. You are aware that the Pharmacy and Poisons Board is also being assessed for maturity level 3 status. And in that process, I can assure you that we have done a lot to make sure that all the loopholes that were there have been sealed. The medicine we are getting into the market is safe. I want to talk about, before I conclude, I know time is running. In conclusion, Pharmacy and Poisons Board alone cannot run this journey. This journey requires collaboration. Collaboration because everybody has a responsibility, the patient. We have the industry and the professionals. And of course, we have partnered with other agencies, government agencies, Last month, the Cabinet Secretary launched an interministerial task force for combating substandard and falsified medicines. And with this, we hope that we are going to walk this journey together as we put the reforms to make sure that the medicines are safe, the care that Kenyans get is safe. Thank you very much, ladies and gentlemen. Have a good afternoon.
Thank you very much, my brother, Dr. Ogutu. For those who do not know me, my name is John Abiwat. I'm the head of biologics and vaccines testing at National Quality Control Laboratories. NQCL is established by State Corporation Act, Cap 244, Sections 35D, the Pharmacy and Poison Board. That's why you see us working together. NQCL is the technical arm of PPB. That's why wherever PPB are, we are also there. Please give me slide number 2. Safe medicine starts with quality testing. Every medicine should be safe, effective, and of high quality. Before medicines reach patients, they undergo rigorous laboratory testing to ensure they contain the correct amount of the active pharmaceutical ingredient, are free from harmful contaminants, dissolve and work as intended in the body, and that they meet the national and international standards. Of course, the national standards are established by PPB, and international standards are established by other organizations, including WHO. And by mentioning WHO, I wish to mention that NQCL is one of the very few laboratories in East and Central Africa that are pre-qualified by WHO for laboratory testing. Slide 2, please, 3. Quality, why quality testing matters? Quality medicines save lives. And one of the reasons why we do testing is to ensure that we detect poor quality, falsified and substandard medicines. And my brother from PPB has mentioned about those substandard medicines. It is our work to now do the testing to ensure that we detect such falsified and substandard medicines in the Kenyan market. To confirm that medicines are safe and effective, and they can actually prevent and treat, and also to ensure that cases of antimicrobial resistance do not exist. We also do testing to ensure that you build public confidence in the healthcare system, such that wherever a doctor is, a clinical officer, or a nurse, whenever they administer any drug, they are confident that that drug is going to work in that particular patient. And the patient is also confident that whichever medicine they are being given will actually work in their bodies. What do we test in our testing? Every sample undergoes scientific evaluation to ensure that we identify the correct medicine. If a particular medicine in their label claim has it that it contains a particular active pharmaceutical ingredient, it is our work to carry out a test to identify that indeed what is in the label claim is what is actually in the product. That is called identity test. There is what we call assay, which is evaluation of the content, the amount of content in any pharmaceutical ingredient or a vaccine. We also do a test called dissolution, which is actually an evaluation of how much content will be released by the medicine into the body. because when you take medicine as given by the medical professionals, that active pharmaceutical ingredient needs to be released so that it can function in the body. So we also carry that particular test in the lab. We also evaluate the uniformity of content. If, for example, you have a tablet and you are given, say, 10, 15, 20 tablets, each tablet needs to have the same amount of active content to an acceptable margin of error so that it can be able to work in your body. So we do also that test called uniformity either of content or uniformity of weight. We also carry out purity tests to ensure that health products do not have impurities. And so that's one of the tests that we do. And we also do what we call stability testing to ensure that the product will remain effective throughout its own shelf life. How medicines are tested? Give me slide 4. Quality is monitored throughout the medicine's life cycle. We have what we call pre-registration testing. That is the testing that is where a product is brought to the lab, and the lab here in the NQCL, and it is tested and a certificate of analysis is issued. The certificate of analysis can then be taken to Pharmacy and Poison Board for registration. That's what we call pre-registration testing. We also have what we call post-market surveillance. These are products which are brought from the market by PPB and they are taken to the lab, to NQCL for analysis. These are products which are actively being used in our Kenyan market, in the pharmacies, in the hospitals. We also do what we call pre-distribution testing. These are usually health products which are from outlets like our big brother, KEMSA, before they are distributed to the counties and the other medical facilities. There's usually a program whereby before those products are distributed, they are sampled and taken to the lab and tested to ensure that they comply to the required standards before they are distributed. And then we also carry out research and investigative testing to ensure that all products, including those which are under registration, will comply to the required standards. Or whenever there is any challenge in the market, products will always be taken to the lab for investigative research and investigative testing. We say at NQCL, we say your safety is our priority. And we say you can have confidence in the health products and technologies you receive because NQCL is there. Every day, scientists, pharmacists, analysts, and regulators work together to ensure medicine supplied in Kenya meet strict quality standards. Na promise to Kenya ni kwamba tutahakikisha kwamba mtapata dawa sawa na bora kwa Wakenya wote. Asante sana.
So thank you very much, colleagues from Pharmacy and Poison Board and NQCL. They have been able to share with us and assure us of the work that they are doing in the life cycle of medicines, right from R&D up to when it's delivered to the patient, and indeed post-delivery to the patient where they have pharmacovigilance. So I'm sure there'll be a number of questions, so I'll request the audience to hold on to that. There'll be, towards the end of this, our session, there'll be a time for Q&A. So we'll straight move on to a lived experience video, a patient story, because we said here we want to share stories from the healthcare providers, the manufacturers, and also the patient on their experience in terms of receiving healthcare and health products and technologies. So please, team, please put it ahead.
Kwa majina naitwa Harrison Mbulu, natoka Kitui County, Kitui East. Ilikuwa last year 19th April, nilikuwa kwa field nikilisha, ndio niliuma na bafada. After hapo nilikuwa niko peke yangu, so nilifunga mguu nikakimbia nyumbani. Kufika nyumbani nilikuwa na namba ya CHP, nikampigia simu, akakuja haraka na motorbike, akalengeza ile kitu nilikuwa nimefunga. After kulengeza, akapiga simu kwa facility, hiyo ni Mtomo Hospital, alafu akanipandisha kwa hiyo pikipiki ikanipeleka huko. Tayari alikuwa anashaongea na madaktari huko kwamba ana mgonjwa na anakuja.
Majina ni Augustine Kibuya kutoka Kitui County, Kitui South Constituency, Mudha Ward. Mimi ni community health promoter. Kazi yangu ni to educate the community members on matters related to health and referring them to health facility. Nimepatana na cases mingi kuhusu watu kuumwa na nyoka.
Nikitoka Mtomo nilikuwa naendelea vibaya. So by the time nilikuwa nafika Kitui, nilikuwa unconscious. Nikiwa hapo facility nilikaa wiki 3. So hizo wiki 3 mguu ulikuwa umefura sana na nilikuwa na blisters. So hizo blisters zilikuja zikapasuka. Ikakuwa sasa ni kidonda. Hiyo kidonda ndio ilikuwa inashughulikiwa for hizo 3 weeks. After hapo nikakuwa discharged. After kundischargiwa nikaambiwa niwe narudi hospitali after 2 weeks. So nilikuwa narudi. After wiki 2 wanaendelea kuniangalia vile mguu unaendelea. Hivyo mpaka nikapona.
Hiyo Kenya ikitengeneza hizo antivenom itapungua sana, kwa sababu katika mashinani wale watu wako huko ni wale wako poor. Kwanza ita lower the cost expense. Distance itakuwa short kwa sababu zitaenea katika mashinani, katika dispensary. Mtu akiumwa anaipata already karibu. Sasa hivi wanatembea sana, kuna challenge kwa sababu mtu anaweza tembea almost 10 kilometers kufikia hospitali, amekuwa unconscious.
Honestly, hapa Kenya tukikuwa na uwezo wa kutengeneza antivenom itasaidia sana, kwa sababu hii shida yote ya kwenda Mtomo nikapata ndawa moja, wakasema ndawa zimeisha, sasa mpaka niende Kitui, ni shida ya kukua. Hizi antivenom hatuna hapa Kenya za kutosha. Kwa hiyo kama Kenya tutakuwa tunatengeneza zetu, zitakuwa hata zinaweza fika hizo health centers za huko nyumbani, na hatutakuwa na shida ya kuwako from one place to another kuzitafuta.
Thank you very much. As you could hear from the patient, the wish is that we, as Kenya, we need to move towards manufacturing anti-snake venom. And I think the good news is that our sister institution, KEPRI, is actually in the process of doing that along with other partners. So make sure that as you, in these 2 days, you also visit their stand. They are doing some great work. And also visit some of the other institutions like PPP, Biovax, and others in the stands, and then you'll be able to hear more. So we'll move quickly to a panel session to be moderated by Dr. Wako, the CEO of KEMSA. So I'd like to invite him to come forward. Dr. Wako. Dr. Wako is here. He will then be able to take us through this panel session where we'll have, we'll go deeper into some of these discussions. Thank you. Welcome.
Yeah, list your what? You can use this one. And their portfolios and questions go up. Yeah. So it is this one. Local manufacturing. Yes. And then how to crisscross between introducing these people. Are they here? Really?
Yeah, you can call them.
Hmm?
You can call them.
You want me to call them for you? Local manufacturing and innovation. Okay. Okay. Yeah, thank you very much. I don't know, we are very dull and we are very far. Do you really want to be that stretched, or you can come here, then we contribute and bring some life to this? Members there, or is that another session? Please come forward. Let's come forward. Let's take 2 minutes to come forward, please. Just come forward. It will be helpful. There are many, many seats here.
Wakati nilisikia ni prostate cancer, nilijua sasa maisha yangu ni kaso. Nilikuwa na mama mkwe alikuwa hospitalini. Nilikuwa naenda kumtembelea. Nikaanza kwenda haja ndogo.
Yeah, so
mara nyingi ninamwacha, ninakimbia,
Oh, DJ, kidogo. Yeah, so thank you very much. Now we are going into local manufacturing. I think all of us know the value of local manufacturing to strengthen our Kenya, our country, so that we don't have to rely, very heavily. We'll never stop relying, but relying heavily on products from outside the boundaries of this country. You know what it means to have your own products, for that matter, not just products, high quality products in this country. That addresses quite a lot of issues. We'll have sustainability, we'll have availability, we'll have affordability, and of course, a lot of employment. And we'll not be relying on other countries where if some ports are closed, then we start suffering. Or the suffering we underwent when we had a COVID scare or COVID outbreak in this country, where other countries had to look at their citizens first before thinking about Kenya and African countries. So it is very, very important that we as a country get into a dialogue, get into a position, talk to ourselves seriously as we do these beautiful reforms and engage ourselves, because it is said Kenyans have the brain, they have the policies, they have the documents, the strategic directions to make these things happen. So we want to have the reality of having local produce of health products and technologies. So we have assembled for you a few top-level Kenyans, and not just Kenyans, and friends of Kenya as well, people we believe can add value to this discussion. And then we encourage you at the end of the talks to ask and engage and see how we can really improve our country in terms of having our products closer around. So I will invite a few eminent people to the stage. Then we'll ask them a question or two regarding local manufacturing and commodity security. Then when they answer those questions exhaustively, or if you have other issues to ask, then I'll give you opportunity to ask. So let's start with Odhiambo, Bwana David, Daktari David Odhiambo is the executive director. Are you here before I start reading a lot? If you are not here, let me know you are here before I read. He's not here. Okay. Let me get another panelist. Sorry, I have to. Let me start with the man seated here. Just 1 minute as my gadget opens. Dr. Wesley Rono, who was moderating the previous session, will now be a panelist. Dr. Wesley Rono is the Director General, the CEO of Kenya Biovax Institute. I think one of the pioneer manufacturing, public manufacturing units for the country alongside KEMRI. I think there are only two, including maybe now KEPRI will be told. So Rono is a pharmaceutical sector development expert and a business leader with over 25 years of experience advancing access to quality medicines and vaccines across Africa, not just Kenya. As the Director General and CEO of the Kenya Biovax Institute, he provides strategic and executive leadership in building a sustainable biopharmaceutical manufacturing ecosystem, strengthening Kenya's health security, and advancing the country's contribution to Africa's ambition to produce 60% of its vaccines locally by 2040. Previously, Dr. Rono led a market design and demand intelligence program at the Partnership for African Vaccines Manufacturing and at the Africa Centers for Disease Control and Prevention, the Africa CDC, focusing on market shaping, demand intelligence, and procurement mechanisms to support Africa-made vaccines and other health products and technologies. Dr. Rono has held advisory and leadership roles within organizations including the GIZ, the Africa Development Bank, COMESA, and UNCTAD. His expertise spans business leadership, strategy, pharmaceutical manufacturing, market development, and health innovation. Dr. Rono holds degrees in medicinal chemistry, business administration, and pharmacy. He loves reading very widely, which is very good, particularly books and articles on leadership, innovation, and Africa's development. Put your hands together for Dr. Wesley Rono, a very eminent Kenyan. Dr. Gerald Macharia, before I read, are you in the house? Oh, yes, sir. This is my boss for so many years. So Dr. Gerald Macharia, as he comes on stage, Dr. Gerald Macharia is currently the board chairperson for API for Africa. Gerald Macharia serves as the board chairperson for API for Africa, APIFA, a Nairobi-based Pan-African organization that works with pharmaceutical manufacturers to develop optimal solutions for technology transfer, capital sourcing, market shaping, and quality improvement. He previously served, this is important, as the Vice President for East and Southern Africa for the Clinton Health Access Initiative, CHAI, with responsibility for Kenya, Uganda, Tanzania, Rwanda, Malawi, Zambia, Zimbabwe, Mozambique, Eswatini, Botswana, South Africa, Namibia, and Lesotho. He worked for a number of multinational corporations, including Colgate-Palmolive, a Fortune 500 company, before becoming CEO at Faulu Microfinance Bank, one of Kenya's largest microfinance banks. He helped in the design and pilot of the M-Pesa mobile money system and floated Africa's first US $7 million microfinance bond on the Nairobi Securities Exchange. He holds an MBA from the Edinburgh Business School and another MBA from Moi University. He is also a Commonwealth Scholar in Strategy and an alumnus of Stanford University program on strategy and organization. He also served in various public sector governance roles in Kenya, key among them being the inaugural chairman of the Kenya National Public Health Institute in 2022. He also previously served on the board of the Social Health Authority. I think the accolades that belong to Macharia has really been made brief. He's more than that. But put your hands together for Dr. Macharia. The next speaker, Dr. Winifred. Is there Winifred? Are you the only two panelists? Dr. Winifred Odhiambo. He was to represent the Association of Manufacturers, I think. Yeah? Okay. He's not there, but our two gentlemen here will do. Dr. Madera. Madera, are you there? Dr. Gakombe is not here also. Dr. Gakombe? Rosemary Kihoto? So it looks like Dr. Odhiambo has come. What happened? Where? Tanazila? Am I ready? Oh, she has come. Where? Oh, I'm leaving tomorrow. Okay, where are the buyers? Professor David, this David Odhiambo is here? Oh, he has just come. Oh. Where is the list? I'll just write for you. Oh, they're here. Okay. Yeah, so I'm told Professor has come. Professor George Njoroge, you are now in the house. Hey. They gave me the wrong list. Okay. Where is this bio? You have it here. Bio, Professor. This one, let. So as we Professor, I don't have. So as we wait for Professor's bio, Dr. David Odhiambo, you are here. Thank you. As you come on stage, Odhiambo is the Executive Director, Africa Pharmaceutical Network. He doubles up as a Senior Advocacy and Public Policy Lead for the Federation of Kenya Pharmaceutical Manufacturers and the adjunct faculty at the United States International University. He's the chairperson of the Supply Chain Committee of the Kenya Health Care Federation. He has so many accolades. We may take a whole day reading it. He holds an MBA from Said Business School, University of Oxford, Bachelor of Pharmacy from JKUAT, a postgraduate certificate in project management, combining very well pharmacy, business, and project management. Put your hands together for Dr. Odhiambo. Karibu sana, Daktari. You have something, Professor? Where is Dr. Nani? Dr. Prof. I don't have Nani's. Dr. Nani should be here.
Dr. Ahmad, CEO.
Where is it?
Dr. Professor was the first one that you had.
Where's the list? Yep, sorry. Professor, I think your CV is so loaded that it couldn't fit in my phone. So, Professor, thank you for honoring us with your presence. Professor George Njoroge has a PhD. Professor is the Chief Scientific Officer at Kenyatta University Teaching and Referral and Research Hospital, and a former member of the Board of Directors at the KEMRI. He has chaired research and innovation committees of various organizations. He is currently the chairman of the council at Daystar University and a former board member of a company of KCA, KCA University, previously a senior research fellow at Eli Lilly and Company, and a former director in the Department of Medicinal Chemistry at Merck Research Laboratories, a very big laboratory, by the way, where he oversaw chemistry program in infectious diseases. He's done a lot of research He's a graduate of University of Nairobi, a first-class honors. Clap for him. First-class honors. He holds PhD in organic chemistry from Case Western Reserve University of the United States of America. He has authored many books and scientific journals, about 134 scientific publications, which were reviewed and published. So this is a very big milestone. He was inducted into the Hall of Fame as a hero of chemistry by the American Chemical Society in 2012. So he's a recipient of numerous awards, including the Emerald Award for Professional Achievement and Thomas Alva Edison Patient Award for Emerging Therapies and Distinguished Alumni. This is a very long CV. Let me just say, is now the founder of Center of Africa's Life Sciences, a premier institution that's being established in Naivasha. Thank you for making sure that we don't lose on this knowledge, and thank you for coming all the way. Professor, put your hands together for Professor. Sorry? For Dr. Ahmed. Where did you send? It has not come. Nazila Ganatra. Where unacheza na mimi? Aha, very good. So, another eminent Kenyan going by the name of Dr. Ahmed Mohammed, the CEO of Pharmacy and Poisons Board. Please come on board. Dr. Ahmed is the current CEO and registrar, very important. He provides of the Pharmacy and Poisons Board. He provides strategic leadership and oversight of the Pharmacy and Poisons Board, a very good regulator. Dr. Mohammed is a seasoned pharmacist and a regulatory leader with over 2 decades of experience in medicines, regulation, health system strengthening, and institutional leadership. Mohammed has a Master of Science in Pharmaceutical Science and Medicine Control from the University of Bradford in the UK. He's an expert in medicines regulation, regulatory systems, strengthening health systems, strengthening and regulatory harmonization. He enjoys walking and tree planting. Wow, very nice ecosystem. Yeah, so thank you very much. I think now, oh yes, my chairs are all full now. We will now go to the questions. The plan is that I ask a few questions. They answer. If you are satisfied, fine. If you're not, then you make sure you ask them why Kenya does not have its own manufacturing optimally. Yes, we do manufacturing, but is that all we can do? Can we do more for our own resilience? So it's very, very important, and they are all experts in their own rights. So it looks like the questions will not be according to how you sit. I hope to have been given mics. Oh yes, Professor has it. Oh, you knew you'll be the first one. So Professor George Joroge from Kemri, on behalf of Kenyans, I'm going to pose 2 questions to you. Then you answer them exhaustively, and then we proceed to the next. So Kenya invests in health research. We do invest. Why do many promising innovations take so long to reach patients, and what needs to change? Number 2, Kemri has been at the forefront of health research in Kenya for many years. How are you ensuring that research moves beyond the laboratories and becomes medicines, diagnostics, vaccines, and technologies that actually improve the life of wananchi? So when do we stop researching and bring these goodies home? Professor.
Thank you, moderator, for those questions, those 2 questions. And thank you for the introduction. Sorry for my CV. I should have truncated it. And those questions are very important. I've been in research for the last 40 years, having 2 medicines, 2 drugs in the market, one in hepatitis C another one in progeria, and another one in cancer. As you heard, I worked for Eli Lilly, as well as Mark Sharp and Dome. I'm very glad to hear about that question because that's where we want to be now. Why is it taking so long to get these products into the market? My first drug that went to the market in 2001, I can tell you it took 15 years and $1 billion to get that drug to the market. Why did it take so long? It took so long because the process of drug discovery, especially for novel modalities, you have to start light from the enzyme, from the test tube. You go to the animals and you start with the mice if it's a cancer drug, mice, guinea pig, then human beings, phase 1, phase 2, phase 3. Phase 1 is basically for safety and also seeing that the product is bioavailable. Phase 2 is a large number of people whereby you now need to show some efficacy, but still show some safety. And then phase 3 is where this is where you have randomized clinical trials, double-blind clinical trials. That process for novel modalities, you cannot shortchange, no shortcut. You have to go through that process. And that's why it takes so long. And then we heard about our regulatory authorities. They have to take care of those to make sure every step is clear and well documented. That's why it is taking so long. The other question that you've just asked is, how can we shorten this process? The good thing, there is an answer now. And many pharmaceutical companies are embracing this. We now have AI, machine learning. And Kenya is in a very good position because we have very talented, competent young people in our universities. They can embrace AI and other machine learning processes. We can now cut down that process and get to the marketplace faster. We also, as you said, KEMRI is very, very advanced in looking at traditional medicine. And this is very, very important because some of those medicines, they've been in biological, in humans and animals, and we know their safety profiles. So we might have to cut down on the amount of time it takes to get these products from the lab to the humans. And KEMRI is doing a wonderful job. You've seen the kind of things, the kits, malaria kits. You've seen the Rift Valley fever kits. And also you've seen bilharzia kits. Several kits are coming from KEMRI because it's adopting a very important strategy. Going to the market, going to the people, helping them. Before, it was very expensive to do things like HIV, Hep C, Hep B analysis. Now they have kits that could address those problems. And before I finish, more important is now science is going into what we call genetic enabling. We are going to what we call precision medicine. In future, you are not going to be given a chemo without knowing your biological profile, your genetic profile. And we are doing a lot of genome work in KEMRI. You know, we are also doing the DNA work on paternal and maternal evaluations. But in terms of medicine, we're gonna go into precision medicine whereby your genetic profile is gonna be taken into account and decide what medicine you're gonna take. It's not just a general chemo. So my feeling is we are on the right track. We have the talents that can do that. We are getting the right equipment to do that. And more importantly, and this is what I'm going to finish with, is in the vaccine area. We need to do the research in our own people. A lot of drugs like we discovered were from the Western world. And most of the clinical trials were done on Caucasians. We need now to really validate that research in our country. And KEMRI has done that with Gardasil. That's for HPV. This is a drug that was produced by my former company, Mark Sharp and Dome. They always indicated that people should have 2 or 3 doses. One, that would be very expensive. But KEMRI was able to find that you don't need 2, 3 doses. And you saw a video here. 1 dose is good enough. And that saves you money and also compliance. For compliance purposes, people now can comply. So there are a lot of things we can do now to move this country forward using the science that is already there and the competency that our people have available to them. Thank you so much.
Thank you. Thank you. Thank you, Prof. Yeah, hello. Yeah, I hope it is on. Yeah, so thank you very much, Prof. The promise of cutting the long processes so that we get the products is there. So now we are going to the Federation of Kenya Pharmaceutical Manufacturers. Dr. Odhiambo, this is yours. What will it take for Kenya to develop and manufacture more of the medicines, diagnostics, and other health products we need locally? And many Kenyans here, they buy Kenya, build Kenya, very nice slogan. But the biggest concern is the price of medicines, and believe that imported medicines are of better quality than the locally manufactured ones. How will manufacturing more medicines here in Kenya make treatment more affordable for the Mwananchi? And what assurances can you give on the quality and safety of the locally manufactured medicines?
Thank you so much. It's good to have this conversation, and I look at it from first key piece is what would it take to get Kenya to manufacture most of the medicines that we need as a country, but as we need as people within this ecosystem. One of the key things that I would say from the Ministry of Health, you see there's a diagnostic report that looked at the capacity. Currently, we talk about 30%, but when you look at it in terms of the essential medical products and technologies that are being used in the country, our local manufacturers produce, I would say, up to 40% of them, which means there's already substantial number of those products that are being produced. The question would be, do we still complement them with imports? Definitely there is. And how do we then move from the current 30% in statistical value, but over 40% in terms of actual items and products that are being manufactured? This comes from first understanding, where does that ecosystem lie? For people to produce more products, we need investments, and those investments must be able to actually harness the returns that they expect. When the cost of production is as high as it can be, that becomes a problem. And most of it comes from a tax policy perspective. And I think we need an enabling policy environment. And my example will come from most recent and the most current challenge that actually the industry is currently contending with is the Finance Act 2026 that was passed. And from the Finance Act, pharmaceutical products, raw materials, inputs, and packaging were reclassified from 0 rated to exempt. That process took 1.5 months to be approved from the Ministry of Health and the National Treasury. But now operationally, the nuances are still coming in where, how do we then get it to be applied for the exemptions? Every single consignment, that becomes an operational nightmare. So I think policy inconsistency, but also the implementation operational hurdles that need to be addressed from an impact standpoint, that is an opportunity to unlock value. The other piece is the ongoing engagement, and I would say from the Directorate of Health Products and Technology, there's been a lot of engagements with industry and trying to see how do we ensure that we move from where we are to the next frontier. And I would say it's a matter of now asking ourselves, there are policies in place. We have the health products local manufacturing strategy that was rolled out. How do we make it work for the industry to actually enable them to produce more? That would be key. The local industry have gone to the level of having these, I would say, technology transfer agreements and partnerships. And I know Wesley is talking about it from BioVax, whatever they're doing. These collaborative engagements is going to ensure that we're able to produce more advanced technologies, more advanced products, but it is by facilitating those partnerships that we're able to move to the next level. The third thing, if you're producing a product and nobody's buying it, nobody's using it, there's no need to produce it. How do we guarantee our local manufacturers have a sustainable and a reliable market in the country? The government is the highest and the greatest purchaser of health products and technologies, and it is a government mandate to guarantee every Kenyan has access to safe, effective, and quality health products, but also access to healthcare generally. That means if our greatest purchaser of health products is the government through KEMSA, how do we make KEMSA buy more from local manufacturers and beyond buying, being able to pay for those products so that we have an enabling ecosystem that is actually complementary and supportive? Those are key things that we need to be able to guarantee. At the moment, there are still lapses and we're hoping that we can make the best move as we move to the next frontier. When we go to the other piece, the other question was that consumption, and I would link it to actually my last point is, Kenyans would be asking access, affordability, and quality. And that is a critical conversation that every Kenyan has to have. But when we look at it in terms of access, what comes into the cost of products is the cost of raw materials, cost of manufacturing, and the cost of logistics. When we're manufacturing them locally, I don't have to ship it from India, which means that cost is already reduced in most of cases. So that is a cost that we can offset. But the question is, can I produce at scale to be able to compete with an Indian or a Chinese manufacturer that is supplying 196 countries all over the world? So that becomes our competitive advantage. And I would say locally manufactured, we have that de-risking capability, but also an access when you have disruption that what we had with COVID-19. Now we can be guaranteed that all our 36 local manufacturers are able to supply what we need at that moment when nobody else is selling. That could be an opportunity for us. And I would look at that as an enabler of access, but also the cost reduction that we come in when we have an enabling ecosystem where the tax policies are favorable, the cost of production is lower, we're able to produce it. The last piece in quality, and this is a conversation that I would say from my engagement and work within the industry, most of our local manufacturers meet the highest standards of quality standard because some of them are already WHO pre-qualified. Some of them are being audited. Some of them have made the certifications in terms of the EUCE. For example, Revital, where you talked about Universal, TASA is under WHO pre-qualification. So they already meet the standards. Beyond that, we have our regulator here. With advances in regulatory oversight, there are improvements in good manufacturing practice standards, which is a compliance requirement to guarantee that whatever is leaving my company today is of the highest possible quality and is worthy of human consumption. The question is, are we communicating this enough to the public? Because when the people don't know about it, there's no way they can trust what is coming into them. And that is the opportunity that we have as an industry to communicate the investment, to communicate the value that we're bringing in, but also to communicate quality measures and what the regulatory oversight mechanisms are in place. Because if we're able to do that and demonstrate it continuously, we build confidence, consumers are taking our products, the government will be buying more of it, and that is the next frontier of where we're moving it. And I'm sure the regulator will talk about some of the other advances, but the key is quality is paramount, access is an enabler, and affordability becomes the last piece where we guarantee that everybody of the 55 million Kenyans can have the products they need. Thank you.
Thank you very much, Daktari. Well put. So we need to make all sides of the coin workable. The access, the government should protect in terms of buying. You may make and then you don't have the buyers. So thank you very much. Now we are going to Dr. Wesley of Biovax. So my two quick questions on behalf of our people seated here. One, why is it important for Kenya to manufacture vaccines and other biological medicines locally when these products can already be purchased from other countries? And what difference will local manufacturing make to access, affordability, and security of supply? Number two, Kenya has really invested in institutions, laboratories, and vaccine manufacturing infrastructure. When should Kenyans expect to start seeing tangible benefits from these heavy investments?
Thank you very much, Chair, Moderator, for your question. In terms of why should Kenya produce vaccines at this point in time,
I would say that 4 years ago, before COVID, it was not only Kenya, but the whole continent that would ask this question and say, do we really need to produce vaccines? But the last 4 years has shown us that we may need, that it is necessary as a country, and as a country, Kenya, and as a continent, that we need to build capacity to produce vaccines. So before COVID, we had what you'd call healthy markets. So in terms of vaccines, healthy markets. So we have the buyers, Gavi, UNICEF, and others, sourcing from the cheapest source, which is outside the continent, India in most cases, long-term supply contracts, negotiated prices. The supply chains were apparently functioning very well, and most of the countries within the continent were receiving vaccines and probably subsidized by Gavi and others. So that was all good and nice, but along came COVID, and therefore the supply chains were broken, and we were faced with the challenge of not having a vaccine to deal with a pandemic that was upon us. So that changed the whole architecture of vaccine manufacturing globally, and the move towards regionalized vaccine manufacturing, so that you have dispersed nodes and manufacturing sites globally. So Kenya is one of those countries that has taken a step in terms of putting in place necessary measures to produce vaccines. It's important that we produce these vaccines, not relying on outside based on those lessons, but there are also other things that are coming along in terms of financing, uncertainty in financing, the buying mechanisms that were there, it's unraveling, and other supply chain shocks that keep coming. So it's important as a country that we build that capacity to produce vaccines for health security. Number two is that as we build the capacity to produce vaccines, we also begin to have the know-how to produce adjacent products, biologics. We are talking about monoclonal antibodies, the insulins, and even as we move towards what Prof is talking about there, precision medicines and all that. So it gives us that capacity to begin to produce these products and not rely on imports. I think the professor also talked about being able to develop our own products that responds to our own unique needs and genetic makeup. So all this is imperative for us to then produce these vaccines and biologics within the country. Secondly, is that as compared to other countries, we have a strong manufacturing base in terms, although we have not been able to, to produce vaccines. So building on those capacities that we have, then we are able to do that. There was a question of what benefits do we get from there. We are then able to build capacity in terms of knowledge and the know-how as we go through this journey. Then there is a question that you have asked about the investments. When do we begin to, as a country, when do we begin to reap, benefits from these investments? So when you go to vaccine production and vaccine production, there are 4 things that need to be in place and needs to be orchestrated so that you are then able to have a successful vaccines business. So one, of course, is technology, having the right technology, having the right finance, having the right skills mix, and then the last one, most important, is market. So if you produce vaccines, who buys these products? So the question then is, what is going on now is we are putting all these 4 pieces together towards what we'll be producing. So the question of when do we begin to actually benefit from these
is that we are actually beginning to benefit from that even as we speak at the moment. As we are building the skills that we require to produce vaccines, as BioVax, we are doing that. And as we build these skills, we also begin to gain knowledge in terms of production of other related products around biologics. Issues around tech transfer is not an easy thing. So even as we go along these processes, we're also beginning to build capacity as a country to do tech transfers, be a recipient of tech transfer, and build that capacity. So already these capacities are ongoing, even as we build the skills. The other thing is about the market. So Kenya is among those few countries, even as we invest on these vaccines, who is among the few countries in Africa who has actually, our Ministry of Health has signed an advanced purchase agreement with BioVax to say that as we produce these vaccines, there is an off-take arrangement that will be in place. And this gives us the confidence to continue investing, although we know that even if they take from us, it will not be at the scale that will keep us sustainable. But then it gives an assurance so that even as we look at other markets. So as I conclude, Chair, in terms of getting the full benefits, the full benefits here in this particular case is Kenyans seeing a product in the market being delivered to the patient. So we are still on that journey, and towards mid-2028, we then expect to have commercial purchase of the products that we are focusing on. Thank you very much.
Thank you, Dr. Thank you very much. Now we go to the regulator, the Pharmacy and Poisons Board. Anything manufactured or imported must be regulated. So, Dr. Ahmed, many Kenyans still worry about fake medicines. What has changed? And how can the public be confident that the medicines they buy today are safe? Many people, second question, many people think pharmacists only dispense medicines. How are PPB's reforms helping pharmacists improve healthcare for ordinary Kenyans?
Thank you. I think pharmaceutical business or pharmaceutical, it's like any other sector. There are criminals, there are crooks who always look for a chance to make quick money. As a result of this, this is not an issue which only touches Kenya. It's a global issue. Even well-resourced regulatory authorities are battling this case. In Kenya, the biggest challenge we had when it comes to fake medicine, or what I will call falsified and substandard medicine, is one, the porous borders, two, the Farmers and the Poisons Board was understaffed. Then there are issues of ports of interest whereby people walk into the country with briefcases containing full medication or falsified and substandard medications. And yes, this is a problem. We cannot run away from it. But what we are doing currently is to ensure that the first thing is to improve the controls at the ports of entries. What we have done is, since the last 2 years, all our ports of entries are manned by the staff of the Farmers and Poisons Board. There are regular inspections going around to verify what is in the market is of accepted quality. And we have introduced what we call mini labs, gadgets which are with our surveillance department This gadget will give you an instant result within 2 to 3 minutes, and it determines whether the product which is being sold in the pharmacy is genuine or falsified. And however, the biggest issue we have is the perception, the people perceptions. And what I mean by people perceptions is we educate Kenyans, but I think the truth is, and people don't want to follow the laws. And people prefer buying from unregistered places because that is cheap for them. So they prefer buying from unregulated or illegal premises for their medication. And this is costly. You can buy, if you buy a fake fertilizer, the result you will get is maybe a failure in crops. But when you buy falsified medicine, then basically the risk is too high. One life lost is too high. And on the issue of the pharmacy practice, I think the truth is that pharmacy profession in most cases have become business oriented. And it has been converted into a kind of nipe nukupe kind of over the count. And this is now what we have started, now what we have introduced is what is called good pharmacy practice. And this basically will standardize the pharmacy practice in Kenya, and they will not be limited only to dispensing. There are other pharmaceutical care they will be giving, including advising the patient. We want to remove the concept that you just walk into a pharmacy, buy prescriptions, and you walk away. We want the patient to take time, understand that this is a drug, it can kill. And when you go to when you are consulting the pharmacist or a pharmaceutical personnel, the pharmacist should be able to explain to you how these products are used. Because some of these products, they're very well known that they cause drug-food interaction or drug-drug interaction, which sometimes can be fatal. So this is what we are telling them. Take time with your patient, advise them on the pharmaceutical care, and if there's issues of incidents of adverse effects, they should report to you. And that report should be forwarded to the Pharmacy and Poisons Board to make policies on what to remove from the market and what to retain. So basically, we want the pharmaceutical care to be a patient-oriented rather than a business-oriented in profession. Thank you.
Thank you, Daktari. I think we feel safe now that whatever we take in or get injected are quite regulated, including the professionals handling. So thank you very much. Now, finally, we are going to talk to Dr. Gerald Macharia, who we know as the former Kenya Country Director and Vice President, Eastern Central Africa of CHAI, the Clinton Health Access Initiative. So, number one, Daktari, you have seen it. You have seen health systems across Africa and globally. From your experience, what can Kenya do differently to make sure every mwananchi can consistently access the medicines and health products they need at a price they can afford? Number two, we are investing in manufacturing more medicines here in Kenya. from your experience, what must we get right so that local manufacturing actually results in more affordable medicines for the mwananchi and not simply more and more factories? Thank you, Dr. Ari.
Thank you, Dr. Ako, and good afternoon. Your first question is an interesting question because there is no manufacturer who produces medicine to keep in the warehouse. You manufacture to sell. And if you're given an opportunity to sell that medicine straight off the production line, it is likely that you will have a very optimal pricing structure because you're not carrying inventory costs, you're turning over your raw materials and your input costs in an optimal way. The problem is that manufacturers in Kenya manufacture for an undefined and unknown market. You sometimes manufacture against hope. But if you're given an opportunity to say that this batch that I'm producing is for this specific customer for the next 2 years, then price will not be an issue. The problem is that uncertainty and that inefficiency that comes out of sporadic orders and undefined market demand. The easiest thing to do is to park it behind the price. So you take the inefficiency, you take the market uncertainty, and you take the taxes and you put everything in the price. So if we fixed all that, price is not an issue because it means that if you're assured of a batch running off your line and going away completely, it means that you're optimizing the entire value chain from the source of raw materials, from the API, from the production materials, from the production line efficiency itself, from your energy costs. You're optimizing all that. So the price will be optimal. But as long as that market uncertainty stays, and as long as those inefficiencies are built into the way we make medicines, the price will always be somewhere up there and will always be running up against very efficient people who have conquered that particular mountain. Now, on your second question on is it more factories or better access, the problem is not the factories. In this region in East Africa, we have the highest number of manufacturers in each country, like about 40 or so. But for a market that imports 70% of its medicines, 40 is a small number. If we just decided to say no more factories, but we're going to push local procurement from 30% to 50%, all those 40 manufacturers will be very, very, very efficient. The problem we have is that the 40 of them can only be guaranteed that 30% of that market. So half the time they are running very inefficient production lines. And the moment you have, a sporadic production process, and schedule, inevitably you will run the medicine that you can sell quickly, not the one that is needed, and if that is the way you're operating, it doesn't matter whether your factory is big or small, you're still inefficient because of the way the market is. So anybody building a new factory now would probably be more innovating on new production methods, not necessarily building a new factory. The factories that we have now, and the PPP boss is here, if we go to ML3, where we are headed, we'll shut down half the factories we have in this country because half of them will not qualify, will not reach that ML3 level. So I think the issue is more what kind of factories do we have, not whether we should have more or less. And that will continue as long as those uncertainties are there and are in place. Thank you.
Thank you very much, Dr. You've heard we have enough infrastructure. The problem is the inefficiencies, which because we are inefficient in many, many ways, we now lump that into the price. So you've heard it all. Now I want to give you guys opportunity. We were asking questions just to tease out a few things here and there. I'm sure there are many things which the people in the preliminary can give us ideas on how else we can fix things. So I'm here to take questions, and people helping me to move with the mic around. Yeah, you can have the mics. A question that will help us. I don't want any speeches. Yeah, quickly, by show of hand. By show of hand. Yes, there's a question there. So introduce yourself. Where from? The lady behind first. Because, yeah, introduce yourself. Oh, Wanjala, Sema. Oh, she's
as we sort out the technical issue, very good afternoon. My name is Dr. Robert Karanja. Can you hear me? Good?
Sorry?
Can you hear me well?
Yeah, now we can hear you.
Yeah, so my name is Dr. Robert Karanja, Executive Director at BioLinks Africa. We are a tech startup, enabler and investor. So my big question is primarily to Dr. Wesley Rono. We know that, of course, speaking to Kenya's health security is significant, and I'm excited to hear the AMC commitment from the government of Kenya. But we know that cannot be sufficient really to warrant that investment. So is there also a regional AMC or a regional play to actually make it financially feasible in terms of export?
I know Dr. Rono has heard me, I did not hear. But okay, the next, Wanjala, what happened to you?
Sorry, my mic was not working. My name is Dr. Cecilia Wanjala from Kenya Biovaccine Institute. My question is to Dr. Gerald about the market insecurity. We have heard from Dr. Rono that for vaccines, he has managed to get advanced market commitment from the Ministry of Health. How do you think we could address that issue for the essential medicines? I would like you to comment on it, and even as you speak to it, maybe also about the time between the supplies and the payment to the local manufacturers. Thank you.
Thank you, Dr. Two more last ones, then we wrap it up. There is a lady at the back. I'll keep calling people lady and gentlemen, don't worry.
Good afternoon, everyone. Can you hear me? My name is Ella Obonyo. I currently work at the Ministry of Health. So I have two questions. One, that there have been 43 recalls in 2025 alone. So why is the rate so high? And what are you doing to prevent the distribution and sale of such products prior to them entering the market? Secondly, as you project the workforce needs to produce and manufacture within the country, how are you encouraging Kenyan citizens, and in particular the youth, to pursue careers in research, in medical research and in product development, so that we can ensure that we have a sustainable and sufficient workforce to develop the products and technologies we desire to see in the country? Thank you.
Now, the people helping us with the mics, we are not, who are they? Where are the technicians? We are not hearing anything. Personally, me, I did not hear any of the questions. So I don't know, my panelists, are you comfortable? Are you hearing the questions? Partly. Okay. Rono?
Let me try. Can you hear me now?
Oh, yes, good.
Great. My name is Dr. Josiah Rono. I'm CEO at TNK Consulting Firm, which is a strategy advisory firm. My question is to PPB CEO around the regulation and the harmonization across the continent. I think listening to the partners, to the panelists, it's clear that we need a big market to be competitive. And I think there's been a lot of effort to harmonize regulation on the continent. We are not at 100%. It'd be great to hear what can we do as Kenya or PPB as regulators here to, drive for, greater harmonization across the continent with our peer, national drug authorities. Thanks.
Thank you. Bas, that's it. Instead, yeah. So thank you. You have a question? Okay, go for it.
Yes, good evening. Robert Ogada, the founder of Care Medical Professional Association. So I have two questions to the CEO of Pharmacy and Poisons Board. My first question touches on access and affordability. So we know very well that the price affects the access of universal health coverage. So in terms of prices, we found that most of the essential medicines have varied prices. Let's say, for example, amoxicillin clavulanic acid. We find that from the imports, we have various prices from retailers and wholesalers. Can we set a regulatory authority, maybe called Pharmaceutical Price Regulatory Authority, that can come with the maximum retail price so that our people who are using the essential medicine can get medicine at affordable rate? My second question is on safety. Recently, Pharmacy and Poisons Board made crackdowns and arrests to the quacks. So can you give me the key performance indicators that the people who are arrested have been persecuted? And can you get the number on your website? Thank you very much.
Thank you very much. So I give, I think there are just two panelists who are asked questions. So we will give you just 2 minutes. It's already 5 o'clock. Then just have 2 minutes, and let's start with Dr. Wesley Rono.
Yeah, thank you very much. I think Robert asked me the question about the advance purchase agreement and whether this will make the business to be sustainable. So I think the key thing here is that what is important is that we have an advance purchase agreement from where we are located, the Ministry of Health Kenya. However, that will not even be enough to take up the capacity that we'll be producing. So it will almost be like probably 20% of what we can produce. So obviously, it's just an assurance, a local assurance for us. But for us to be sustainable, we'll have to look at beyond the Kenyan market. So there are initiatives, continental initiatives that are happening, and in terms of pool procurement, specifically looking at supporting African vaccine manufacturing in the continent, so that there is viability in the business, not only for what the BioVax, but also for other manufacturers in the continent who are being set up. So there is a continental initiative that is happening in terms of at policy level, but also there are initiatives with partners, Gavi, UNICEF, and others, to begin to look at their procurement systems and purchasing systems so that they are able to give some commitments to African manufacturers so long as they meet price and quality. So there has to be a mix of all those. Then there was a question about workforce. How do we interest young people in this direction of biomanufacturing and all that? As BioVax, even as we develop workforce, we look at the young people, and we are trying to establish platforms and hackathons towards areas around biotech, and we'll be working with others so that we create an interest. There's already an interest, but we want to be part of that the platforms that then encourage interest in these areas. Thank you.
Thank you, Daktari. The other one is Dr. Ahmed.
On the issue of harmonization of regulatory process across the country, across the continent, and what is going on is basically the first stage in every process, confidence building. And now we have the African Medicine Agency, which is coordinating the process of harmonization. However, one important thing we should know that harmonization process is a political issue. And unless that political issue, we have political solutions to this harmonization, then all these issues we're talking about harmonization is not, it will not be possible. For the East Africa community, what we have done is we harmonized all our documentations. That is the document which is used for registration in Tanzania, Kenya, Uganda, are all the same. So all the documentation is done, and as a shortcut measure, what we have done is registration process is going through the East Africa community, and the East Africa community, which has assigned Tanzania as the lead country. Once we have this, Tanzania notify us, and what we do a common evaluation. Once that product is evaluated, then it is registrable across the East Africa. On the issue of accessibility, price control, yes, it's a critical function. Actually, this is a critical function of for Farmers and Poisons Board. Basically, it is the quality, efficacy, and the safety of the drug. However, I'm a member of a committee which has been set up and is looking into the harmonization of the prices across in medicine. And on the number of, if the number of arrests and the number of people arrested in our crackdowns, if it's available on our website. At the moment, it's not available. But what we intend to do in the coming process is we have decided to be publishing our reports on our website, and it's the process of improving service delivery, so whereby we'll be accountable. But if you want it at the moment, I think we can provide you, but it's not available to the public at the moment. Thank you.
Thank you very much, Dr. Gerald Macharia.
Yeah, thank you. Thank you, Cecilia, for that question. My experience with advanced market commitments is they are good for a manufacturer who's looking for a return on investment. Very good. And same thing works with volume guarantees. They at least give you a chance to recover your production costs and give you some headway as far as working capital is concerned. But they don't make you efficient, and they don't necessarily guarantee you a future in your business. You still have to come back to the same market and compete with others. So as much as they are a leg up, they are not instruments that you want to continue using forever, because what you'll be doing is encouraging some degree of inefficiency and laziness. It is good to get the leg up, but have a limit as to how much you can use those market instruments to make the market work better. Ultimately, you must let the markets compete the way they should compete. And that's the only way you can get prices down, if the competition is as near perfect as possible. So yes, good instruments to use, but in a limited way and for a limited time. Thank you.
Thank you very much. So I think now maybe I want us to give a big round of applause to our eminent Kenyans. You've heard them. Asanteni sana. Nisaidieni kuwapigia makofi. Asanteni sana. Now we can get off the stage. Now, you know, everything, it's okay. Everything we do it for the government on behalf of the wananchi, the citizens. So it's actually the core mandate of the government to ensure that this happens. So now we are going to call in the government for the next 5 minutes, the director of the Directorate of Health Products and Technologies. We have had researchers, we have had, leaders, we've had many expert, eminent Kenyans. Now allow me to invite Dr. Nazila Ganatra, who will give us a 5-minute communique on what we have discussed. If what we have been saying made sense to the government, she will tell us. Thank you very much. As you applaud for me and Dr. Wesley Rono, you have something to say. Okay. Thank you very much. Bwana Chair, back to you.
Yes, he forgot to give it back to the chair.
Sorry. Let me officially give you back the chair, sorry.
So just before she comes in, I forgot to introduce Dr. Wako. So I'll just take 30 seconds because to give his profile. So because he's, first of all, to let you know that Dr. Wako was my classmate in high school, and then we went to college together. So that's a long time back. So he holds a bachelor's of medicine and surgery, and then a master's in public health. He is a distinguished public health physician and health systems leader with over two decades of experience in Kenya's health system. At KEMSA, he has led significant program of institutional transformation, and you heard it in the morning today about reduction from field rates, increasing the field rates to over 90%. So he has strengthened governance and operational systems. So he has championed innovative financing and strategic partnerships to strengthen the availability of health products and technologies while advancing KEMSA's finance and diversification. He has played a strategic role in Kenya's health systems transition under the Kenya-United States Health Cooperation Framework, supporting the strengthening of government-led procurement systems. A recipient of the Order of the Grand Warrior, Dr. Chesa brings together clinical expertise, public health leadership, and strategic management in advancing a resilient and sustainable health supply chain systems. Thank you very much. Now you know more about Dr. Wako. And thank you for your time as I was the chair. Thank you. Over to you.
Thank you so much, Chair and the moderator, Dr. Wako. So, good evening, everyone. I didn't see anyone introducing me, but with my bio. So, I guess I'll just make it a brief introduction. My name is Dr. Nazila Ganatra. I am the Director for Health Products and Technologies at the Ministry of Health, and found it very interesting to have this very lively and vibrant conversation. I know we are few, but the points were actually driven home. So as we close this session today, one message is very clear, that Kenya does not lack ideas, innovation, or ambition. What we need is how, or a push to implement what we have done. As we have discussed today, we have focused mainly on research and development. We have seen how KEMRI has transformed research into action. And we really need to ensure that we incorporate AI and also encourage our young brothers and sisters to be able to join into the research and development area. And we have also spoken about accelerating the regulatory excellence. And we have heard how Pharmacy and Poisons Board is working to ensure that quality and safety while creating an enabling environment for innovation and investment. And then we are also rooting and calling out for Build Kenya, Buy Kenya, which is going to translate our local manufacturing strategy into predictable demand, procurement commitments, and investments in Kenyan manufacturers. We did not speak a lot about strengthening the supply to the last mile, but I know that KEMSA is really working hand in hand with the Directorate and with DHA to ensure that we harness digital technology and data to enable us deliver and procure to the last mile. So finally, when we speak to the call to action, basically to the government, that is ourselves, is to create enabling policies, create demand for our commodities, and provide financing and improve conditions for implementations. To the counties, we encourage strengthening the last mile systems and create environments where innovation and manufacturing can thrive, such as the environment created by Kilifi County. To the industry, we encourage you to invest in manufacture and innovate in Kenya. To researchers and regulators, shorten the journey from discovery to the patient. And finally, to our partners, invest with us in sustainable Kenyan systems and not parallel solutions. The next chapter of Kenya's health products and technologies agenda must move from policy to products, from imports to increase local production, from fragmented systems to visibility, and from warehouses to the last mile. So as we live this today, let every Kenyan, wherever they live, must be able to access quality, safe, and affordable health products and technologies when they need them. The future of health security will not simply be imported, it will be researched, regulated, manufactured, and delivered right here in Kenya. The time for discussion is ending, and the time for delivery is now. Thank you so much. I wish all of you a lovely evening, and see you tomorrow, same place. Bye.
We received a number of equipments through the National Equipment Support Program, NESP, ranging from the imaging department, where we received a digital X-ray with fluoroscopy function. We received a 128 slice CT scan with various modalities. We received 3 ultrasound machines with echocardiography function. We appreciate what these machines have been able to do for our catchment population, ranging around 8 million.
Na hiyo mashini kama ingekuwa nje, ingekuwa gharama ingine tena kuenda tena kutafuta, lakini tunashukuru kwa sababu mashini imepatikana huku kwetu Samburu na imetusaidia.
So you find that patients who need CT scan services from far off places, they only need to be ferried by the ambulance to this facility.
Since the inception of this program of the equipments, we have seen an improvement in service delivery. Want to confirm that the services are now efficient and safe. We have reduced the waiting time of patients.
Sasa ndio hapa Kisii venye hiyo ndio wametuwekea karibu, inatusaidia kabla ya kwenda mbali Western Transport ama masaa ya mgonjwa. After nilifanyiwa operation nilirudi sawa, sasa ninasikia sawa, sina shida ingine sana, niko sawa.
Health is a right, and a right must be delivered, from the idea to the proof, to the shelf, and to the patient. This is the journey of Kenya's health products and technologies. It starts with a question that leads to research in search of answers.
We were able to show that one dose is enough, just one shot. The World Health Organization took this data, and late last year, they changed their recommendations to 1 or 2 doses for ages 9 to 20.
That's one lab, one disease. Across the country, other researchers are chasing different threats.
Now, KIPLE is Kenya Institute of Primate Research. This is Biomedical Research Institute that has a mandate of improving human health by ethically utilizing non-human primates. In this country, over 20,000 Kenyans are bitten by snakes. And we have about 8,000 who suffer permanent disfiguration. Now, currently, all the antivenoms that are being used, because when you're unlucky to be bitten by a snake, what you are administered with to manage that is called an antivenom. Now, currently, all the antivenoms that are being used in the market are either from Europe or in India. So what we want to do is to use our own venoms here from our snakes and improve the efficacy rates.
But an idea alone doesn't protect a patient. Before it reaches them, it must be proven safe. Across Kenya, 57 million people trust that behind every medicine is a question already answered. Is it safe? The Pharmacy and Poisons Board regulates the professionals, the premises, and the products. Over 15,000 licensed pharmaceutical professionals and more than 11,000 licensed premises nationwide. Through market surveillance and pharmacovigilance, 1,413 quality complaints are reviewed. 99 products are recalled. Over 32,000 adverse drug reaction reports assessed. New systems like Track and Trace and Practice 360 are following every product from source to patient. None of this works without somewhere to actually test the products.
So one of the things that we are doing as a country in Kenya is to ensure that these medicines, the ones that we import and even the ones that are manufactured in country, are tested for quality. And that is what the National Quality Control Laboratory does. So we are expecting that within the next 1 year or so, or shortly after, we should be able to have a lab that can now meet the standards of that demand of being able to produce vaccines and biologics and other things.
Regulation builds trust, but trust needs supply, and that supply must be made at home. During COVID-19, Kenya learned a hard lesson. The countries that survived were the ones who could make their own medicine. COVID-19 exposed a hard truth. The countries that could provide their own medicines were the ones best placed to respond.
So Kenya Biovax has been given this mandate to lead in terms of producing vaccines and biologics. Our target is to produce vaccines that are safe and of quality, of international standards, especially for childhood immunization. The vaccines that we produce at Biovax is not only for Kenya, but it will also serve the continent.
Manufacturing is only half the story. The vaccine still has to get to the end user. 24 hours a day, 7 days a week. KEMSA keeps Kenya's health supply chain moving. Over 90,000 square feet of warehousing. Every product tracked. Every shipment secured with geographic information system enabled logs and digital proof of delivery. from Nairobi to regional depots to every one of Kenya's 47 counties, bringing essential health products closer to the people who need them. It's not just medicines that need to reach communities. Specialized care does too. That's the work of the National Equipment Service Program NESP, taking specialized medical equipment and services out of major referral hospitals and into county and lower level facilities. Every machine installed, maintained, and kept running with vendors paid only for the services they deliver. The goal? Decentralized specialized care like radiology, surgery, and dialysis, so patients can access it closer home. Research that asks the right questions, regulations that protect every dose, manufacturing that builds self-reliance, delivery that reaches every county. This is how Kenya is reforming health products and technologies, one link in the chain at a time.